Good morning, one and all. So we'll start with our IAS1 program, knee arthroscopy schedule. So I welcome you all for this CME. Hope you all have a good learning opportunity and a good CME. So first we'll start with the knee arthroscopic and knee anatomy and basic arthroscopy sessions. So for that, I'd like to call Dr. Terence and Dr. Narendran to chair this session.
Very good morning to all of you. Me and Narendran here will be chairing the session. So to start with, we have knee anatomy and basic arthroscopy. The first talk by Dr. Maulidharan on knee anatomy for the arthroscopy surgeon.
A very good morning to everyone. I kindly thank IAS1 for giving me this opportunity. Let's start with the session. It's very difficult to speak complete knee anatomy within a short period of time. I have made it more of a clinical anatomy. Let's get into the topic. Knee as such a joint, as arthroscopic surgeons, we deal it with delicacy comparing to an organ. So it comprises of osseous, extraarticular structures and intra-articular structures which function like a symphony in an orchestra. Coming to the osseous structures, it simply can be called as hinge joint, but it's not true. It is more of rotatory components with the distal, femoral and lateral condyles having a different shape, which comes into articulation at various articulating points, which we know as a screw home mechanism. Coming to the articular surface, the medial surface is like a wheel running on a flat surface, whereas a lateral surface, it's a wheel running on a dome. So the ligaments acts as a constant to provide a congruent motion. Coming to the extra-articular tendinous structures, it comprises of synovium, capsular structures, collateral ligaments, and muscular tendinous units comprising of gastrocnemius, quadriceps mechanism, hamstring, popliteus, and IT band. Coming to the quadriceps tendon, which is the anterior-most structure, which is gaining importance in recent days because we more harvest central quadriceps tendon for ligament reconstruction. It comprises of 4 components with 6 layers. Our main concentration on the first 2 layers. So we see in this cross section, when we move from lateral to the medial, the rectus femoris is the most lateral and midline structure, which is separated from the deep layer by a fatty layer, fatty tissue. It gets adhesions only at about 4.5 centimeter from the superior pole of patella. So our superior thickness quadriceps graft, which comprises of rectus femoris, whereas a deep CQT graft, which includes a superficial and deep intermediate layer. Coming to the medial side of knee, it constitutes the superficial and deep MCL, posterior oblique ligament, and the arms of semimembranosus tendon, and the medial patellofemoral ligament. Coming to the medial collateral ligament, it comprises of superficial, deep, and posterior oblique component, in which the superficial MCL has a femoral attachment just posterior and proximal to the medial epicondyle, and it has 2 tibial attachments, one just closer to the joint line, posteromedial aspect, just 1.2 centimeter below the joint line. Another attachment that is 6 centimeter from the joint line, which is the posteromedial crest. Coming to deep MCL, as per anatomical structure, it cannot be separately delineated. It can be seen as a separate structure from the anterior aspect, but coming to the posterior aspect, it blends with arms of semimembranosus and also with the posterior oblique ligament. Coming to the posterior oblique ligament, it has 3 arms like superficial, central, and capsular, whereas central is the thickest portion, which we reconstruct regularly. It has a femoral attachment posterior to the tubercle, which is called as an adductor tubercle, and its tibial attachment is in the posteromedial crest. Coming to the medial patellofemoral ligament, it is a distinct structure, which is a main stabilizer of the patella on the medial side. It has a fan-shaped origin from the supromedial part of the patella and gets inserted into the triangular area between the 3 tubercles, that is the medial epicondyle, adductor tubercle, and the gastrocnemius tubercle. Since we do many of our MPFL, femoral tunnel is done as a blind tunnel using a CM control. We take the shortest point as an anatomical landmark, which is formed by the cross section of the posterior femoral cortex line and the posterior femoral condyle line. Coming to the posterolateral corner of the knee, which is the main primary stabilizer of the rotation and the varus strain. The primary stabilizers are fibular collateral ligament, popliteofibular ligament. Secondary stabilizers constitutes the musculotendinous units. Coming to the fibulocollateral ligament, it's a straight ligament originating from the lateral epicondyle just proximal and posterior and gets attached to the fibular head. In extension, it is a prime varus stabilizer, whereas in flexion, it aids in stability under IT band, popliteus and biceps femoris. Coming to the popliteus, it is the only intra-articular ligament which can be seen when we do a diagnostic arthroscopy, either behind the lateral meniscus or also into the lateral gutter in the popliteal hiatus. It has three origins, like tripartite origin. It originates from the posterior aspect of tibia and also shares fibers from the lateral meniscus, posterior horn, and also gets origin from the fibular head and attaches to the femoral condyle, just 18.5 mm anterior and inferior to the LCL attachment. The important point here to note is the popliteus tendon always runs beneath the lateral collateral ligament, so which we have to keep in mind while reconstructing the popliteus tendon. Coming to the anterolateral ligament, there are nearly 20 anatomical studies discussing about the origin insertion of the anterolateral ligament, but most of the studies come to a conclusion that it originates from posterior and proximal to the lateral collateral ligament and runs anteriorly and gets attached in the midway between the Jerdis tubercle and the tibiofibular articulation. It has a thickness of around 7 mm and it provides anterolateral rotative stability both in 30 degree and 90 degree flexion, which is the basics of our ALL reconstruction, which is getting popular recently. Coming to the menisci, as we all know, medial meniscus is larger than the lateral meniscus, but lateral meniscus is thicker in its body portion, whereas medial meniscus is less mobile than lateral meniscus, because lateral meniscus has some of the ligaments to save it from the injury, like popliteus, and meniscofemoral ligaments like ligament of Risberg and Humbry. Coming to the fibers arrangement of meniscus, it has three various fiber arrangements like circumferential, radial and perforating fibers. Together, along with the attachment to the bone using anterior and posterior roots and meniscocapsular attachment, it forms a hoop stress like a hoop around a oak barrel. If a hook gets torn at any one end, like a root tear or complete radial tear, the complete tension of the meniscus is gone and it moves faster towards the joint force. Coming to the vascular anatomy of menisci, as we all know, the perforating capillary vessels, meniscocapillary vessels, perforate from the capsule on the periphery. Because based on the vascular zone, we divide it into red-white and white-white zone. Comparing the medial and lateral meniscus vascular anatomy, the anterior and posterior root areas are rich vascular along with the body area. There is a small point on the posterior horn of lateral meniscus, which is the site of popliteus tendon, which is hypovascular. So tears in this zone have a poor prognosis. Surprising to know, the lateral meniscus is in great friendship with the femoral condyle during rotation. Usually the meniscus follows the flexion extension along the tibia, whereas in femur it follows rotation. Meniscus has an additional role like tibial translation, rotational stability, which is the origin of the ramp lesions. The cruciates and the collaterals, they also act synergistic, but also as antagonists during the rotatory movements. Coming to the anterocruciate ligament, it has two bundles like anteromedial and posterolateral bundles, which prevents the anti-translation in flexion and extension respectively. Coming to the femoral insertion, it inserts as posterior on the middle part of the lateral femoral condyle, and its origin is just below the lateral intercondylar ridge, which is reproducible arthroscopically. Tibial insertion is a duck foot insertion, just 9 mm posterior to the intermeniscal ligament and 7 mm anterior to the PCL. It lies between the two intertubercular eminences. This is the intra-arthroscopic landmark that is 8 mm from the posterior femoral cortex and just medial to the anterior horn of lateral meniscus. Coming to the posterior glossal ligament, the largest intra-articular ligament, the two bundles which are inseparable anatomically, it has anterolateral and posteromedial bundle. Coming to the femoral attachment, it has a huge femoral attachment connecting all the 3 points like trochlear point, medial arch point and the posterior and medial intercondylar ridge. Its tibial attachment is in the posterior PCL facet between the two tibial eminences posteriorly, just above the champagne glass drop. These are intra-arthroscopic pictures to make the anatomical reconstruction of the PCL, where we can see the PCL facet and the champagne glass drop with many fibers from the medial meniscus. Coming to the vascular anatomy of the knee, there are superior and inferior medial and lateral genicular vessels, which are in great adjunction during the osteotomy procedures. The superior lateral genicular artery, which is 5 to 6 centimeters from the lateral joint line, which is in high risk during the distal femoral osteotomy, whereas the popliteal vessels during the high tibial osteotomy, which is in close relation when we make our osteotomy superior. So the magic number here is 3 to 3.5 centimeter below the joint line. Even when the saw oscillates, the popliteal vessel is in safe zone. Coming to the medial genicular vessels, while doing the high tibial osteotomy, it lies 3 to 3.5 centimeter from the medial joint line. Coming to the popliteal vessel relation to the meniscus repair, popliteal vessel just lateral to the midline, just back behind the posterior horn of lateral meniscus and the posterior root of the lateral meniscus. Coming to the nerves around the knee, the most important nerve which gets damaged usually in the hamstring graft harvest is infraorbital branch of saphenous nerve because of its varied anatomy, which can be avoided by keeping the knee in flexion with blunt dissection and identifying the structures. Coming to the common peroneal nerve, which is the structure runs just posterior to the biceps femoris from the fibrous tunnel and attaches using fibrous bands to the fibular neck, which is of great risk during the LCL reconstruction and the postlateral corner reconstruction, which can be avoided by identifying and isolating the fibular nerve, common peroneal nerve, and also by keeping the knee in flexion, which pushes behind the common peroneal nerve. So take-home message is, be clear in the anatomy. As arthroscopic surgeons, we deal in millimeters, so we have to be very clear. An anatomical reconstruction is the knee. Posterior knee, still a darker area, so we need to get to the areas where to work and also where not to work. So when the question, the why is clear, the how will be very easy. Thank you.
And thank you for the great talk, Dr. Maulidaran. I'd like the speakers to be on time so that we can be on time with the live surgeries and finish the program on time. But speakers, please note to be on time.
So questions we'll discuss after the session. Yeah. So I request Dr. Santosh Anand sir to give us talk on his live clinical examination of the knee.
Yeah, thank you. But
Thanks.
we need to.
Yeah.
ಇಲ್ಲ ಇಲ್ಲ இந்த பக்கம் வச்சுக்கிறியா இல்லை நீங்கள் இங்கேருந்து பார்த்தா கொஞ்சம் மூவ் அப் இந்த ஏரியாவுக்கு ஃபோக்கஸ் பண்ணலாம் சரி எந்த கால் சொன்னால் இந்த காலா ஸோ அப்போ நான் அங்கே இருக்கேன் நீங்கள் இந்த பக்கம் கட்டுங்க So any patient who comes to you, first you must know, your examination goes along with the history. No point examining the patient without knowing what history. So first thing, what happened to you? So he gives a history of, for want of time, I'm just telling the history in brief. He has a history of fall from bike and he comes limping to you. So first thing you need to find out is it so severe that he is unable to weight bear or not. So that itself makes you how much you must examine him. With pain you cannot do all the tests. So first thing is to point out where is the pain. Where is the pain for you? So he is pointing out to the lateral side. So examination is straight away, you know something wrong on the lateral side. So our mind must start thinking, so he had a fall from bike, so what other things could have happened, and go on and examine from there. First thing you look, see, Kal terida. So first is your inspection, as basics as Das tells you. First you see, for the inspection, look for the swelling, look for the bruises. Is there contusion anywhere? I'm not going to the trauma part of it. It's a cold case where you're just examining for swelling and things. So, other aspect is as you examine, you need to keep talking to the patient so that they feel comfortable. Their knee must be relaxed for you to elicit most of the tests comfortably. So talking to the patient as you examine is the way to go about. When you ask them to flex, they might do it voluntarily, but you must be able to do passive flexion extension. That's possible only if the patient is relaxed. So first you must get the confidence of the patient. So you have to keep talking to them. Then you gently see how much of flexion extension is possible without pain. Before you go on to palpate the painful spots, try to palpate other areas which are less painful so that you don't elicit pain in the beginning. Then the rest of the examination becomes difficult. So make sure the other examination points are done first before you get to the painful spot. So now with so many youngsters coming up with MRI and X-rays being so much freely available, we tend to miss out on the clinical examination totally. So it is the gold standard. Without clinical examination, any MRI or X-ray is not going to give you the right kind of diagnosis. MRI might show up so many things which is irrelevant in that particular situation. The patient's complaint might be totally different from what is seen in the MRI. Unless your relevance, whether the complaints are of the patient might be in the medial side, what you see in the MRI might be something lateral. So just based on that, we cannot go and diagnose. Certain such examples are some scenarios where patient comes in severe pain, unable to walk. Your X-ray will show grade 3, MRI will show cartilage loss, and some synovitis. But the clinical examination is the thing which will help us know which is the fact or the part which is actually giving them the disability. Your examination will tell us whether it's a medial joint line tenderness which is giving the disability, or the synovitis which is going to be a suprapatellar tenderness which is going to give you the disability. So your clinical examination is the thing which will help us identify whether which region is actually giving the pain and which is the source of pain. In that situation, if it's a suprapatellar area which is giving the pain, your diagnosis is going to be synovitis and not medial joint OA or nothing to do with the meniscus. Even though MRI might show a degenerative meniscus tear, cartilage loss, your X-ray is going to show a grade 3 change. So the treatment is totally different. If it was you might have advised a joint replacement or an osteotomy just based on X-ray or MRI, but your clinical finding must be just synovitis. So your treatment is just going to be a painkiller or synovitis relieving drugs, or it's going to be an injection which will relieve the pain of the patient, and symptomatically they will be better. So your diagnosis based on clinical examination is the best thing to go forward, because MRIs and X-rays are so much freely available. Now hardly some newer generation do not even touch the patient. So patients also are complaining, so many reviews are there just based on these, they don't even touch the patient. So touching the patient is very, very important. So before you touch the patient, first you need to examine, see the knee. I guess you're not able to see the knee yet. So he complained of lateral side pain. So things which would come into our mind is where can the lateral side pain happen? If it's in the joint line, it might be the meniscus. If it's above or below the joint, then I'm good. So if it's in the joint line, can you see? Okay. So first, starting off, I would just do the patellar mobility, see how mobile the patella is, how much of retropatellar tenderness is there, roll out over the suprapatellar area, find out is there an effusion, how bongy is the synovial swelling, is there synovitis. Post-COVID, there are a lot of synovitis which doesn't vary. So first, see if there is swelling in the suprapatellar area, how much is the synovitis, how much is the swelling. Roll around the knee like that so that they relax, see how good is the patella. Look for the joint line tenderness. He's been complaining of lateral side pain, so lateral joint line is somewhere there. Palpate high to look for the lateral epicondyle, palpate low to see if anything in the gutters, any pain is there. That's how you examine the lateral side. So what all things would come to your mind is if there is lateral condyle or lateral joint line tenderness, something to do with the meniscus or might be the ACL. ACL in the acute stage presents as lateral tenderness because of the pivot shift contusion pattern over there. They might not have anything else. Then goes behind, if he was running and falling, is there any muscular tenderness in the lateral gastroc? Is it the biceps or is it the posterior popliteal pain which he is having in the back of the knee? Same way if we go to the medial side, if there is a fall, again joint line tenderness over there. If you can see, that's the area which you need to see for joint tenderness. If you go higher, that's the MCL insertion point which you are looking at. If there is tenderness in the MCL insertion point, then keep it in mind, or it's that distal tenderness, or is it in the behind your gastroc, is it your hamstrings which is painful? So you have to be very specific, just not say it's a medial side tenderness. You have to look into various points. Molidharan had shown the anatomy, so keep the anatomy in your mind and just identify each point. So palpate each of those points and find out which point is painful and which is the source of pain. In these elderly individuals, so often we find only there is no medial side, it's just distal to the medial side, or it's going to be the gastroc, or there'll be spasm. So straight away look for the dorsiflexion, see if there is pain in the gastroc. Most of the time it's going to be calcium vitamin D deficiencies which is going to give the pain, or sometimes it will be distal tibia, anserine bursitis. Sometimes your root TAS will present as distal tibial pain, no joint line tenderness. So root TAS, then you have to ask for an MRI. Medial joint line tenderness, it could be the meniscus or any other structures close to it. If it's little proximal, straight away go on and do a valgus stress test. Can you see that? So when you do a valgus, so valgus stress test in extension, it might not be painful, and go into flexion and do a valgus stress test. If it's painful, then you think suspicious of a medial MCL injury. Then come to, as usual, you have to, for all arthroscopy surgeons, most important is to do a Lachman. For that, the patient should be relaxed. So what I do is, ask the occupation of the patient and keep talking to the patient. What are you doing? So as he was talking, you easily feel the Lachman. So try to distract the patient when you want to do a Lachman. Keep talking to the patient. So what do you want to do in the future? So distract his attention if you want to do a Lachman properly. So that's how you do a Lachman. If the knee is small, if you're able to grab easily, this is the way you can do. But some of our patients are so bulky. So the other alternative way is just get your thigh underneath. So get your thigh underneath. So again, keep talking to the patient. As you keep talking to the patient, you will be able to elicit the Lachman properly. At the same time, you have to keep pushing it back, look for the sag. That's the way, even in this, if you're not able to elicit, you can grab the foot in your axilla and then try to talk to the patient. Then this is the pivot shift mechanism which you can elicit. This is the way you internal rotate and keep talking to the patient as you do this maneuver. There are various ways you can do the pivot shift. I'm not going into the details. So these are the basic points of how you need to examine the knee. More important things in the rehab which I wanted to highlight was when you see your patients in your follow-up, people do not know what exactly to see. They keep complaining of pain. Again, we need to find out what's the source of pain. There might be pain anteriorly. You have to look for FFT. Is there a flexion deformity or not? Is there full extension possible or not? How much is the range? And the other aspect which we usually miss is the gait. Before I finish, I just wanted to show what we look for in the gait pattern. So if, please watch from there carefully. You can see him walking. So what kind of gait is this? Anybody can answer, please? 3 people, can you repeat, please? Arvind is doing a good job. So can anybody mention what kind of gait? Probably a stiff knee gait. Stiff knee gait? Okay. So he's keeping the knee stiff, if you can see, stiff knee gait. The knee is stiff. You just see him limping and you try to correct it. This is because he's not flexing the right side. So you need to increase the flexion. So your rehab must concentrate on increasing the flexion. First one. What is this gait? Everything is the limp, but what is this gait? Repeat. These are small things, very, very important, because we are the surgeons who know what we've done for him. So without a physio might suggest a rehab for him, which might be harmful for him, unless we are able to guide properly. What gait is this? Antalgic gait, exactly. So how did you identify it as antalgic and not stiff knee? Short stance face, yeah, exactly. The stance face is shorter and the stride length also will be shorter. These are small things which we need to pick up, and that's because of pain. So we cannot keep pushing them to keep walking if they have antalgic gait. If it's a stiff knee gait, we can ask them to keep walking. If it's antalgic, there is something harmful. If there is effusion, you have to stop loading, you have to unload. Next time. Stiff knee, next. Pixel flexion. What gait is this? F50. F50 gait. So we have to see if it's the stiff knee 8 or F50 gait. F50, we have a separate protocol to correct the F50 where we put them prone hangs, F50 correction. That rehab is totally different. You have to concentrate on correcting the F50, otherwise that's going to stay, especially in an ACL patient. If you don't correct the F50 within 2 months, it's going to stay. The last gate, which is the difficult part of the gate. Can you see the go back. What is this gate? Exam question. Whereas you cannot do where the rest. See the entire limb. See the hips. Trendelenburg gait. So when do you get a Trendelenburg gait? So everything presents as a limp to you, but you have to identify how are the shoulders, how are the hips. So this is because of abductor weakness. So if the abductors are, because we've immobilized them, we will put them on non-weight bearing for 3 to 6 weeks, the abductors would become weak. They would limp in this manner. In this situation, your rehab of thighs will not give you the answer. Your rehab must be concentrated on the hips. So identifying your gait and correcting them is again a part of a clinical examination of knee. Again, knee examination does not stop with knee alone. You have to look into the foot, you have to look into the ankles, you have to look into the hips in examining knee, and gait is a very important part. Your examination starts with the gait when the patient walks in your clinic and ends with your rehab, again watching the gait. Thank you.
So inference on this contusions, ecchymosis on the lateral and the medial side. What is it? When they come with the sitting, there's ecchymosis on the posterolateral or the posteromedial side. So what do you suspect in those conditions?
Some collateral injuries usually present with ecchymosis. Immediately, they will be usually around 2 to 3 weeks when you find those ecchymosis, especially in fast skin. And our skin, probably it won't be seen. Any kind of direct impact injury, any kind of injury anteriorly might track down posteriorly, anything similar to the ankle contusions. So it doesn't really give us intra-articular pathology ecchymosis. It's something extra-articular which usually results in ecchymosis. Your ACL doesn't present with ecchymosis. That's something extra. Table killer.
Next, I would like to invite Dr. Bhupesh, sir, for knee imaging X-rays, CT and MRI.
Thank you. I asked, sir, good morning, sir. I asked Santosh that I might not be able to do justice to all three, so he said choose one of the three and then you can do justice. And then I'm known to finish in time, so I asked our IAS secretary 3 more minutes from his talk because he said he will finish in 4 minutes, so I'm taking 10 minutes of your time. So we'll talk on X-rays, CT and MRI, and we will concentrate a little more on X-rays because CT and MRI, I think most of you know. We usually do AP view, supine. If you have a problem where you think there is degeneration, then you do a loading X-ray. The intelligent thing is to do a bilateral knee AP standing, so you will always be able to compare with the other side. You have your lateral view, you have your patellofemoral views, you have your stressed X-rays for your cruciates and collaterals, and of course you have the bilateral AP view of the lower limb, which is the alignment view. Now we will concentrate on the last one. This is when you have osteoarthritis, when you want to do not only of the medial compartment, of any compartment, when you have ligament injuries or malunited extraarticular proximal tibia, then you think of doing this. The first thing that you have to know is how to take the X-ray properly. So this is a horizontally projected X-ray beam, and the patient should be at least 3 meters away from the X-ray beam. Why I am trying to talk about this is many people don't do these X-rays, and you plan osteotomies with short-legged X-rays. This is not something which is very fancy. You can all do it. It is very simple. You just have to have the 3-plate cassette and it will go into any of your X-ray machines. The second thing is to make sure the patella is corrected. The patella should be centered. To center the patella, you have to internally rotate your whole lower limb by around 8 to 10 degrees. If you don't center the patella and the X-rays is taken in external rotation, then this is not a good X-ray for alignment reading. You can strap a 3 centimeter ball into the thigh so that you will have a magnification factor, and then you can plan your osteotomy numbers based on that. But now that we have angle measurement guides in osteotomy sets like a jack, it is not very important. The next thing, the pelvis should be corrected. There should be no pelvic tilt. If there is a limb length discrepancy, you put tiles down and then correct the limb length discrepancy so that your pelvis is not tilted. Now to zoom in and see how the knee should look, the patella should be centered, the joint line should be well visualized, and usually the tibiofibular overlap should be around 1/3. The second thing is to understand these X-rays. You have two axes, the anatomical axis and the mechanical axis. We all know about it. Center of the femoral head to the center of knee is the mechanical axis of the femur. The mechanical axis of the whole lower limb is called the Mikulicz line. Usually the Mikulicz line is 2 to 4 mm medial to the center of the knee joint. It is from the center of the femoral head to center of the talus. Trying to get the center of ankle might be a little tricky, so the easy thing to do is to find the center of the talus. If the Mikulicz line is 10 mm lateral or 15 mm medial, it means it is a deformity, either on the varus or the valgus side. Now we have to understand where is the deformity before doing any procedure. The deformity can be in the femur or it can be in the tibia. To understand this, we look into two angles. The mechanical medial proximal tibial angle, that is the angle formed by the mechanical axis of the femur and the joint line of the distal femur. This is called the MLDFA. Femur and the joint line of the femur is the mechanical lateral distal femoral angle, and the mechanical axis of the tibia and the proximal tibial joint line is called the MPTA, or the medial proximal tibial angle. Both are around 87 degrees, and you should not take the joint line congruently into this while correcting, and this is how it looks. So this case that we are going to discuss has a proximal tibial varus alignment, and the problem is not in the femur because the LDFA is 90 but the MPTA is 83. So what do you do? The third point on what to do with these X-rays now. You have taken X-rays, you have understood them, and what to do. We use the Miniachi method to do our HTOs. You have 3 points. The lateral hinge point is in the tip of the fibula. The planned correction point is where you want your joint line, your mechanical axis to shift. Now the orange line is the Mikulicz line. You want that angle to shift to the yellow line now. To do that, you draw a planned draw a line from the center of head through the planned correction point. And then from there, you take a line from the center of ankle to the lateral hinge point. And from there, the same size line, the size of line from this point to here, from the center of talus to the hinge point, the same size line should be drawn from the hinge point connecting to the future mechanical axis, which is the yellow line. Now this angle that is subtended is your angle of correction, and if you apply that angle of correction to the HTO, you will get a line, you will get a limb which is well corrected going through this. So that finishes our X-ray. Quickly to CT. CT is important to identify loose bodies better than MRI. It is important to do your TTTG distance, and it is important to do your avulsion fractures, because some of the avulsion fractures might be missed with X-rays or MRI. So these are three indications where CT scores over the other things. MRI is the mainstay of our investigation. I know you all know how to read MRI, but some classic things I would like to show. Very quickly, anybody, what is this? Most common thing that you see? ACL tear. How do you know this is ACL tear? ACL is an oblique ligament. Unless you take oblique sagittals, you will not see the full ACL in a single picture. So you also have to rely on the question mark sign or the buckled PCL sign to know that your ACL is torn. What is this? This is a lateral meniscal tear, correct. What is this? This is a medial meniscal tear. You have to start learning to see things in all three planes. You have to try to see them in sagittals, in coronals, and in axials. So medial meniscal tear, and then again you can see the same medial meniscal tear in the coronals also. What is this? This is a PCL tear. ACL looks intact, PCL is torn. This is a combined ACL and PCL tear. It's like a bomb blew off in the knee. What is this? Yes, this is PCL avulsion. This is where your CT will score over other things, because once you suddenly see all this, it can be missed. This is a PCL avulsion fracture. This is a large PCL avulsion fracture. What is this? Yes, this is the cystic type of the mucoid cyst, which is more commonly seen behind the PCL. You can see it in all three planes, in the coronals, in the sagittals, and in the axials. This is the other type of one. In ACL, you usually get a fusiform type. This is a cystic plus fusiform type. And you see ciliary stalk appearance classically in the ACL fusiform type. And loose body here. What is this? Yes, there is extrusion of medial meniscus. When you see these three classical points, extrusion of medial meniscus in the mid coronals, and then the ghost sign of the medial meniscus in the sagittals, and hyperintensity in the root attachment in the posterior coronals. These three signs together know that it is a medial meniscal root tear. This is MCL tibial avulsion. What is this? Double PCL sign. Whenever you see double PCL sign, you should also look for the next one where there is absence of MCL there. So this is bucket handle medial meniscus when you have these two together. What is this? This is anterior horn, double anterior horn sign. This is for bucket handle of the lateral meniscus. This is MCL, MPFL femoral attachment, MPFL tibial attachment tears, and then you can also use it to identify some of your fractures. Thank you, and I want all your support from Tamil Nadu for the upcoming IAS elections. Thank you very much.
Thank you, Dr. Bhupesh. It was a well-tailored talk. Next, I would like to call upon Dr. Geethan to deliver his talk on basic arthroscopic setups.
Good morning. Thanks to Tamil Nadu Arthroscopy Society for inviting me, Dr. Geethan from Trichy, and I'll be talking on basic arthroscopy setup for beginners. I have focused this talk for the very beginners to start their practice, or perhaps if for a new surgeon to start his practice in a new hospital. So of course, arthroscopy setup, we all know we need equipment for visualization that includes monitor, camera and scope and light source. Then for debridement, which includes shaver and ablator, positioning devices and further instruments. And I would recommend that in at least in early cases, before the patient gets an anesthesia, we should switch them on, and it's a good practice to make sure that all these devices are in the on condition before even patient gets anesthesia. But in early stages, it's not enough if we see only an arthroscopy cart, because we should ensure that the other theatre setups are also ready. So I'll be talking briefly about the arthroscopy cart and then about the other setups very briefly, and then go through the checklist later. So moving on, we'll have the stock in 4 divisions, and I'll talk about the choice, and wherever possible I'll talk about the usage tips and sterilization methods. So visualization, we'll have to see with scope, camera, light source and fluid management are the components to visualize. Regarding the scope, currently there is not much choices. It's a standardized, we need a 4 mm scope. It is 170 to 180 mm length and 30-degree viewing angle. We also have scopes that are shorter or longer, but it's only for wrist or hip. That's not essential for the normal joint arthroscopy. And also viewing angle can be 70 degrees, rarely used for some conditions, especially in hip and shoulder. And while choosing a scope, we'll have to look at the image quality. We can try the scope before and see how durable it is. Local company scopes are usually less durable, and we'll have to look at what sterilization methods that scopes can support, and also use a scope which comes with a smooth obturator and not a very sharp trocar. Moving on, while using the scope, we should always protect it. We should never insert a scope directly into the joint. We should always follow it after inserting a sheath using a obturator. Before switching on the shaver or burr or ablator, we should visualize where it is, because shaver or burr or ablator can really damage the tip of your scope. And we should protect the scope against bending. Like when you're going to visualize the posteromedial joint space, or when you're doing some complex maneuvers, just ensure that scope is not under tension. Moving on to camera, the current standard is using a 3-chip HD. We can also have a 4K or a 3D cameras, but I don't think currently they are needed for arthroscopies. It's preferable to have a camera which supports recording also. Again, while choice, we'll have to look at the image quality, the durability, and what sterilization can support, and also look at the ergonomics, build and heat. For example, this camera here is very thin and like a rod, like we don't know, when the early stage we don't know which is up and which is down. But if you use some other camera which is like asymmetric, we will know which side is up. And also in this, there are no 2 knobs. Like when you try to adjust the focus, the adapter comes off. So these are the small things to look in. So sterilization, for scope and light cable, I would prefer ETO or plasma sterilization. For camera, it's always better to go with only camera cover and now avoid any kind of sterilization to protect the life. And Sidex and formalin, people have used it. I don't recommend using it, but if at all you have to use it, ensure that you know the sterilization time. For example, for Sidex, 20 minutes is only the disinfection time. It's not sufficient for arthroscopy procedures. Sterilization time mentioned in the box is about 12 hours. And formalin, again, it should be in a formalin chamber for at least 12 hours for us to consider that it is sterile. And Lotto consider that Sidex and formalin, we don't have any sterilization labels, so we are never really sure whether our instruments are sterile or not. Light source, again, current standard is used to use a LED light source. It's better to have a console which mentions the usage hours and residual time left, so that we are not for surprise when it goes off. And we should understand that there are different kinds of adapters at both ends. Our scope should match the adapter here, and light source console should match the adapter here. And moving on to fluid management, of course, having a pump is ideal. There are smaller pumps, but they give peristaltic kind of like short burst kind of fluid. But having a continuous flow pump actually makes the vision easier. But this is not essential for all cases. In most cases, we can use a saline bag and gravity-assisted flow. If you want real added flow, we can buy tubes with bellows, or you can have 1 liter saline and use a quick infuser to pressure fuse it. And some people actually use a BP apparatus to pump air in, but I don't recommend it because again there are concerns about sterility. And tourniquet is a must. We should all invest in a good quality tourniquet, and we all know how to use it also. Moving on to the next step, shaver, burr and ablator. Shaver again, the factors I consider are the ergonomics, whether we are comfortable with hand or foot pedal, the efficiency of resection, the life of shaver blade, and also build quality. And again, we should know about the shaver blades. There are many different types of blades, depending on whether you want speed or control. For example, if you want to do aggressive cut, you can go this side, but if you want to debride meniscus without injuring the cartilage, we should probably use a smoother bite. My personal preference is aggressive plus cutter and a 12 fluid barrel. These are usual for most purposes. Usage tip, we should, shaver after use, it's better to clean with pressurized air because small tissue that goes inside shaver can really reduce its lifetime and sterilize the ETO. And ablator, they have options of using underwater cautery or RF ablator. Again, we will have to consider how efficient it is. Usually use it and try it, and life, whether you want hand control to choose it. And positioning devices, we should ensure that the theater supports or it has all the devices that we need to position for knee in two positions we commonly use, and also for shoulder, whether you want to use a beach chair. Beach chair, it's preferred to have a dedicated head positioning device, or we should be ready with supports if we do not have a dedicated head positioning device. Should have all the other apparatus to position. We should make sure that all these are ready before we post a case. And again, for lateral position, we need a traction stand, bolsters to position, and we should have all these ready before planning of surgery. Instruments, of course, Dr. Terence will discuss in detail. Let me briefly mention that all these instruments which are considered typically used as shoulder should be in a knee set also, because that will make you versatile in repairing the meniscus and doing many surgeries. And implants, again, Terence will talk, but I want to ensure that all these implants should be in your knee set, the backup, because these will help you to come out of any situations. So moving on to table, we should have a table which supports going all the way down tourniquet, and I'll just move it. I'll have eventually have sterilization also. And with all this, I prepared a checklist. Due to lack of time, I will not go into it, but you can always scan this QR code and follow it. So as I said, before starting a case, we should ensure all these are actually on, and we are actually having all these in a sterile position. And further on, our checklist goes into all the implants that is required, but you can always download it and have a look later. Thank you.
Thank you, sir. That is a wonderful talk. Next, I would like to invite Dr. Arish Kumar for his talk on diagnostic arthroscopy and knee portals.
A very good morning. I am Dr. Harish Kumar from Trichy, here to discuss about diagnostic arthroscopy in knee portals. So, starting with a brief introduction. From its introduction in 1912, arthroscopy has found a very good place, both technical and technological. The advent of MRI has actually changed the need for diagnostic arthroscopy as a sole procedure in all cases, but nevertheless, diagnostic arthroscopy still finds a place even in the era where MRI has superseded. One has to be familiar with the surface anatomy of the knee, which includes the bony anatomy of the patella, medial joint line, lateral joint line, tibial tuberosity, and the patellar tendon, with importance being shifted to patellar tendon and tibial tuberosity in the case of diagnostic arthroscopy. So, what are the prerequisites for actually doing a proper arthroscopic procedure of a knee? Starting with the patient positioning, the patient should be positioned properly, either in a hanging knee position or a knee supported on a table with a bolster to support the knee in a 90-degree flexion, with side support dangling at the side of the tourniquet. This position is very mandatory because if we have to examine the meniscus, the side support plays a part, and the support at the knee joint actually helps us in hyperflexing the knee to actually visualize the structures. So the positioning of the patient is a must, and then the tourniquet availability should be checked, proper placement of portals should be done, and proper need of portals. What all portals have to be needed? We have the MRI actually telling us what pathology needs to be addressed, and in that case we have to pre-operatively plan for the portal placements, and we have to check on the availability of all instruments needed for the knee arthroscopy, irrespective of the pathology described in the MRI. one has to be familiar with the triangulation technique and understand anatomy in each case, because each individual is different. For example, if a patient has a PCL tear, there will be a posterior sag of the tibia. In that case, the establishment of portal will be a little tricky. So you have to reduce the knee to establish a portal. And if there is scar contracture or a patient who has a trauma with the patellar tendon, there are a couple of cases where the patient had a patellar tendon tear with the open knee, for which in freelance you cannot actually deny the cases. You have to go for the cases. So you have to understand the anatomy in each case. So these are some of the indications where arthroscopy has a place. So moving on to it, I'll go into the proper visualization of knee joint. So in order to do a proper visualization, one has to be actually familiar with what all structure needs to be visualized. So we start with the suprapatellar pouch. The introduction of the knee with the blunt trocar starts with the extended knee. With the knee in extension, you introduce the blunt trocar to the suprapatellar pouch, and from there the examination starts. So suprapatellar pouch we examine to see if there is any loose body or synovitis, and then we move into the patella to see if there is any osteochondral defects or if the patella has some chondral fibrillations, and then we go into the trochlea to see if there is any osteochondral defects and the patellar tracking is fine, and then we go into the medial and lateral gutter to visualize the body of the meniscus and also the loose bodies if impacted. Usually in the lateral gutter, if you're lucky, you can see the popliteus tendon, or you can visualize the popliteus tendon in a figure of 4 position. Then we actually move the scope to the intra-articular position, where we actually attend to the pathology of the patient, mostly ACL in cases. But even if the patient has an ACL tear, meniscus should not be left unvisualized. So visualization of the medial meniscus is a little tricky because of the narrow joint space. So in that case, you can see this video where the MCL, as the MCL is being imbricated, the medial joint line opens. So you can have a better understanding of the posterior part of the medial meniscus and the root, from where we can actually probe in to see the mobility of the posterior part if there is a type 4 or type 5 ramp lesions. The lateral meniscus should not be ignored in a patient with defined pathology, because this is the lateral meniscus which we can appreciate in a figure of 4 position. We can see the lateral meniscus. There are a dozen cases where I actually found a discoid lateral meniscus in a case of ACL. So the discoid lateral meniscus is not always indicated, but I said in a dozen cases where I found discoid lateral meniscus, nearly some 1/3 of the patient had a symptomatic lateral meniscus. Even before the ACL tear was present, the patient presented with a pain. So the lateral meniscus should not always be ignored in any cases. Then we move on to the posterior medial joint space. The posterior medial joint space is always a treasure box where you find a lot of lesions actually. The posterior medial joint space is usually advanced using the window between the posterior window between the PCL and the medial femoral condyle. Here you can see the video where actually I introduce the scope between the window between the PCL and the medial femoral condyle, introduce the scope, visualize the posterior part of the posterior medial joint space, and from there you can establish the posterior medial portal as and when indicated. So the posterior medial joint space has to be probed because there will be a side and ramp lesion of the meniscus, or there can be a loose body impacted in the posterior medial joint space. As in this patient, this was a army individual with a 10 years old ACL tear. He had an ACL tear. When probed into the posterior medial joint space, I could find a very large loose body. Actually, this loose body was seen in MRI, but in the suprapatellar pouch. But during probing into the posterior medial joint space, during probing into the diagnostic approach, I couldn't find any loose body in the suprapatellar pouch, but it was in the posterior medial joint space. So ignoring the posterior medial joint space is a little thing. So also there is a case where I did a Baker's decompression from the posterior medial joint space. So posterior medial joint space probing is always helpful in several scenarios. When there is a ramp lesions are usually the type 1, type 2 and even type 3 ramp lesions are not generally seen in an MRI. So in those cases, actually the posterior medial joint space visualization will help you. Many cases are there where I actually probed into the posterior medial joint space and I could see a meniscus cyst being decompressed. Why this is important? Because the patient actually has a meniscus tear or has an ACL tear, and he does an MRI at the time of trauma, which signifies that patient is having an ACL tear, and he presents to us maybe a month or a couple of months later, and in the due course of time he will have a medial meniscus tear. So if you are going to attend the patient according to the MRI report, which suggests an ACL tear, we will be tending to miss the meniscus tear in these patients. So always probe into it to find the lesions. So moving on to that, I would like to highlight on the portals needed. So the anteromedial anterolateral portal, always mandatory. You viewing an instrumentation portal primarily, far medial and far lateral portal. If you want, you can actually choose. I always go on for a far medial portal for an ACL trajectory. And then the posteromedial and posterolateral portal. Posteromedial is usually done in direct visualization behind the MCL, and posterolateral portal, usually you do it between the biceps femoris and the LCL. Avoid going posterior to the biceps femoris because there is more chances for injury for the common peroneal nerve. Then the accessory portals will be supromedial and supralateral portal, which may be needed, and transpatellar portal, which is not mostly done nowadays. And then we have the mid-medial patellar portal, mid-lateral patellar portal, as and when indicated. So the take-home message is diagnostic arthroscopy is always gold standard. Double check on the instrument and optics, understand the anatomy of each and every patient, proper placement of portals is needed, take time on Hoffa's fat pad. Always go by this parable, blind man and elephant, perception is always subjective and limited. You have the scope, you have the visualization, probe in and enjoy the experience. Thank you.
Thank you, Dr. Harish. It was a very crisp and precise talk. Next, I would like to call upon Dr. Terence to talk on scopy instruments and implants.
Good morning, everybody. So my talk would be in the extension of talk of Dr. Geethan sir. He's already highlighted the important setup principles that we should have when we start an arthroscopy surgery. So on continuing on that, this talk would be basically to highlight what are the must to have arthroscopy instruments. This armamentarium is a very, very important thing for an arthroscopic surgeon. If you are a freelancer, to have a very good set is very important, even in an institute as well. So this will decide on what quality of surgery you're going to give the patient. So first thing is the scope. This is our navigator to the joint. So we have to, all of us have to have a good scope. Investment on this is very, very important. So starting with this is we have a sheath and a trocar. So either one side will be inflow connecting with the saline, another will be connecting to a suction, or some people like to connect the suction to the shaver as well. The scopes, as Geethan sir said, we have wide varieties of scopes up to 4K qualities now. So more the money you spend, the better image quality you get. And a recording device is very important to document all your cases from the beginning to improve on your skills and also for any presentations if required. So holding the scope is very important. How to hold the scope? Yesterday we were having a small discussion on this. So it's very important to hold the scope properly. When we start, always we hold it with one hand. Always use both your hands to hold the scope and the light source. Also use both your index and a middle finger for taking pictures and also doing a video capture. So this is the 30-degree scope. I think it's good enough to have a 30-degree scope for the knee, but for the shoulder sometimes some people also prefer to have a 70-degree scope. But as a basic investment, I think 30-degree scope is very good to begin with. So an extended finger of an arthroscopist is a probe. Some people call it the knot pusher as well. There's kind of a duel between these. But a probe is very important to begin with. As a basic arthroscopic surgeon, we always have to go, especially during the meniscus lesion, the cartilage lesions, we probe, we see how stable is your repair, and for everything, this is like an extension to your finger, and it's a must to have thing in your instrument box. So shavers, as sir said, wide varieties of shavers are there, different names. Basic idea is Basic idea is to have two basic tips. One, which is a smooth, non-serrated shaver, which you can use for any meniscal lesions if you're just trimming a part of the meniscus. Whereas serrated shaver, you can use it when you want an aggressive shaving, especially at the fat pad, or you're debriding a stump, or for a quick debridement. That is very useful to have an aggressive shaver. The speeds of the shavers, usually for knee, again, if you're using an aggressive shaver, it can be like 2500 to 3000 RPM. In the shoulder, we generally keep it around 2000 RPM. So it's depending on your technical feasibility. So these are the different upbiters. It's if you tell, it's must to have. This is one straight upbiter that you should have. This comes, the dimension can be a slightly bigger one, or you have a mini upbiter in the same, which is a straight upbiter. This is a must device to have. Apart from this, good to know upbiters, you have a right and a left upcutting punch. This is a left one, and this is a, sorry, this was a right one, and this is a left upcutting forceps. Another one to have is a reverse upcutting. This is a reverse upcutting, especially which we can use it for most anterior part of the meniscus. If you want to trim them, this can be useful. But if you want to have one, invest in one straight good upbiter. So now we know that there are a lot of types of devices for repairing the meniscus. We have inside out, all inside, we have outside in. But I think if you have one inside out device, which is zone specific, I think most of the zones you can repair. Even the posterior most part of the meniscus, we can make windows, and we can use the same inside out devices. So if you're looking at cost cutting, still giving a good quality to a patient, again investing on a good zone specific cannulas, zone specific needles for meniscal repairs should be good enough. So we all know this. For anterior most part, we use the outside in. For inside, for the body, we use inside out, and for posterior on, they say all inside. So this is how we use the inside out needles. Among the devices that we use for repairing the meniscus or stitching the ACL grafts, we have fiber wires and fiber tapes now. Both are reinforced polymers with very good strength and ductility. So all inside is a whole new realm. So if we have to go in, I think further talks will be there describing the all inside devices. I don't want to go in detail with this. Different companies have different devices, but still, if you're looking at a cost cutting to the patient plus giving a good quality, still investing on an inside out device with the zone specific cannula, with making adequate portals, posterior portals, we can still manage even the posterior test with an all inside with the inside out repair. We are going to have a live surgery today on root repair as well. So root repair is having a knee scorpion is very essential, especially when we're dealing with the meniscal root tests. So a knee scorpion is different from a shoulder scorpion. The profile is lower, so we need to have both if you're doing knee and shoulder arthroscopy. So this is a self-capture device. We feed a fiber wire into it. It takes a bite of the meniscus and has a self-capture which withdraws the fiber wire out. If you're doing a root repair, we need to have a suture button or a free endo button at the tibia to tie these fiber wires. And today we also will be seeing the root fix anchor from Osteocare, which is also a very good device, because if drilling multiple tunnels is a problem when you're doing a multi-ligamentous injury. So if you have a device where we don't have to drill an extra tunnel or keep the tunnel short with the root fix device, it will be very useful. So jigs, ACL jigs, we all know this. So whether to use a ACL offset jig for femoral tunnel drilling has been a debate for quite some time. So a jig it can be a 5 mm jig and a 5 mm offset jig or a 7 mm offset jig. So you can see this. This was a very interesting study by Kim et al. In Casta, which suggested that when you begin your arthroscopy, it's always better to keep the offset jig, because very, very rarely you can have any posterior or lateral blowout with the offset jig. But if you're doing a freehand technique, as a novice surgeon with less than 1 year experience, it might be difficult for you to get the exact point according to the study, and they always have recommended the use of an offset jig. We also have to have outside-in jigs, especially if you're looking at an all-inside ACL scenario. We are doing an ACL in pediatric age groups, physis open. We need to have this outside-in jigs as well in the armamentarium. This has to be there. A PCL jig is completely different from an ACL jig. A PCL jig has a double curve like this, and it has to be there in the armamentarium if you're looking at a multi-ligament disc scenario. Coming to fixation devices, just brushing on these topics. Suspensory fixation devices, going into details won't be possible in this talk. This is a fixed loop and this is an adjustable loop device. A lot of people like to, they have their own favorites to go with. There are a lot of conflicting studies on this as well. This was a very recently published study which suggested of a lot of cohort, 2,600 patients studied, suggested that there's no clinical difference between adjustable and fixed loops. But a lot of biomechanical studies but show that adjustable loops have certain amount of lengthening. So people, I recommend putting knots after you do your adjustable tape to be on the safer side. Coming to the interference screws, bio screws, what we use for soft tissue grafts at the tibia. For BTB, we use metal screws. We can use bio screws as well with the tap. So these are the interference screws for the knee arthroscopy. Cannulas are important because, especially as our previous speaker said, if we are dealing with a ramp repair, if you're doing a ramp repair, having a cannula is important. If you're doing a PCL reconstruction, if you're doing PCL avulsion fixations, using a cannula is important. So you can use a 6 or 8 mm cannula. These are twist-in cannulas with built-in stoppers, which avoids the fluid from coming out. Passport cannulas, especially in the knee, we will be using it if you're doing an all-inside ACL. Suture passing devices, especially if you're doing a ramp repair, it will be very useful. These are all retrograde suture devices through which we shuttle the nitinol wire and then the fiber wire across for the repair. Always remember, cartilage lesions come as a surprise sometime. When you're doing an ACL, you find a focal cartilage defect, you might have to do a mosaicplasty. So it's better that you invest in this, buy it once, and then you can keep reusing it at least for 10-15 cases after that. Thank you.
So that closes the first discussion part. So any questions for the speakers?
So okay, if there are no questions, then we'll close this session. And first we'd like to call Dr. Muralidharan and felicitate him. Muralidharan? Yeah, Muralidharan, sorry. Dr. Bhupesh. Dr. Geetan. Dr. Harish. Dr. Terence. I'd like to invite Arumugam sir to felicitate our chairpersons. and Dr. Dinesh. So we'll move. So we'll move on to next session. Now I'd like to invite the chairperson, Dr. Sundarajan sir and Dr. Sandeep Biraris to chair this meniscus section.
Good morning, everyone. I call upon Dr. Bhaskaran to speak about meniscus anatomy, tear types, and partial meniscectomy indications.
Good morning, all. I thank Professor Armugam, Dr. Sundar, Ramakant, Sandoz for giving me an opportunity to share my thoughts today. Anatomy is very important. You need to know first normal. Then only you can find out the abnormal things. Otherwise, you will unnecessarily take the tissue. Once you've taken it out, you can't put it back. So one-way route. So meniscus develops between 8th to 14th week of fetal development, and it develops from intermediate layer of mesenchymal tissue. And by 25th weeks, the lateral meniscus develops well with the good orientation of the fibers, but the medial meniscus will have some randomly oriented fibers. The growth is complete by 10th year of our life, and it is composed mainly of water, and other components are collagen, proteoglycans, glycoproteins, peptides, and fibrochondrocytes. So medial meniscus is a semicircular shape. It occupies 50 to 70% of the medial tibial plateau. So you need to know the dimension. It is around 45 millimeter length and 25 millimeter width, with slightly wider on the posterior aspect. So it has three kinds of attachment. So anteriorly it attached just in the anterior part of the intertubercular area, just in front of the ACL. It has also got an attachment to the lateral meniscus. It's called intrameniscal ligament. And the middle, that medial meniscus attached to the MCL and also capsule, and also the meniscotibial ligament. The posteriorly, it is attached just in front of the PCL and just behind the medial tibial eminence and lateral to the articular surface. Okay. So you need to know the attachment. So when you do the root repair, it is very, very important. Lateral meniscus, it's a C-shaped. It covers 75 to 90% of the lateral tibial plateau. So, so it has this anterior horn attachment, which is, you can see that in the down one, just it's anterior to the tubercular. So lateral tibial eminence, it's attached to the anterior surface of the tibial eminence, and also some of the fibers are intermingled with ACL. So when you do ACL reconstruction, if you remove the ACL stump, you might damage the anterior horn of the lateral meniscus as well. So you have to be very careful. So another thing is the posterior root of the lateral meniscus. It's diverse and it's complex, So the posterior root is just again in front of the PCL attachment. It is just medial to the lateral tibial eminence, and also just posterior to the postlateral part of the ACL. Again, here as well, you have to be very careful, otherwise you might damage the posterior horn. That posterior horn has also got an attachment to the medial femoral condyle. You call that as ligament of Humphrey, which is anterior to the PCL, ligament of Risberg, which is posterior to the PCL. So early stage of growth, that meniscus will have more, it is more cellular and vascular. So as we grow, that cellularity comes down and fiber content goes up, and also vascularity decreases. So at the finally, you'll have only 10 to 25% of the meniscus has got a blood supply. So with weight bearing and the joint motion, most of the fibers reorient and to become a circumferential nature. So in the red zone, you will have a type 1 collagen. The white zone, majority of them are type 2 collagens. So meniscus gets a blood supply from popliteal artery through medial, lateral, and middle genicular arteries. And also, the red to white zone is a bit hypovascular. So if you repair, if there is any tear, there is a healing rate of around 86%. So just there is one, and I try to repair it. The white zone, it is avascular, aneural. So the function, it converts the axial load into circumferential hoop stress. So by that way, it prevents meniscus extrusion and maintain the knee kinematics. It also acts as a shock absorber, distributes the load, and improves the stability of the joint and lubricates the cartilage and the meniscus. So if there is radial tear of the meniscus or there is any root tear, so that increases the peak contact pressure. In the medial compartment, it increases by 25%. In the lateral compartment, it increases nearly by 50%. So if you repair that, it restores the peak contact pressure. So it's very important to repair it. So you can classify based on the etiology as traumatic, degenerative, or iatrogenic. So based on the tear pattern, you can divide that as horizontal, longitudinal, radial, bucket handle tear, flap tear, or degenerative tear. So Leopard has classified this root tear into 5 types. Type 1 is a partial tear, type 2 is a complete root tear, and type 3 is a complete root tear with the bucket handle component. Type 4 is a oblique tear with the tear extending into the root. Type 5 is avulsion fracture. There is subclassification for the posterior horn of the lateral meniscus because it is a complex, because it has got a meniscofemoral ligament. So based on that, they classified into 3 types. Type 1 is avulsion fracture, and the type 2 is a radial tear of the meniscus there with the intact meniscofemoral ligament, and type 3 is complete rupture of both meniscofemoral and meniscus. Another one is ramp lesion. So you can see it with it is associated with the ACL in 10 to 20% of the cases. So if it is divided into 5 types, so majority things, if it is a complete tear, so you have to repair it to restore the biomechanics of the joint. So this is the tear pattern and what you do, how to treat. So in 2000 by 2010 in UK, if you take a day case list, if you have a 10 arthroscopy, 6-7 cases for a meniscectomy. So there is no concept of meniscal repair at that time. So you can, depending on the tear pattern, you can either trim it or do partial meniscectomy or total meniscectomy. But nowadays we try to preserve the meniscus. So, but there is a still role for some partial meniscectomies. If there is a small flap tear or some complex tear which you can't repair, degenerative tears. So there are some other examples. You can see that this is the bucket handle tear of the medial meniscus. It's torn. It's a young man. The joint, the cartilage, they are good. So here, so it's better to repair it. This is an example of flap tear. You can see that there is a small flap tear extending into the joint. So it may give like giving a feeling for the patient. So you can use a punch to cut that, or a shaver in combination to remove that to make it meniscus stable. So radial tear. So this first one is a traumatic tear, radial tear close to the root, and the second one is the radial tear of the body. So the traumatic tear, if you repair it, gives a good result. But radial tear, it's not. But still, you try to repair it so you can avoid worsening of the cartilage wear. So this another thing is when you do arthroscopy, you have to look for it. So only the eyes can see what mind knows. So if you look at it, so you can see that there is a small longitudinal tear on the superior surface and also the inferior surface. So you have to probe it and you have to look for it. Otherwise, you will miss it. So oblique tear, and here you can see that there's oblique tear. It's extending into the root. So here, so you need to repair. It's like nearly a radial tear. So you have to repair that. This is one of the variant. You can see that meniscofemoral ligament is intact there, but the root is torn. So it seems that the ends are rounded. So that means it's a long time. It happened long time ago. So you can see the other end of the torn meniscus. If you go just a bit laterally, you can see that is healed up. It's just. This is an example of the bucket handle tear involving both meniscus. This is a medial meniscus. You can see the bucket handle tear. It seems locked in intertubercular groove, but you can see that it's complex in nature. Okay, so the lateral meniscus this is complex tear again with the flap tear, and there's a vascular. The posterior horn. You try to repair that young man. You want to preserve the cartilage. So when you do partial meniscectomy, you have to make sure that the remaining meniscus is stable. So you don't want to leave any acute turn. You try to try to remove only required meniscus. Don't go beyond that. So the anatomy is very important. It helps in managing different types of tear, and the classification helps how to manage each tear, whether to do a meniscectomy or a repair. So partial meniscectomy still has got a limited role, but you always try to save if you can, so that you can save the knee as well. Thank you.
Thank you very much, sir. I think we'll be taking questions at the end of the session. So I'd like to invite Dr. Karthik Selvaraj to give his talk on inside-out repair and outside-in repair techniques.
At the outset, I would like to thank the organizing team for having given this opportunity in this wonderful meeting. We'll discuss mainly inside-out repair, and because I mostly do inside-out repair almost for all types of tears. Sometimes I do all inside as well. Huh? Power. So inside-out repair is the gold standard to which all the repair techniques are compared, and it's a very versatile technique and precise and very cost-effective as well. It's very favorable in large, complex, multiplanar tears, and stabilizing the tear, regardless of ultimate healing, is beneficial. We need to understand that even if you sort of stabilize a complex tear, and if it doesn't heal completely, still the meniscus is there and it's holding there, and it's very important, as Dr. Bhaskar said, trying to preserve that meniscus is important. Having said that, you should not be attempting to repair each and every meniscus you see. If there is some small flap tear, a small oblique tear, a white on white tear, and some tear which will not heal at all, then there is no point in actually doing heroic repair in that, because the patient might come back with a symptom later. So the principles, as many sutures as possible, as necessary, actually 4 to 5 millimeter apart. So the vertical suture orientation is biomechanically favorable, and in the inside out repair you have the freedom of actually orienting your sutures in any which way you want, and combine it with both femoral sided and tibial sided sutures. So you need to put sutures on either side. The ratios is 1:1, but at least 2 femoral sided to 1 tibial sided suture is a good ratio. So if you look at the placement of the sutures, it's better to place vertical mattress, as I said, is better. So when you take a vertical mattress, ideally you should be taking the bite through a little bit of the meniscus rather than just through the capsule. So you can actually pass one needle through the meniscus, one needle through the capsule, but actually biomechanically passing it through a little bit of the meniscus is biomechanically superior in strength. So try to take a bite here rather than there. If it's possible, you take it here. If it's not possible, you can take it through the capsule. One bite through the meniscus, one through the capsule. And this is the position we prefer if you are doing an isolated meniscus surgery. This is like a single lumen long needle meniscus protector system, which I prefer using because it's reusable. It's got an needle with an eyelet, and you can pass as many sutures as you want, and you can sterilize it and use it again. Usually you make a small incision on the medial side. So the steps here are: first position the patient accordingly. If you're doing combining with ACL, PCL, you can just do it on the supine position like normal. But if you're doing only meniscus, there is more space on the medial side if you use the leg holder. The next thing is the pie crusting. I can't re-emphasize the importance of pie crusting. It's a good technique to save the cartilage from your damage, because you're trying to put so many instruments inside. So do pie crusting. It's a good technique to save the meniscus and the cartilage. So this is normally how we do it. You usually do it at the level of the joint line, just proximal to the joint line. Bansha has actually described it as the magic point. This is a good paper to actually study, read. So if you see, you draw a line along the adductor tubercle to the posterior medial tibia, and then just about 1 centimeter above the joint line, one prick. He says only one prick from posterior to anterior, the joint just opens, and it does work. We did it, and it does work actually. So earlier we used to actually try and do multiple pricks, but then actually one prick just at the right spot opens up the joint quite well for you. Next thing is to make the incision. So you make an incision 1/3, 2/3 along the joint line, above 2/3 below the joint line. This is the space you are looking at between the semimembranosus, between the medial head of the gastroc and the posterior medial tibia. So this is where all your needles are going to come out. Even the anterior most sutures you can easily take out through these sutures. I think Santosh actually takes out the sutures from his hamstring harvest incision. But I mean, if anterior sutures, it's okay. For the posterior sutures, to directly suture here,
this is the best part to actually do it. So once you do that, you need not be very scared about the popliteal artery. It is not going to come in your way even if you are going posterior horn medial meniscus, because actually it's slightly lateral. If you are repairing posterior horn lateral meniscus, obviously we don't do it through inside out. There we use the all inside, but you can do inside out. You have to actually make an incision if you want to do it and go and save the. But what you have to be aware of is the saphenous nerve, because the nerve is actually just percutaneous. You can actually tie the nerve when you actually tie one of the sutures, and it can cause painful neuropraxia. So beware of the nerve's position when you make the this thing. So this is like a three-man procedure here. So one person is holding the scope, one person is passing the sutures. If you have one or two assistants, it's easy, and all three need to know what is happening. So here I have not made the incision yet. I'm just passing the sutures. So one person passes the sutures, other retrieves it, and you clip the sutures straight away. There will be like 10 to 12 sutures, so suture management is important, but it's nothing scary. It's not very difficult at all. So sequence, usually I make the femoral tunnel first, then repair the meniscus, then tibial tunnel, and then graft passage. So make the femoral tunnel, then repair the meniscus, and then tibial tunnel later. If you make the tibial tunnel, then all the fluid is flowing out already, and it's a lot of fluid wastage. So this is the first case, 38-year-old female, left knee pain, medial joint tenderness, no instability, already ACL done. So if you see, they probably done something to the meniscus already, and this is the meniscus left actually. So you can see it's like a bucket handle tear. She's a dentist. She's got locking episodes. So you start from the center. We're starting a little anterior. Then you first put a stay suture sort of thing in the center, and then you keep using the device, and then you can keep going front and back and put as many sutures as you want, and then you can achieve a very stable. This is another 21-year-old male. Again, a complex tear, like a bucket handle tear with an oblique component as well. Again, in any different configurations you want, you can pass. This is like a single lumen device, so you can space it. You can put a vertical mattress, you can put an oblique suture, you can put horizontal. And sometimes it doesn't reduce very anatomically, you don't need to worry about it. It synovializes very well and heals very well. And especially in a young patient, try and hold the meniscus there and immobilize him. In 6 weeks' time, it all heals up. So you can pass a horizontal masses, vertical matters, tibial side sutures, as many as you want, and takes a couple of minutes later to actually just repair it. This is another case. You can see this is again a chronic 1-year-old tear, bucket handle tear, repeated locking episodes. Again, 25-year-old male. You don't want to actually, I think it's better to give an opportunity for it to heal rather than to cut it and throw it away. So again, multiple sutures passed. Give me 1 minute. So he's 1 year down the line, done a repeat MRI, and the meniscus actually has healed. So even menisci which were in young patients which were considered unsalvageable can be repaired very well with this inside out technique. So all the literature supports inside out. Comparing inside out to all inside, now the all inside saves time a little bit, but it's quite expensive, and reduction in operative time they say, but you know, when we use all inside, there's a 30% deployment failure in any type of device, especially in a very tight knee where you're trying to, but with the inside out you don't have all those problems. I think one should master this technique. Outside in is quite simple, so I'm not going to talk much about it. If you want to learn, Bhupesh has got an excellent video on YouTube. I think you should go and watch it. Thank you very much.
Thank you, Karthi. We will have a discussion at the end, and I request Sandeep Braris to speak about all inside repair techniques.
Thank you, Ramakant, and Dr. Sundar sir for this warm invitation. Greetings from Mumbai. So when, as earlier speakers, Dr. Bhaskaran and Dr. Karthik has told principles about the meniscus, so that makes my life very easy. So when we choose which area, so that red area, that's usually most of us tend to do all inside. Blue region can be managed with inside out, and the green outside in. And nowadays, lots of companies have come up with various flexible devices. So almost every corner can be managed with all inside as well. About the stitch, both the speakers have very clearly stated. So the horizontal mattress, vertical mattresses works better than horizontal mattress, but depending upon the tear morphology, you may need to choose the configuration as you deem fit during the surgery. All inside repair usually, it reduces surgical time. There are no external approaches or incisions on the skin, and accessibility to the tears of the posterior horn regions in both medial and lateral meniscus are made very easier because of these various devices. So these are the self-adjusting devices. You can calibrate, you can decide how much depth you want to pierce. So because if you are doing lateral meniscus posterior horn, then you need to calibrate your, pre-decide your depth of penetration. On medial side, it is less, more forgiving. And then studies have shown that the results of the strength are very much comparable. But as the earlier speaker has said, that there is a cost difference is quite a lot between all inside and inside out devices. The advantage which are being, the deployment is very easy. It is very secure deployment. You can see and you can tighten depending upon how much strength the suture has. These are comes in various flexible and various angles. These are low profile, so they do not damage the meniscus much when you are inserting them. And the main tear types which are repair types are like a capsular base. That means you pass the needle through the meniscus and also one other end of the device through the capsule, and you repair this meniscus. The other ones are being meniscus based repair, the all inside, which can be very easy to do on the lateral side. On medial side, it is very difficult, can be managed with the low profile devices like Scorpion, and then you can do all inside repair of the meniscus tears. As Dr. Karthik has very well said, that pie crusting is very important, because if you need to reach that posterior medial corner, then you need to do good pie crusting. And as I usually prefer to do it on the femoral side, the place where the magic point described by Dr. Bancha, but we are not always as lucky as him to do with a single prick. So we make usually one hole and then do the same hole 2-3 pricks, and it very well opens up the joint, and it's very important part when you are contemplating any of the meniscus repairs. When you find the tear, with the help of this diamond rasp, abrade it, or with the help of shaver also you can do. But when diamond rasp becomes little easy, because shaver may eat out some part of the meniscus. Dr. Bhaskar has very clearly said the anatomy, so I'm not going to go into detail. So medial side of the posterior horn medial meniscus is like very easy. You cannot damage, chances of injury to the posterior vessels are very less. But then when it comes to the lateral, the vessels are very much closer to the posterior horn and the root of the lateral meniscus. You need to be cautious when you are using these devices, or otherwise there can be injury to the popliteal artery. On the lateral meniscus, whatever you do anterior to the popliteus tendons is very easy, but when you go behind the popliteus tendon, then you need to be cautious about the common peroneal nerve there. All other thing, as I said, lateral meniscus posterior horn is also, you need to be very cautious. So like as Dr. Karthik has said, not all tears can be, repaired. So sometimes you need to choose depending upon the surgery. This particular gentleman, 32 years male, who injured his meniscus, and he was just being managed conservatively. So when he visited, so now this, by looking at this tear, it looks like as if it is torn, and if we don't know if it can be repaired, though it was very much stable, but there was undersurface type of tear here, as you can see. I'll just run through the, so with the help of punches, I did little more cosmetic correction for these ragged edges. So it makes little more descent now, looks a little more descent. The water free and loose ends have been removed, and now it's like looks like more like horizontal. So whole aim of the meniscus repair is to give stable peripheral rim, because if there is a rim, but if it is not stable, then it is going to cause further damage. And then depending upon location of the tear, rest of the meniscus was looking good. So in such cases, I mean, one single all inside device is enough. So whenever you are inserting your needles or devices, you make use of these spatulas, so that these are the blunt spatulas. So it makes your passage of your device or needles very easy. With the help of this, you just go inside, pre-decide your location where you are going to insert. Now here I'm just putting it through the horizontal mattress fashion, because I just want to use one and cover that area and make it a little stable. I'm not that much fan of doing circumferential stitch and all, because I feel it makes meniscus too much bulky. And once you deploy this, both the devices inside, then always whenever I am tightening, I use probe to give counter traction, and then gently we try and secure to the thread, tighten it gradually, so that to avoid any cheese wiring, because there is no point if you put devices at right position and it cuts through your meniscus. This one another case, I'm just going to quickly run through, because devices are simple. It's a bucket handle tear, so it is not always that all inside devices work very well. So in this particular case, I decided, so first capsular stitch I had taken, so I put it in capsule. Then now I came onto the body of the meniscus. And then while pulling, all of a sudden that thread gets snapped. So these are the things, because when you use one, and then automatically that's the loss to the patient. While tightening, the thread is snapped, maybe some defect somewhere. Then ultimately, with the help of some Indian jugaad, anyway both the anchors have been already deployed. Then with the help of grasper, we just pull it out and tighten it. So somehow try to save that one particular device. So these are various configurations. The flexible devices can be used from different angles. Sometimes you may have to switch the portals if you are not able to access. You may have to take additional portals also, so whenever we are doing all inside or inside out technique, I feel that you first stabilize the meniscus, and if there are wide zone radial fragments, just trim that. That makes life easy and helps in healing the meniscus. Thank you very much.
Thank you, Sandeep. I request Dr. Palnivel Rajan to speak about the root tears.
Good morning, everyone. First of all, I should thank IAS and the Coimbatore team for having invited me for this meeting. My talk will be on root tears. So each meniscus, as Dr. Bhaskar told, has been rooted into the tibial plateau at both the ends. Any tears that is 1 centimeter of the meniscal insertion or avulsions at the insertion of the meniscus, we call it root tears. This tear causes a failure to the meniscus to convert axial loads into transverse hoop stresses, and it accelerates the degeneration of the joint. I don't want to go into the detail of all the attachments, as Bhaskar has clearly explained that. So extrusion of the medial meniscus has been observed in both partial and total meniscal root tears, with extrusion more than 3 millimeter being associated with increased cartilage degeneration and osteophyte formation. So we need to address it accordingly to prevent the degeneration. The changes in joint loading leading to accelerated cartilage degeneration with changes comparable those in following a total meniscectomy has been studied by a lot of people. So That is the importance of root tears. So that acute tears as well as chronic tears. You have acute tears which is very rare. Usually it's combined injuries, multi-ligament injuries we commonly see in lateral meniscus, sometimes in medial also, young athletes. And chronic tears which are very common, they are also almost always associated with degenerative changes in the knee. And the injury is very subtle or just a pop sound they hear when they're getting down in the stairs or sometimes from vehicles, and then after a month or so the pain aggravates. They may get a pain in the joint, or they may get pain in the tibia because of the stress reactions on the tibial surface. So X-ray, you can see some kind of degenerations. In some patients there will be varus malalignment, and very rarely you can see bony avulsions. So MRI is a gold standard. It's very sensitive and it's also very specific for the root tears. You can very well make out, and everyone should always be on an alert mode when you see an elderly patient with joint pain, with pain radiating down the leg. You have, I'll just show you the most important MRI findings. I think Bhupesh has also told. You have the ghost sign, which is the absence of normal meniscal sign in the sagittal plane, which is very important. And also you can see a linear high intensity signal, which is perpendicular to the meniscus at the meniscal root in the axial section. Again, a vertical linear defect on the medial meniscal root, which is called truncation sign, which is associated with the medial meniscus extrusion. This is also very pathognomonic of medial meniscus root tear with extrusion. So all this need to be, we need to make out in an MRI. So as I told, it's benign twisting motion, and there will be some joint effusions, sometimes climbing stairs, standing for a long time is all very common. So some acute onset time pain, which is more severe than other meniscal tears, which will be continuing or will be increasing the intensity. You should always have in mind that there can be a root injury. These are the types which already Dr. Bhaskar has explained. So the medial root tears with medial extrusion may precede a degeneration of the joint rather than the result of this. So we need to keep in mind, and we also need to inform the patient that they are going to a degenerative joint mode. And so you have to be very cautious in telling the patient what to do, whether you need to do surgery or whether we need to do some other procedures, or you need to tell the patient that they're going to proceed to a degenerated state. Again, spontaneous osteonecrosis, which also occurs with medial root tears, which need to be addressed with medical management and rest. And a lot of root tears have the same effect like meniscectomy, which has been studied in a lot of studies, and has shown that they are going to get up too much pressure on the medial side. These are the important things and confounding issues which you see with the root tears. So the treatment modalities restore the joint contact pressures, kinematics, and to delay the development of OA. So non-operative treatment is also a mode of treatment which has been successful in a lot of people, so you need to keep in mind. And then the meniscectomy, which we did in our older times, which is what we do sometimes back like 10-15 years back, which is not done very commonly now. Then root repair. Again, non-operative treatment for lateral meniscus, sometimes you can do with the patient with severe OA, you can manage with. Surgical options, transosseous technique, suture anchor technique, and you can also do side-to-side repair in lateral side. So this is a case, as I told, that she had a fall or just sudden pop sound on the knee, and after that she started getting pain. I'll just show you the surgical video of this. So you can do a pie crusting to see the real the tear part, as well as you just debride that area to make it raw so that there's some vascularity in the area, and then you just try to pull it to see if you can mobilize this. This is very important. If you're not able to mobilize, you may have to do a little release, and you have to do some more additional fixation. So once this is done, then the first thing I do is I always take the sutures first, Lot of times I prefer to take cinch knot because to prevent cutting through of this little degenerated tissue. And once you take 1 or 2 sutures, then you can prepare the site where you want to make the tunnel. There are special jigs available. You can also use an ACL jig to do this tunnel. Once this is found out, the next thing you need to is you have to protect the tip of the wire from going back, which is very important. So just use a scoop or something to cover that one, and then you start drilling with a 4.5 drill bit, so that it will be very convenient for you to take the sutures down, and you can put a button which will sit on the tibial side. Just 10 seconds, we'll finish up. So just make a drill hole, and once you make this hole, then you prepare the chondral surface around the tunnel for better healing. And then you can pass an ethanol wire or something. You can take the wires out. See that you don't have a tissue bridge in between. That is very important. So once this is done, then you take both the sutures through the hole down, and after you're confirming that you have pulled the meniscus right into the tunnel, I always put one on the anterior side and one on the side so that it goes into the tunnels to get a better healing. Once this is done, then you can use a button. You can use, I don't use a sliding knot because that aberrates and sometimes damages the meniscus. It's a little brittle meniscus when you compare to the normal meniscus, so you should avoid damaging the sutures. Once this is done and you're fixed, then your surgery is over. This is the post-op X-ray. I'm not going to the second case because of the time. So non-weight bearing is very important for up to 6 weeks, and then you can start the range of motion in the first week, end of the first week, and then start slowly strengthening exercises. You can rehabilitate the patient. At the end of 6 weeks, you can allow the patient to walk. The results are always good. Usually medial meniscal root tears are subtle and easily missed. That is very important. Consequence of non-diagnosis, or like you are allowing the patient to go into a severe degenerative mode, and osteochondral defects also starts appearing. So always suspect medial meniscal root tear when you see a patient with a degeneration and joint pain. Thank you.
Good morning everyone, welcome you all for this IAS 1, and I thank Armugam sir and Sundar sir for this opportunity. So my talk is on radial tear. So I'll be speaking on the types, classification, identification of the tears in the MRI, the repair techniques, and the salvage of the radial tear which is converted into root. So the radial tear is nothing but the perpendicular orientation to the meniscal axis, disrupting the circumferential fibers. It can be traumatic or degenerative. It's a very simple classification, 3 types. White zone is a type 1, type 2 and type 3 in the red-white and red-red zone, and type 4 and 5 is nothing but the amount of gap between the radial tear. So other classification based on length and shape is the simple radial tear, which extends to the periphery, and it can be a flap tear or a L-shaped tear, or with extending to the peripheral rim and with a bucket handle tear. So the other complex radial tears are the L-shaped tear and the T-shaped tears. So the MRI is used to identify these radial tears, the truncated sign, the cleft sign, the marching cleft sign, and the ghost sign. So when the section passes through the tear, it appears as a truncated triangle sign, and the section is perpendicular. It shows as a cleft sign. It can be seen in the different coronal and the sagittal sections, and the marginal cleft sign in the 3 different consecutive sections. We can see the marginal cleft sign, and of course the ghost sign when the tear is in the red zone. So the type 1 tears, it's incomplete radial tears. Only the white zone is involved, so we can just trim it, and the type 2 and type 3 tears, which is extends up to the periphery, the horizontal mattress fashion needs to be put for these tears. So there are 3 techniques to do it. One, we can do it with all inside all suture. Just take the bites across the tear and then the horizontal configuration can be done. Or we can also use the inside out technique where we can pass it, if it is in the body region, we can pass the inside out needle and then tie it outside the capsule like in this fashion. Or we can use all inside devices, commercially available devices, where the implant will be deployed beyond the capsule and then the repair is done. So some of the case example, this was kind of a complex L-shape kind of tear. So first the side to side repair was done for this, and we can see as we tighten there invariably happens, it's very difficult to control that fragment, that overlap. So the inferior fragment can be excised in this fashion, and then the tear is approximated, and then to fix it to the capsule we can use the inside out device, and then as we tighten we can see that approximation, and then the C-shape configuration is recreated. So we can use a combination of techniques, that is side to side as well as the all inside devices can be used. This is another type of radial tear where the cross stitch configuration which provides more stability for the repair. So first the side to side repair was done, the approximation, we can see that there is a good approximation, and then this needs to be fixed to the capsule because invariably the T or L-shaped component would be there. So to fix it to the capsule, we can use the all inside device, and we can make it like a crisscross, and then then the approximation gives a good stable kind of a repair, and small overlaps in the white zone can be excised, and this forms the completion of the repair. This is a arthroscopic picture of the radial tear and the cross fixation. So when there is a type 3 tear which is extending peripheral, and there is not much displacement, and it is across the body, we can do a hashtag configuration kind of a repair. The hashtag, or it's also called as cross tag or rebar or a tie grip kind of a repair, where the vertical sutures will approximate to the capsule, and the horizontal sutures will approximate the meniscus. So this is a type of tear where the patient had a kind of a partial discoid meniscus. The inner portion of the anterior part of the meniscus was trimmed. So here we can see that trimmed so that we can get the C-shape kind of configuration after the final repair, and then the inside out repair was done for this. So you can see that this is a popliteus tendon. The repair is in the body, radial tear. So the horizontal sutures were inserted first, and then the vertical sutures. So that gives the approximation also to the capsule, and then tightening will form a stable kind of a repair. So this forms the hashtag kind of a repair. So once we tighten it, and that forms a stable repair for a radial tear. So radial tear needs multiple sutures for a good approximation. So all inside all suture device using the Scorpion causes less damage to periarticular surface, and whenever there is a more than 3 mm gap is there, the reduction stitch or the meniscal releases needs to be done, and then the repair can be completed with the hashtag configuration. So another tear, this patient had a little bit poor medial component. First we try to do side to side repair with the knee Scorpion, and every time it used to get pulled out, and every bite got pulled out, and then there was a cutout, and then the meniscal, as we tighten here, we can see that it is getting cut out. So the meniscus becomes more fragile. So the small flimsy fragile was excised in this case, and then the gap was more than almost 10 mm gap was there. So for which we planned for a root reconstruction. So first the transtibial tunnel was drilled, and then the gracilis graft was harvested. It was passed through the medial fragment in this fashion, and then the sutures were retrieved through the tunnel, and both the sutures were passed, shuttled across the tunnels from the graft, and then pulled it through the tunnel, and then the gracilis reconstruction was done. So this is a salvage procedure. When there is a very flimsy medial fragment, then we have to excise it, and then the root reconstruction needs to be done. So the take-home message is radial tear. It is through the meniscus, needs a robust fixation. Repair depends on the tear morphology. Simple tears, side-to-side repair, all inside devices can be used, or inside all the combination of techniques can be used. For higher grade tears, repair provides stable fixation, and poor tissue quality root reconstruction may be needed with a graft. Thank you.
Thank you, Ramakant. We'd like to invite Dr. Dinesh for his talk on ramp tear.
Good morning. At the outset, I'd like to thank the organizing team for this opportunity. Going to the topic, ramp, a few words about the anatomy. Here you can see the capsular branch of the semimembranosus that gets attached to the posterior horn with expansions above so-called meniscocapsular and below meniscotibial ligament. So, and there is some loose areolar tissue behind that middle meniscus. So what is basically ramp? It's a peripheral longitudinal tear of the posterior middle meniscus at the meniscocapsular junction with or without meniscotibial ligament disruption. So this is the mechanism of ramp lesion. Whenever there is anterior tibial translation, the ACL gets torn first. With continued internal rotation, ALL tear happens, because of which the knee gets translated anteriorly. So this is the capsular branch of the semimembranosus. It tries to reduce back the translated knee. That's when the ramp occurs. This was a study published by a Santi group. The main reason for ramp is because of the contraction of the semimembranosus. So if we are unidentifying and untreating these lesions, it can lead to rotational instability and ends up with excessive anterior translation, so leading to graft failures, ending up in accelerated degeneration of the medial compartment. So the incidence is about 12% in ACL deficient knees, particularly in males who are less than 30 years. Some of the risk factors being patients with high grade pivot, we have to suspect ramp lesions, and particularly if the patient has any bone condition in the posterior tibia, which is evident with MRI findings. There are certain, these are also variable risk factors. MRI, we can find out some fluid signal changes and irregularity of the posterior medial meniscus, but the most important finding is bone brewing in the posterior medial tibia. The sensitivity is low in MRI because the most of the MRIs are done in extended position, because of which there is no much capsular separation. That's why MRI is not able to pick all the ramp lesions. That's why ramp is often termed as mislesion, because it's not evident with MRI. Even with routine anterior arthroscopy, we cannot find it. So as Dr. Harish Kumar was mentioning earlier, we have to go and look for the posterior medial compartment in all the cases when you are addressing ACL. So few tips and tricks how to enter the posterior medial corner. So this is a case of bilateral middle meniscus. Once it's reduced, using the Gilchrist manner, we have to go in the triangle between the PCL and middle femoral condyle. With gentle push, we can enter the posterior medial compartment. It's not possible in all the cases, particularly if the knee is tight, even after debridating the PCL, it's tough to enter. In that case, we can change the portal, pass the Isinger rod from anterolateral, go away all the down, to the posterior compartment, then we can pass the scope and sheath to visualize the posterior compartment. This article by Soneri Kote, where he mentioned out of 302 patients, he identified about 75 meniscal tears, the classical ones with the anterior probing. But once he entered the posterior compartment, he identified additional 29 ramp lesions, and he didn't stop with that. With probing, he could find out 21 hidden lesions. So according to him, step 2 and step 3, he could identify 40% of ramp lesions. That's importance of exploring the posterior compartment. And this is the needle test. We have to go just above the hamstrings. With the help of translumination, we should avoid injuring the saphenous nerve and vein. With this needle, we have to just probe and see. We have to always look for these hidden lesions. So this is a classification given by Thonat, as mentioned by Sir Bhaskar. The first type is a meniscocapsule junction tear, more of the synovial region. The second is a partial superior tear. As you can see, just the upper meniscocapsule ligament has torn. Type 3 is partial inferior, also called hidden lesion. With clinical suspicion, we have to debride. Unless we debride, we won't able to see this type 3 lesion. Type 4 is the classical ramp through and through at the periphery. You can see the capsule has gone down, exposing medial tibial condyle. And type 5 is double tear, both involving the posterior ramp part and in the meniscus. So coming to management, type 1 and 2 is stable. We can very well manage with trephination and abrasion, which allows good healing. Type 4 and 5, 3, 4 and 5, it's unstable because of the disruption of the meniscotibial ligament. So type 3, so-called belt lesion or degeneration, we can go ahead with all inside repairs because the capsule is already in place. Whereas in type 4 and 5, which has gone down, we have to bring it back to the joint line with the help of ramp lasso, like we do in Bankert repair, sometimes with knee scorpion. These are the criteria for unstable ramp. Not all ramps need to be treated. If the size is more than 2 cm, exposing the tibial condyle surface, and if there is more than 5 mm displacement in your probing, particularly during flexion extension, and particularly type 5. These are all unstable ramp which has to be addressed for sure. This is just a case illustration. Here this is the right knee. We are going to the anterolateral portal. As in every case, we have to prepare the surface for healing, first with the rasp and followed by shaver. This is a 25-degree lasso available in Orthrex. The advantages we can take as a single bite all the way from the posterior capsule from the meniscus. And then we can use the ethylon to shuttle the size 0 fiber wire. Avoid pausing sliding knots to avoid abrasion. Once the knot is cut, it's better to go and visualize from the posteromedial portal. Here we can see the first bite. We need additional 1 more bites. Ideal to start from the medial and go towards the center. The second bit is repeated similarly. This is the, just for completion's sake, this is the video by Dr. Sheetal Gupta where he used scorpion using 2 portal technique. The first is the pass, park and tie, where he used 3 different fiber wires, and after every bite he pass and park in the anterolateral portal. Similarly, like he used 2 second and third bite, whereas in the shoelace technique, using a single fiber wire, he alternately took the bites either in the meniscus and capsule alternately, so that at the end he gets a robust repair. So my take-home message is ramp lesions is quite common in all ACL deficient knees, at least 1 to 2 cases per 10 knees. So posteromedial portal exploration is must, and soft tissue debridement might uncover hidden lesions. Fail to diagnose ramp and or inadequate repair can lead to ACL graft failures. Thank you.
Any questions from the floor? I expect some questions at least. So I'll ask questions.
For a radial tear, sir? Yeah, definitely we can do. So just put it across and then we have to do the tunnel and then we can do. When what they suggest is when the gap is more than 3 mm, So additional side to side and the radial tear. In the classification in the figure itself, we can see that we can do one transtibial tunnel, and then needs side to side and as well as one more stitches through the radial tear will give a good approximation to the bed.
Ramakant, very nice talk.
Yes,
But the one you showed using Gressel as a
yes, sir.
salvage procedure, it's been published in the literature how the Gressel will act as a meniscus or any other experience. How?
In the literature, it just adds as a collagen tissue to get the meniscus and then heals in the bed, sir. So basically, it is just a filler tissue. So the meniscus functions is restored. So of course, it definitely doesn't give full hoop stress what the root repair would give, but then it is better than the completely there is a defect. So the hoop stress is not completely restored in these cases, but at least will restore some meniscal function. That's a biomedical study which is published.
Published, okay. Very interesting because there's a tendon, how is it going to replace the meniscus? Yeah. Another one thing is
because now now they are using the semi-TS meniscus allograft.
Okay, that is
so yeah. So semitendinosis. So people are using as even allograft, claiming it's healing well. So, but still, we don't have the long-term results, but the reports techniques are coming like that.
So I also request to add one talk on the meniscectomy and meniscal balancing. I don't want the delegates to go with the idea.
And already,
yes, sir.
Bhaskaran
sir. Sorry, I was not.
So my question is to Bhaskaran. What is your indications of a partial meniscectomy in degenerative kind of cases? Patient comes in the older age groups with your indications for him, because many patients osteoarthritis, patients comes with the MRI with the horizontal tear, radial tear. So what is your indications when to do a meniscectomy? Role of arthroscopic meniscectomy in osteoarthritis?
So as far as meniscal repair is concerned, traumatic tear heals well. So in the degenerative tear, the healing is not that good. So you have to assess whether there's already arthritic changes are there. No, it's not going to improve if there is any mechanical symptoms. Mainly in the degenerative meniscal tears, if there is a mechanical symptoms, then that's where that the meniscectomy is already indicated. But that too, if there is a root tear, if you repair that, definitely it will reduce the progression of the arthritis. But how far it's going to symptomatically to improve, it is very difficult to say. But the repairing meniscus in degenerative tear is always, it's not a...
Only meniscectomy. So some through the inside-out technique. And what is your tips and tricks to avoid the failure of all inside? Because each one is 20,000 rupees. So your tips for the audience.
So now my choice for the treatment is always inside out, whatever it may be. I never put more than 2 all inside, even if it is bucket handle, and all inside is mainly for the posterior. So the chances of failure I have noticed in my hand more on the lateral side, because lateral side I am very skeptical to push it too much inside. So we usually keep it 16 or 18. But on medial meniscus posterior horn, I mean, like, I'm not scared, even though with that 20 millimeter depth we can go. If you go too much deep inside, chances of failure are less. But if it is like less than 16, the pull out from the capsule is, that's what I have noticed. And even from the meniscus fragment.
And also you mentioned in your talk also already you mentioned about the all inside technique. When you have the 2 or 3 important is, one is the pike resting. So make sure that you have enough space. The most of the failure happens when you insert the your all inside device, which against the femoral condyle gets bent, it gets failure. There also can fail. So one is the pike resting. Second is you have to go as perpendicular as you can. So make sure that you make a needle incision to make that perpendicular to your tear. So if it is not there in your portal, then you make an additional portal. That's Sandeep also mentioned in the talk. So you make an additional portal, make sure that you go perpendicular, your device doesn't hit, so make a probe and go insert and see that it doesn't hit your femoral condyle. So nowadays we have even good flexible all inside devices have come. So if you think that it is hitting, then you can use that, even the flexible all inside devices. So these are 2-3 tricks which you should always use when you use all inside, because they are very costly.
can't operate with only one portal.
Yes, always you have to switch the portal. I think that is also Sandeep mentioned. That's why you have to make sure that you are going through the perpendicular to the tear. If you are not perpendicular, then make an additional portal either medial side or a lateral side. That is the
Another interesting thing, want to get your opinion. You have two different scenarios. One is a meniscal tear with a ligament injury, isolated meniscal tear. These two are two different entities where one happens because of the instability, other one is other reasons. There are so many reasons why they get. The second one is how to approach an elite athlete with a meniscal injury and a software engineer with a meniscal injury. You can't go in the same way for both of them. What's your experience like? You have any different ideas for top-end athletes, for hot athletes like Djokovic? He had a meniscal injury. He got it meniscectomy.
yes.
So in high athletes, you have to be very, very careful when you go for repair, because the high chance of re-tear. If they have 2 times or 3 times re-tear, 2-3 years is gone, then the career is gone. So you have to think twice when you have a high-end athlete. You have a red-white zone. Always, my choice is to do a meniscectomy. We have a lot of kabaddi players, pro kabaddi players coming up with this kind of injuries. We don't repair that. If you repair and they go and play, they get back. If it is with an ACL or with a PCL injury, then the chance of healing is very high. But if it is happening without any ligament injuries, if they have a meniscal tear, horizontal tear, the chance of healing is very less in high-end athletes. So that's my thing.
Yeah, we all agree. I mean, we just do, our job is to just counsel them. So we have, but you have to counsel them. So but if you do a repair, it's going to take a long time. No, they may miss the session, and the whole season they may lose. They lose a lot of money. For that also they prefer for the meniscectomy, and they want to go back to the sports immediately. So when you do a repair, then it is going to take 1 year, and if you say a 20% chance of failure, they don't want to take it. So they want to do a meniscectomy. That happens to all the European football team members who gets injury. I think same thing we should also do that. We can counsel that it's a patient has to choose whether to do a meniscectomy or a meniscus repair.
So one question, sir. For a chronic root tear, when a patient comes and when we try to get the extruded meniscus to the anatomical position, when we are not trying to, when we cannot get the meniscus to the anatomical position, what should we do in those cases?
Root repair. Talk.
So in a chronic root tear, when we are not able to get back the meniscus to the anatomical position, so what do we do in those cases?
Yeah, 2 things. One is you see what is the status of the cartilage, medial joint. If it is severely degenerated, or if there is a lot of alignment issues, the first choice would be to correct the alignment. And you can leave the root tear as such. It won't have any big detrimental effect if you do a H2O, if you are not able to do a repair, but you have a good lateral condyle. The other thing is that you can release to some extent, and if the cartilage is good, then you can release, and then you can put an anchor, and you can stabilize the meniscus in the middle, and then you can do a repair. You can just medialize little bit, but you'll have some meniscus which will have some effect on the weight bearing. But if there is lot of degeneration one side and you have a good cartilage in the other side, there is slight malalignment, it's always better to do for a correction. Suppose the patient comes before 55 years, you just look for the alignment correction. That will be a better option, because if they come after 65, if there too much degeneration, patellofemoral degeneration, then you can treat them conservatively and then go for a TKR in the later stage.
To add on that, that means we are not able to repair the root repair. That means your indication itself is wrong. You know, the selection of case for the root repair is very, very important. So if you think that if you go inside, then the root is not repairable, that means that patient is not an indication for a root repair. So that means that established osteoarthritis or chronic root tear. So both will fail. So the root tear will only sustain, a repair will sustain only in a younger age group. If it is a grade 2 or maximum grade 3 osteoarthritis with the sudden onset of pain, with the sudden onset of root tear. So the patient, that clinically you have to ask all this history to diagnose. So what kind of pain? If the patient got already 2 years pain and MRI shows a root tear, and if you go and do a root repair, it will fail. Because that will not heal, because it's torn 2 years before. So unless this patient is as Palni said, that the patient has got a malalignment, but a chronic root tear, again there is no point of doing if you're not able to root tear, just do osteotomy, it's more than enough. So otherwise, most of the root repairs, the indications are when you have an acute root tear, then the chance of healing is bit high. In younger patients, the alignment is good. If the grade of arthritis is grade 2 or 3 maximum, then that patients, it can heal.
And in Laprade type 2, when it is more than around 9 mm, do you use a side-to-side stitch, or you get back the remaining part of the meniscus to the roots?
Root, for the tunnel technique?
Yes, sir.
So I think that you suppose if you have enough root and the attachment level, if you are able to do, sometimes you can do a side-to-side repair. We can do even use all-inside device. Also can do we can do a multiple 2 or 3 stitches on that. But definitely, if you think it's very small, then better do the pull-out technique, which is more biomagnetically more stable also.
Thanks.
Thank you. I think we are running out of the time. We can go for inauguration.
The chairpersons to felicitate our faculties. First, Dr. Bhaskar, sir. Dr. Karthik Selvaraj. Dr. Palnivel, sir. Dr. Palnivel, sir. And Dr. Dinesh Chidambaram. Now we'll proceed with lamp lighting. May I request our IAS President, sir, Dr. Armugam, sir, to the stage, and Sundar, sir, and Sandeep to stay in the stage. May I call Dr. Divya, sir, for the inauguration. So we'll proceed with the lamp lighting. So may I request all the faculties to honor this occasion with lamp lighting.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापं सन्ध्यादीपनमोऽस्तुते ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः.
So thank you, sir. May I request Dr. DVS, sir, to have a few words for us.
My hearty congratulations to the Indian Arthroscopy Society, Tamil Nadu Arthroscopy Society, and the office bearers. So, especially to Dr. Armugam, Dr. Sandeep Birares, and others who are present here, Sundar, and all the office bearers. Because earlier we had only one meeting a year, and now we are having regional meetings. I'm certain that that helps a lot of the newcomers and beginners to take up arthroscopy. So don't stop with these talks. You must go on the cadaver and then do your work. So recently, two very interesting papers from members of the Indian Arthroscopy Society, as well as especially the Tamil Nadu, two interesting papers which really make the industry wake up. The one is by Ramakant and Sundar, saying that suture tape augmentation is not that very great. That's a really industry shaking paper. I congratulate you on that, and I hope everybody reads it, and that will we're going to make a lot of difference for the industry. And another paper is by Sham from our hospital, and that is emphasis on transosseous repair of the cuff. So which again, you eliminate the number of anchors you use, and thereby help our population to do an economical arthroscopic transosseous repair, and that also is a very good repair that makes this a trendsetter and makes the industry think. And the youngsters and the beginners are here, so don't be carried away by the industry. And they may tell you a lot of things, and what you read, and you talk to the seniors. Is a very good opportunity where you can talk to the seniors who have a lot of experience, and also resist temptation to get the industry guys to come and do the surgery. I recently heard that even seniors in big hospitals also get the technicians from the various companies do the surgery. Resist it. Only the Indian Arthroscopy Society can do it. I wrote a letter to the then president some time back and received no reply. And unless there is some whistleblower calls it, I mean, don't wait until then. Before that, the Indian Arthroscopy Society must put an end to this. So, congratulations to Indian Arthroscopy Society, Tamil Nadu Society, and my very best wishes for all those who are participating, and welcome to the arthroscopy fold, and do a lot of cadaver work. It is so easily available now, and my best wishes to you. Thank you.
Thank you, sir. May I request our IAS President, sir, to address the President's address. Thank you.
Respected Dr. David Rajan and my dear friends and colleagues on the dais and off the dais, it gives me immense pleasure to welcome you all for this another edition of IAS1 at Coimbatore. The presidential theme during my tenure is bridging the boundaries. So with that ambitious motto, we want to take the arthroscopy to every nook and corner of India, so that the arthroscopic surgical technique is available to all the young orthopedic surgeons, and ultimately the common man gets benefit for us. And we started about 3-4 years ago, but it got really amplified during my tenure, and certain days we'll have at least 3 or 4 IAS1 on the same day on the different zones of country. So I thank the members overtaken it so actively, and it has really served the purpose of creating more faculties and more interactions and more to the basics. Whenever we talk about as wise words by Dr. David Rajan, don't carry it away with all these meniscal repairs and all those things. Still, basics are important. That's the main role of IAS 1. So it is very satisfying to see. I think it may be a 20th or 25th program in this academic year of my IAS 1. And I take this opportunity to welcome the new members to join the IAS. It has become now 4,000 plus strong association. A lot more opportunities are available. We have increased the number of inland fellowships. Dr. Gopalakrishna fellowship was there, but now we added, thanks to the IAS Con last year, which gave 1 crore to the IAS. We created more fellowships, so young arthroscopic surgeon can avail these fellowships and train inland. Also, we have opened more new centers, accredited centers by IAS, so you need not travel far off from your homeland, home city to learn this technique. And also we are working on getting some new international fellowship, especially very soon we'll be launching the IAS and ESCA fellowship, traveling fellowship. And one more thing is the IAS registry. See, we use do a lot of surgeries, a number of surgeries on par with any other international international center, but we don't get the same amount of respect because we lack scientific data. So unless we document, you won't be able to produce papers. So we launched this IAS registry, and which is on par with international rating, and the data will protected. More than anything else, will be your own logbook. Like people working in centers like teaching institution or big centers, they have a supporting staff to maintain your log. But people who are on their own, you can make this as your own logbook, and I request all of you to use the registry. And already about 5,000 cases have been documented. Very soon we'll be launching the shoulder registry. So again, I congratulate the organizing team for putting up this good show, and also the trade industry for supporting this, and wish you all a very fruitful learning experience. Thank you.
So thank you, sir. So we come to the end of inauguration. So let me complete the inauguration with a vote of thanks as well. Oh, sorry. So first we'd like to felicitate all our faculties in the dais. First we'll Armugam sir to felicitate Dr. DVR sir. Armugam sir to Sandeep Piraris. DVR sir and Armugam sir to Sundar sir. Dr. DVR sir to Armugam sir. Santosh sir.
Yes, Arumagam sir to felicitate Dr. Ramakant.
Thank you, sir. So we'll conclude the inauguration with a vote of thanks. So first, I would like to thank Dr. Armugam sir and Dr. Sundarajan sir for giving an opportunity to Coimbatore to host this IAS 1. And also, I thank and Santosh Anand and Dr. Bhupesh Karthik and Dr. Terence for helping us in preparing this agenda and setting up this live surgeries. So, and also I thank the industry for supporting this event to make it a successful one. So I thank one and all for this. Hope you all have a good time in learning and take back home with a lot of good messages. Thank you. Thank you all, sir. We'll continue with the session. One second. So we have from Armugam sir, we have one request for the Indian Ligament Registry Society. So we'll just play that video for all the viewers.
We all know that the number of ligament surgeries being done in this country outnumber that in many other parts of the world. I think this registry will help us understand the trends of ligament surgeries that are happening in India and help us in bettering our outcomes in the long run. The Indian Ligament Registry will help Indian surgeons showcase their work on the world stage. Dr. Armugam and his team needs to be complimented for the exemplary work that they have done for the Indian Arthroscopy Society. By setting up the ligament registry, I think they have notched up the game by a couple of points. I again compliment the IAS for setting up the Indian Ligament Registry.
So we'll continue the ACL session next. So I call upon Dr. Karthik Chitartha and Dr. Priyan TP to chair the session. Please take this. start off.
Good afternoon, everyone. I will call Dr. Bhupesh to present on ACL graft harvest techniques, bone patellar tendon and central quadriceps tendon graft.
Good morning, one and all. So I will be talking on BTB harvest and CQT harvest. We'll directly go into the video. So you try to make a oblique incision like this, because a midline incision will cause kneeling pain, and once you do an oblique incision with the help of skin hooks, we try to start going vertical after that. So the skin hook here will pull more and the skin hook here will pull more to make a oblique incision into a horizontal dissection, vertical dissection further on. So once you do that, the structure you see is the paratenon. Once you see the paratenon, make a gentle nick with your knife and then take your medicine bump scissors and then open the paratenon vertically, superiorly and inferiorly. You can go all the way till there. And inferiorly, you can similarly go and clear the paratenon. Vertically split the paratenon. This paratenon which you are splitting has to be repaired after your graft harvest. So be very gentle with your dissection. This has to be repaired at the end of your graft harvest. Once you retract the paratenon, you will see the tendon. The knee is in 40 degrees of flexion now. In this, you can do a mobile window technique and see it up and down. To harvest the graft, you will have to hyperflex the knee because you have to put the patellar tendon in tension, and only then you can cut the fibers parallel to each other. So take a sharp 11 blade and through a single cut parallel to the fibers, make a incision. We try to take the central 10 mm of the graft, and with a single cut you have to come all the way down, otherwise you will be losing fibers which are cut in halfway. After that, you again put the knee in 40 degrees of flexion. In 40 degrees of flexion, with two good Langenbachs pulling down, you can expose the tibial side very well. Now pre-drill with the 2 mm K wire 3 holes so that you don't have to make holes after your harvest to pass your ethibond. It is important to put 3 holes because once you fix the femoral side, you have to pull the tibial bone plug to fix your tibial interference screw. So it is important to have 3 holes here. Now take your oscillating saw and then start going with single cuts like this. Start off at 45 degrees, and as you reach superiorly, make it more and more vertical, and that completes your graft harvest in the tibial side. Take an osteotome only to deliver it. You should never do banging with the osteotome here because you don't want to disturb your graft here. Take a huge carcass and then gently pull the graft downward for it to detach. Don't start pulling it upward directly without pulling it downward first. If you do that, you will break the tibial tongue, which is a very important part of the graft. This part, which is the non-articular anterior tibia, which is to be harvested along with this. This will prevent your graft tunnel mismatch, because many times with patella alta, all your graft will be inside and the bone plug will be outside. So it is very important to harvest that part of the bone. Now you bring it into full extension or even hyperextension, and then use Langenbach's to pull the skin up. Now this is called the mobile window technique. In the same incision, now you can expose the full patella, again outline the amount of graft you want to take. If you are doing the transportal technique, you have to take around 18 to 20 mm of patella. If you are able to achieve anatomical ACL with modified transtibial technique, you can take 25 mm to 30 mm of patella. You here make a single hole in the patella, pre-drill, as I said. Don't make a long hole and then violate the intra-articular part. It has to be only around 1 centimeter. Now these are called the initiation cuts. So you make cuts on both sides and then start bringing the saw from the superior inferior direction. First you went horizontally to initiate the cuts, and then here. This has to be again 45 degrees only, and once you finish the side to side cuts, make sure you don't make multiple cuts. It has to be a single line cut. Then take your final cut, which will be your transverse superior cut. If you have done a proper graft harvest, with a 11 blade, you should be able to just lift off the patella. Don't use osteotomes on the patellar side, even to deliver. And then remove the fat gently. Don't make a big hole in the anterior fat pad, because during arthroscopy, water will keep leaking out of it. And as you pull it, usually the graft will come out. So you have taken a good 100 mm of graft with a small incision, which is maybe the size of STG or a little larger than that. It is never big. So, but you have taken a good graft here with the tibial tongue. Now, this is Santosh's talk, because he's gone for life surgery. I am doing it for him. This is the CQT harvest. Again, the important points here is the tendon should be in tension when you are harvesting. There are two types of grafts that you can harvest. One is the partial thickness graft, the other is the full thickness graft. Santosh is showing you the full thickness graft here. So make a vertical incision there and then dissect out your full thickness graft. It is a good idea to take a bone plug when you are taking full thickness graft, because with full thickness graft you might only get around 8 or 9 mm of 9 centimeters of tendon, and if you take 1.5 or 2 centimeters bone graft, then that will act as your femoral fixation. So once you see the fascia, do vertical cuts as we did in the BTB. You can use your medicine bomb scissors to get some more length by pushing it inside like that, and make sure you have taken the full thickness with your right angle forceps. And then go in and complete your graft harvest with this. Okay. It is important to close this part later, because your knee arthroscopy again will be difficult and water will be close coming through. If you want to do in robust, well-made people, you can do a partial thickness graft, wherein you can take your local tendon strippers, the bigger ones, which are around 8 or 10 mm size, and then elevate the partial thickness, and then you can slide it along the thigh to take your partial thickness. Here you are not going to violate your knee. And then with the graft, with a saw, you will be finishing your graft harvest. The final cut is always important to make sure you don't go intra-articularly in the superior pole. You do a transverse cut to harvest this part of the graft. So, and that's how you tie it. You can either do with a bone plug and put interference screw, or if you are taking partial thickness, you can use your suspensory loops and then do the surgery. Thank you.
Thank you, sir. It was a beautiful demonstration of both PPTB and CQT grafts. Next, I call upon Dr. Narendran, sir, for his talk on hamstring and peroneus extractions.
Good afternoon all. At the outset, I thank the Indian Arthroscopy Society and Tamil Nadu Arthroscopy Society for trusting me with this opportunity to give a talk on hamstrings and peroneus longus autograft. I think this is the first procedure in arthroscopic practice which in beginners get an independent chance to do. So I think with the permission of Chair, I take some time to elaborate on these steps a little more. So going ahead. So I'll start with the peroneus longus talk, which is a little easier to do, and it is more recent in the block, and most surgeons try to prefer it as a first choice of graft. But I think the indications should be more specific. There's no rule book, but we should have more respect to hamstrings, still which we are, it's difficult, but still we have to follow the peroneus longus as a reserve graft. And we use it for multi-ligament knee and ACL reconstruction female obese females, and when you have hamstring graft amputation. So I start with this technique. So I follow 1, 2, 3, 4 rules, and first mark the fibular head and the lateral malleus, and mark 4 finger breadths from the fibula head. So this is to avoid passing the tendon stripper, to avoid common pelvic nerve injury. So from the tip of the lateral malleus, 1 centimeter posterior and 3 centimeters above, we make a 2 centimeter incision. So why 3 centimeter is, there is a retinaculum which holds on to the peroneus brevis tendon. So we should not cause subluxations. So that is the important thing. So 3 centimeters from the tip of the fibula. So we can directly, when you invert the foot, we can find the tendon stretching. So that's easily palpable. We can just make the tenotomy, not the tenotomy here. The paratendon can be cut and directly pass a curved mosquito, and we can identify the peroneus longus tendon, which is the most first structure here. But it is always good practice to identify the second tendon, which is muscles are covered over the peroneus brevis. So identify it first, the tendon which is beneath the peroneus longus, so that we don't get into the wrong graft. So confirm it, and then we can put a ethibond over the peroneus longus tendon which you have identified. So peroneus brevis is identified with more muscle belly over the tendon in this particular area, whereas peroneus longus has pure tendon attachments over there. So pass over the ethibond, and you can secure it, and now you try to invert the foot to maximum so that you get extra bit of length of tendon that's more distal. So we can see how much of excursion is there. So almost this gains around 3 centimeter of the length of the tendon, and we can just snap it. So I usually do not do tenodesis of this stump to peroneus brevis. So even Professor Bancha has said that it has its own isometric way of fixing into the peroneus brevis. So why we do it? And while getting into the paratendon, first enter vertically, perpendicular to the graft, and then underneath the paratendon, keep your assistant, ask the assistant to keep your fingers where the level is marked, and you can pass on the stripper. So it is easy, and I directly suture with the ethilon. You don't have to do subcuticle closure over here. So advantages is the consistent size and simple and cosmetic, and still we have to take it with a pinch of salt. Certain donor site morbidity do exist, but which may not happen in common people, but in sports persons we do have to consider certain biomechanics are being altered there. So hamstrings is the first common thing which we tend to do it in our practice. So anterior methods, anterior vertical incision and anterior horizontal incision is there. Sometimes posterior harvest techniques also are there. So this is the traditional method where the vertical harvest method is being used here. So we make a 3 centimeter incision between the tibial tuberosity and the posterior medial of tibia, and here it is important to erase the fat over the sartorius fascia, and that's important. We can find the bump over there. When you feel the bump, over the bump make the first transverse incision, and the vertical incision is to be made closer to the tibial tuberosity here. So in this case, this is the sartorius fascia along with the tendon and the periosteum which we are cutting here. You will get a flap. So beneath this flap you will be able to identify both the tendons. So it's clearly, and while making the dissection, it is important that you don't dissect too medial, because the MCL you may start erasing the MCL. So one careful structure you need to be very careful of at that particular junction, and the tendons are visible, and you can pass your right angle strippers, artery forceps, and you can take it out. And that's how we take this in this anterior vertical harvest.
So yeah, this is advantages. It's easy to identify, most commonly followed it, and disadvantages, you can't do an isolated semi-tendon harvest in this particular method. So my preferred technique is anterior horizontal harvest, where the incision is the same between the tibial tuberosity and the posterior medial part of the tibia. Again, we clear the fat over the sartorius fascia, and actually the sartorius fascia, you can hold it with your forceps and you can pull it, and you can feel the bump. And here is beneath the sartorius, beneath the bump, you need to make a transverse incision over the sartorius fascia, and you open that window, and you will be able to put a retractor inside the window, and you can see the tendons directly. An important thing here is the sartorius fascia and the underneath tendons need to be separated, and you can put a right angle artery forceps and you can deliver the tendon out. So in this technique, you can do an isolated semi-tendon harvest here, and there's very less chances of causing MCL injury in this particular technique. So the rest is you pass the ethibond and you can do the harvesting with this normal closed strippers here. So advantages, you can do a isolated semi-tendon harvest, and they retain the attachment of the hamstrings in the tibia. Suppose you can do with when you do patellar tendon reconstructions. So this technique can be still used here. So the disadvantages, identifying the separate sartorius fascial layer may be a little difficult in the initial cases. So posterior hamstring harvest tendon, when you want to do AC joint reconstruction, so you don't have to cause such a big morbidity over the anteromedial aspect of tibia, where still paresthesia do exist in these techniques. So I tend to do this posterior harvest technique. Usually the posterior, the tendon is easily palpable at the popliteal crease over the medial side. And first before elevating, making the tunicate inflation, first mark it. And that's how we mark it over the popliteal crease, medial, and just make an incision there. There's no nerve structure at that particular, it is quite safe there. And it is same like the peroneus longus. When you separate the fat, the tendon is easily visible there. So one thing here is the one tendon which you tend to see there is only the semi-T. It is very difficult to isolate the gracilis at this point of time here. So but you need to have open strippers here. That's how we remove the proximal end of the stump first, and then we pass the closed stripper and remove the distal part of the stump. So you need open strippers to this. That's how we insert it, and you pass. So one thing we need to notice, we may not get the same kind of tendon thickness like how we do in the previous methods, but this is when you need a lesser size, and for smaller reconstructions like MPFL reconstruction and the AC joint reconstructions. So that's how we do it, and it's very cosmetic and no nerve involvement over here. So we need to be aware of the saphenous nerve and its branches which can get injured. So two parts can get injured, the infrapatellar branch of the saphenous nerve and the sartorial branch of the saphenous nerve. So this red indicates the sensation area, and the blue paresthesia area when the sartorius branch is involved. And also you should be aware of the anomalous variance and the attachments of the semitendon. In this particular case, we had two attachments of the semitendon. So we should not take this as gracilis. So we will cause auto amputation, and the desired thickness cannot be maintained. When you take it, we can get a size of even 10 for single harvest. So graft amputation we know, but also important is volume reduction. So these are the twigs of attachments, veniculae, where the semi-T gets attached here. One is at 4 centimeters and one is at 7 centimeters. So it is important to identify these veniculae and detach them to get that. So one way to identify the veniculae and how do we remove it is, you don't blindly put the scissors and cut the veniculae. First identify the veniculae and pass the right angle artery forceps and try to pull the veniculae out as much as possible, so that its attachments at the periphery, and try to snap it at the periphery of the attachment and not close to the tendon, because each veniculae has at least 20% of the tendon contribution. So that is important. When if you cut the veniculae proximal to the stump, you are losing the tendon thickness. So to summarize, good harvest skills are developed only with systematic steps and followed to be again. Starts with surface marking. Use the same instrument and pressure for retraction. Repeatedly inquire about post-op praxia to redefine your harvesting skills. So choose graft and technique based on patient type and indication. Thank you.
Thank you, sir. That's a good video demonstration. Next, I ask Dr. Suman to give a talk on fixed loop versus adjustable loop fixation.
Good morning, one and all. Thank you, organizers, for the opportunity. So, I am Dr. Suman from BGM Hospital and Lalita Hospital. We'll talk about both fixed loop and adjustable loop one by one. Yeah. Sorry, 1 second. Sorry for the interference. So, these are the various fixation devices which we wear off, from the transfixation pins. The suspensory device is the fixed. This is the fixed A, and B is the adjustable loop. I have retained this image throughout the presentation. We have the metal and bio screws, and of course we have the staples. This is just introduction slide. So, A is fixed loop. We'll first start with that. It's an extra-articular fixation. It's a first generation device. This is the size of the metal button, usually made of titanium. Of course, different companies have a variation of few millimeter, and the polyurethane ribbon, or it's also made up of ultra high molecular weight polyethylene. It comes in different sizes, 10 to 30 with 5 difference. Earlier it used to come even with 2 difference in some companies. So we have this 2 threads. One will be the leading suture and one will be the lagging suture, depending on which comes up or down. We'll see in the video as we go. So the purpose is to keep the graft in tension and encourage good soft tissue to bone healing. So the trick here is to calculate the socket length. The socket length means how much the graft has to go into the bony socket from the articular side. Just learn this formula. On the video we will apply it. Okay. The length of the socket will be the total condyle length we are drilling minus the fixed loop length we are planning plus 7 millimeter for flipping. I just repeat this because it's a basic mantra. Socket length is the total condylar length minus the fixed loop length plus 7 mm for flipping. So for example, if the total condylar length from inside to the periosteum is 42, and let's say 20 is a standard button to easily calculate here. So keep it 20, and we need 7 mm for flipping. So 40 minus 20 plus 7 is 29. The steps are: we drill to the lateral cortex, then the fixed bead pin, and then we ream with the 4.5 reamer. Then measure the total depth, which is 42. This is the total condylar length. Then we calculate 29, like the way I said. Then we ream with the actual graft width diameter. Always ensure we don't have a lateral blowout, and the wall has to be at least 7 mm. The disadvantage of fixed loop, you need a big armamentarium of instruments of different sizes. If we drill too short, flipping will not happen. If we drill too long, we get a lot of empty tunnel. So that's what we should be very careful about. And the bungee cord effect is there because of, we all know what is bungee cord, the elastic activity we do as sports, right? So there may be poor healing at the soft tissue to bone interface. And semi-T alone may not be enough. We may perhaps need both the grafts. And the dead space of 7 mm after flipping, when the graft comes back, the 7 mm can cause synovial fluid accumulation and tunnel widening. So let's take my patient, which I performed this week. The basic graft diameter was 8.5, graft length is 9. The semi-T was 27, so I tripled it. The gracilis was 20 and I doubled it. So after and before preparation, basic image. So the total, please note these values, I'll show on the image again. The femoral condyle was 40, fixed loop I choose is 20. So 40 minus 20 is 20 plus 7, so that's 27. So we put up 1 mark is required here at the final mark of 20. So this is the drilling in full flexion. The first image is drilling, and second is the 4.5 reamer. So drilling is still complete the lateral cortex, and the reaming 4.5 is also till the lateral cortex. Now this is the depth being measured. This is the external measurement. That's just to show how the depth gauge is. And you see it is up to 40 it is going, which is the total femoral condyle length. So after that, the based on the calculation, 40 minus 20 plus 7. I think it's self-explanatory. So up to 27. I have done the the actual reaming of 8.5 diameter tunnel. Okay, I hope everybody was clear. So now this is the graft preparation part, the tripling of semi-T and the doubling of the gracilis, and that is with the fixed button. You can see the polyurethane, the titanium metal, and the both the sutures. Okay, so only one mark made at 20. So the target is after flipping, when the graft comes back, the 20 mark should be visible. That's it. Okay, we'll go through the 1 second, please. Yeah. Oh, this is the graft insertion, just casual insertion through the tibia. So this is the intra-articular image. You can see the button, and that is the next image. Button entering the tunnel, the polyurethane, and then the graft starting from the tibial end. Okay, so femoral side, tibial side. So this is the graft going in. The mark is just slowly going in. The mark has gone inside. Okay, and now the graft will disappear. While the flipping part 7 mm, it will go. So just checking the flipping is perfect. When the assistant pulls too tightly, we won't be having the flipping. Konja relax panna, a little bit of relaxation, and we can check the flipping. Okay, be careful, of course, not to flip it on the tensor fascia. It has to be on the bone. If you're really in doubt, check a CM shot. So the difference between fixed and adjustable loop, you have 2 threads here. The flipping, the leading strand and the lagging strand. Whereas in an adjustable loop, you'll have 3 strands. We'll show it in the next image. So this was fixed loop, as simple as that. Okay, we'll go on to the second half of my presentation, which is adjustable loop. So this is second generation. Like I said, I'm retaining the same image, fixed and adjustable. So you see the loop is quite long, and it is a single device. There is no big armamentarium of implants. This is the basic value in most companies, 14 into 4 into 1.5 titanium button. Here there is no risk of dead space, and at the end, after you finish the case, you can adjust a little so that you can get appropriate graft tension. So finish the tibial fixation, go inside, check the tension. You can always milk it a little more and maintain good tension. So there is no risk of under or over drilling here, technically, if your graft is long enough also. The only point is lateral cortex 7 mm at least try to maintain so that you don't get any blowout laterally. Semitendinosus alone is enough mostly. Calculate the lengths correctly, and there is only single implant, and calculation is quite easier. So my patient, which I did around 10 days back. So graft preparation, this is a basic graft. Again, semi-T tripled, and the gracilis was doubled basically, and graft sizing, preparation, etc. We'll go to the main part. So again, this is the left knee. That was the right knee. This is the left knee. So first the bead pin is going in, and then the 4.5 reamer over the bead pin, going through and through. Measure the tunnel depth, which is roughly 44. Sorry, the image is not that clear. Too many synovial particles. So the socket drilling. So I just roughly cut by 20. Let's say we want 20 mm of graft. I've just calculated the graft length, right? Assuring 22 mm of the graft. So I've reamed only up to 22. A little 2 mm extra I've given in case a little leeway I want to adjust. That's all. I just always I recheck the diameter properly, because once you put the threads, it may be a little thicker also. That I always check just to show you that point. And this is my graft with the adjustable loop device. So 2 markings will be done here. The first marking is for the total length of the tunnel from the the metal button you mark, which is 44 mm. Okay. So once the flipping is over, that mark should be visible on the articular surface side. Okay. So this is 44. Sorry, just 30 seconds more. So 44 and 44, like roughly it is marked. The second marking is for the socket length. That is made on the graft. That is the amount of graft which has to go in, right? So roughly 22. Actually it is 20, but I've kept it as 22. A little leeway I want to have. That's all, like I said. So 22. And this is the graft insertion. I'll go to the video. This is the flipping video, the same style as in fixed loop. Checking, pulling and seeing whether the flipping is happening or not. And this is a milking video. This is a pulling, like milking a cow, like that. You pull it. See to that you don't do it very fast. Otherwise the graft will go straight inside super fast, and it may not be on the tibial side. It will go straight away into the tunnel. So calculating this length alone is the trick here. So take home message. I mean, I read through a lot of studies. Some are telling this is good, some are telling that is good. Each has its own advantage and disadvantage. My purpose today was to show demonstration of both the techniques for the benefit of both consultants and postgraduates. For adjustable loop, the most common problem is the loop may loosen later and the graft may get loosened. For fixed loop, the problem is the dead space, which is given in almost all the studies. So it's a matter of your comfort, and the disadvantages you should know. So thank you very much. Hope it was useful.
Thank you, sir, for the wonderful talk. So next I call upon Dr. Yugal for his talk on pit stop technique and safe methods for femoral tunnel.
Good afternoon, everyone. Thanks organizing committee for giving this opportunity. Today I'm going to speak on getting ACL femoral tunnel right using pit stop technique. ACL reconstruction, though it is the most common arthroscopy surgery, the failure rates can be as high as 5 to 15%. Among these various reasons for ACL failure, my focus today will be on the femoral tunnel malposition. At present, in spite of improved instrumentations and technology, femur tunnel malposition is very common. These X-rays or these scenarios we regularly see in our OPDs. Some of the main reasons being improper understanding of the ACL footprint anatomy, improper visualization of the posterior cartilage margin of lateral femoral condyle, narrow notch, or the trajectory of the tunnel. First, let us understand the anatomy of the ACL footprint. So there are two main bony landmarks on the medial surface of the lateral femoral condyle, lateral intercondylar ridge, or also called as residence ridge. It is the most anterior point of the ACL insertion. Apart from that, there is a lateral bifurcate ridge which separates the AM and the PL bundles of the ACL. The direction of AM and PL bundles of ACL, it changes with the knee movement. So we should be careful when doing the scopy and making the tunnels. There's one more concept of ACL footprint insertion. These are direct fibers which are present at the anterior half of the insertion, and the indirect fibers which are present attaches at the posterior half of the insertion site. Eccentric tunnel over the anteroproximal region of the ACL footprint, which corresponds to the direct fibers, it is the ideal tunnel position. So we should aim for that. We have developed a technique for making transportal ACL femur tunnel to overcome the problems of trajectory, length, and depth of the femur tunnel. First, before making any ideal femoral tunnel, we should manage the notch properly. In case of narrow notches, it should be widened to clearly visualize the bony landmarks and the ACL footprint, and to avoid the future graft impingement as well. After this, we should check for the posterior cartilage margin. It should be clearly visible. Then with knee in 90 degree of flexion, mark the clock position of femur tunnel using chondral pick, and then recheck it through the anteromedial portal, whether the position is correct or not. Now using the offset guide, the depth of the tunnel is measured, and 1 centimeter pit is made using beath pin at around 100 degree of knee flexion. 4.5 endoreamer loaded over the beath pin and make a pit of around 5 to 10 mm at around 100 degree of flexion. Then recheck the position of femur tunnel pit from the anteromedial portal. At this step, now we can manipulate the direction of the beath pin to get proper trajectory, depth, and the length of femur tunnel. In case of multi-ligament injuries or when we are planning for the lateral extraarticular tenodesis, this step is very important. After 4.5 mm reaming, again check the position of femur tunnel through AM portal. And after this stage, we can do the tunnel adjustment using notcher with the knee in full flexion. So we get 3 checkpoints if we go through this technique to make our femoral tunnel ideal. To prevent chondral damage of medial femoral condyle, insert the reamer at 90 degree of knee flexion. Then insert the beath pin into the marked femoral tunnel Now bend the knee to full flexion and then ream the femoral tunnel up to the desired length. So it prevents the damage of the cartilage. This is a small video of the pit stop technique, what we do. So first of all, clear the soft tissues to visualize the posterior cartilage margin of the lateral femoral condyle. Using the offset guide, after marking the clock position, depth is measured. And a small pit is made using the 2.4 mm bead pin for a depth of say 5 mm to 1 centimeter. Over-reamed by 4.5 endo-reamer for a depth of 1 centimeter. And then position of the intended tunnel is rechecked through the enteromedial portal, and in this case you can find it is higher. So again we are using the offset guide and a bead pin to make a pit at a little lower level, over-reamed with a 4.5 endo-reamer. After confirming the correct position of the second pit, the bead pin is passed through the lateral femoral cortex through and through and over-reamed with a 4.5 mm tunnel. Length is measured. Again, we can check the tunnel position from enteromedial portal, and it was found that it is little distal to the ideal position. So the tunnel was proximalized using the notcher, rechecking again through the AM portal after notching. So now the tunnel looks perfect, and the reamers are now introduced at 90-degree flexion. Then bead pin is introduced in the femur tunnel and knee is fully flexed. Then the femur tunnels are reamed up to the desired length. Sequential reaming is done in same steps. And this is the final ACL femoral tunnel, what we get at the end. To conclude, ACL femoral tunnel is still the technical weak link. Time spent in this step is worth. We should view from both the portals, be ready to make a small changes and protect the cartilage while reaming. Thank you for your attention.
Thank you, Igal. That's a good presentation. Next, I welcome Dr. Arul Daniel to give a talk on ACL avulsion.
Thank you. At the outset, I would thank the organizers for giving me an opportunity. So today I'm here to talk about ACL avulsion injuries. So as you all know, ACL avulsion is not as common as ACL injuries per se. It constitutes only about 15% of ACL injuries, generally seen on younger age group, between age of 8 to 14 years. It's also seen in adults, but most commonly associated with other proximal tibia fractures or plateau fractures. Why it's common in children? Because the strength of the tibial plateau, that is incompletely ossified tibial plateau, is weaker when compared to the ACL fibers. And what is the mode of injury? Generally, initially it was thought as a bicycle injury when it was described by Mayers and McKivers in 1970. But most recently, it is not only because of bicycle, it's commonly because of sports injury like soccer, football, and other contact sports. So the basic mechanism of injury is flexed knee flexion with the simultaneous tibial external rotation. And our second mechanism is direct blow over the back of the knee, generally the posterolateral aspect of the knee joint. The third, it's hyperextension of the knee with valgus or rotational force. So classification is the age-old classification, Mayers and McKeever classification, type 1, 2, 3, and 4. Type 1 is non-displaced or undisplaced fracture. Type 2 is partial displaced, there is always a posterior hinge. Type 3, it's a complete displacement, further divided into A and B. A involves the ACL insertion only. Type B, which has a complete displacement, which includes the entire intercondylar eminence. Type 4, which is extension of the classification, where there is a combination of the fragment. There's a recent classification described in 2019 by Green and Tuca based on MRI, which is more appropriate for planning for surgery. Grade 1, it is undisplaced, where the displacement less than 2 mm on MRI. Grade 2, where it is more than 2 mm anteriorly, but either posterior hinge is intact or posterior hinge, the displacement less than 2 mm. Grade 3, further classified to 1, 2, 3. The first one is displaced more than 2 mm. And the second one, where there is interposition of the meniscus, it can be either anterior horn of medial or lateral meniscus or the transverse ligament. And the third type of grade 3, where the fracture involves the tibial plateau or the whole of the eminence. So this is a better classification when compared to Mayers and McKeever's. Now presentation, generally the patient presents following a sports injury, and almost always there's a history of popping at the time of injury, and the patient will present to you with the pain and swelling. Instability is not always present as seen in ACL tears, and the patient will generally complain of inability to weight bear, and there is almost always extension block. The patient will be keeping his leg in fixed flexion deformity of over 10 to 20 degrees because of the bony block. Diagnosis, the first investigation taken is a plain radiograph, but the fragment is generally seen in the lateral view than the AP view. CT scan better for the better visualization of the fragment. MRI is the investigation of choice for assessing and confirming the fracture. It also helps in checking for the associated injuries, which is almost always present. What are the other associated injuries? The meniscal entrapment, meniscal tears, concomitant ACL mid-substance lesion along with the ACL avulsion, chondral lesions, bone bruise, and tibial plateau fractures. Cocker et al. Identified entrapment of either the antihorn of medial or lateral meniscus, intermeniscal ligament in 26% of patients with type 2 fractures and up to 65% in type 3 fractures. So this is the reason for getting an MRI for ACL avulsion. And there's one more study by Mitchell et al. Where he noticed 29% of entrapment in type 2 fractures, 33% associated tears in type 2 and 7% chondral injuries. Coming to type 3 fractures, he noted 48% of meniscal entrapment, 12% had meniscal tear, and 8% experienced chondral injuries. So this was a study looking for the meniscal tear in children with ACL avulsion, and they concluded telling 37% of children had meniscal injuries, among whom 90% had lateral meniscus tear. And a point to be noted, whenever you have a pediatric patient with knee effusion between the age group of 6 to 8 years, there's an entity called cartilaginous avulsion of ACL, which is not seen on X-ray or CT scan. So MRI is advisable in these scenarios. This was present in Costa 2013, generally in the age group of 6 to 8 years with ACL avulsion. So this is a nutshell of thing. Better seen on lateral view in X-ray, CT for better bony anatomy, but MRI is an investigation of choice to look for interposition or other concomitant injuries. Coming to management, it can be managed conservatively or surgically. So conservative is generally reserved for type 1, type 2 fractures. Type 1 immobilized in a cast or splint for 6 to 12 weeks and typically in extension. And type 2, reduction is attempted in extension where the the trochlea pushes the fragment into place. If it falls into place, then you can put the patient in a cast or splint for 6 to 12 weeks. And most common cause of inadequate reduction is interposition of either the meniscus or the intermeniscal ligament, as shown in the picture. So this is a fragment, and you can see the transverse ligament falling in between the fragment and the condyle. So type 3 is almost always surgical fixation. If left unoperated, then there are 70% chances of laxity. If operated, the laxity is reduced to 14%. So any type 3, type 4, no close reduction, it's always almost surgical fixation. Why fix? To get a better stability, to regain proprioception, avoid extension lag, and early mobilization. So what are the methods of fixation? There are various methods described, but most commonly used is sutures and screws. Rest is outdated nowadays, so I'm not talking about it. So coming to sutures, it is single or double tunnel. We can fix it with adjustable loop or anchors. Screws can be cannulated or solid screws. It can be either metal screws or biodegradable screws, and traditional screws or a headless screws. So coming to a debate about screws or sutures. So suture has a better fixation and lesser complication, whereas screws has higher risk of fragment combination, iatrogenic damage to the ligament injury, posterior neurovascular injuries while drilling, and failure to screw purchase may need implant removal in the later date. So there are various studies comparing screws and sutures, where screws has more stiffness, removal of hardware, and residual laxity. So this was my biomechanical study which showed cyclic loading comparing sutures and screws, and concluded stating suture fixation gives a more stable fixation when compared to screws, and second screw does not give any positive effect in the biomechanical characteristics. Coming to case example, this is a 20-year-old football player, 3 days old injury, and this is a video. So initially we debride, identify the fragment, debride the footprint, and then temporarily fix with the K-wire while the assistant is holding it in place with the probe. And then we take bites through the suture lasso and shuttle the sutures with the proline to a fiber wire. Nowadays we use mini tape or fiber tape as well. And this is a double tunnel technique. Generally the crisscross way of fixing, the lateral sutures is taken to the medial tunnel and the medial sutures the lateral tunnel. So this gives a stable fixation. Nowadays we take a bite through the self retrieving suture passer as well. And this is whenever you fix, once you finish the fixation, it's always better to put the knee in the range of motion so that it will be easier for mobilizing the patient. So this is a video. This is a single tunnel technique where we fix it and then put the knee in a full range of movement and check for the stability. Once found stable, we can ask the patient to move from day one. So other methods are suture anchors, where you take a bite traditionally and fix it to the anterior cortex of tibia. So this similar one presented by Mukesh Loda, Indian surgeon, and protecting the physis. Do we always have to protect the physis? There are papers which states when you use a vicryl instead of fiber wire, or even a transfacial suturing technique is okay, and there are very less complication even when you do a transfacial suture technique. When you minimize the tunnel to less than 3.2 mm, nowadays we use 2.5, 2.7 mm tunnel, there are less chances of growth arrest. So complication, very less. Laxity is about 14%, which might require ACL reconstruction, generally in like adolescents. And stiffness is 60% when you wait to mobilize for more than 4 weeks, and non-union is very less, about 1.7%. Post-op rehab, toe touch walking for 4 weeks, and posture waiting for 2 more weeks, and then you get a check X-ray and full weight bearing. And you start movement from day 1, 0 to 90 degrees, as the patient tolerates the pain for first 4 weeks. Summary, identify early. MRI is the investigation of choice, and fixation is required whenever the fragment is placed. Sutures are better than screws. In older children, adolescents, then there is a greater risk of laxity. If I have time, I present only 2 slides. This is one technique described by Ortho1 by Dr. Santosh Sanan sir, David Rajan sir, and the team. So this is a suture web technique. So whenever we have a comminuted fracture, or you would have done a fixation, the anterior fragment lifted off from the anterior cortex. So you pass 2 sutures traditionally, and 2 more sutures are passed through the tunnel, and the intra-articular piece is taken anteriorly over the tibia and suture to the self. So this is a very good technique described. It's also presented in the article, and this is the way it is fixed. This is how it looks intra-operative. So this is the fiber, which is the tape which is taken anteriorly, which will push the anterior fragment downwards to the plateau. Thank you.
Thank you, sir. So next I call upon Dr. Palnivel Rajan sir for his talk on complications in ACL reconstruction.
So once again, thanks to the ACA for the IAS for giving me this opportunity. So before going into the complications, we can't brand everything as a complication for ACL surgery. You should know that there are 3 different type of challenges you come across in ACL reconstruction. Some are called obstacles, where it can challenge the smooth progression of the ACL reconstruction. Some of them are problems, which are unexpected events that arise during surgery, which often require immediate solutions. If effectively resolved, they typically don't leave any permanent effects and outcome of the procedure. And then there is another group of problems that's called complications, which is an adverse outcomes that may occur due to various factors, resulting in negative consequence that may require further treatment or intervention. So if you see the obstacles, this can be preoperative factors that need to be addressed prior to the surgery. First thing is the patient condition. Obese patient, there's always challenge in positioning the patient, the tourniquet applications, and the graft harvesting. All these things you need to keep in mind when you see very obese patients which more than 100 kgs, and the pre-existing conditions like bronchial asthma, cardiac issues, blood thinners, which require careful management, and you should not overlook all these conditions when you come across an ACL patient. All these will try to prevent a lot of complications if you address it properly. Then the skin conditions like blisters in plasters, varicose veins, infections, abrasions. Sometimes patients have psoriasis like patches on the graft site and surgical site, rheumatoid arthritis, patient with a lot of synovitis, even some patients may have osteoarthritis, and a lot of associated ligament injuries. All these can complicate the surgery, and you need to be very specific in considering all these conditions, and you have to plan it accordingly to prevent complications. And then you need an adequately trained assistance, which is very crucial for effective and efficient management of the procedures. And all the required appropriate equipment should be there so that you can do all the procedures and don't leave any procedures because of the want of any equipments or implants, and all these things need to be taken into considerations. Then there are problems which are challenges. The first one, you need to plan preoperatively to avoid some complication. The second one is unexpected events that happens, which when solved will not have any residual effect. Anesthesia effects, difficulty intubation, and sometimes anesthetists may push you to do the surgery fast, or incomplete or inadequate spinal anesthesia, which the patient will be moving, making some, which all will distract you, and you need to manage this and tackle this accordingly so that you don't have any permanent impact on your surgical procedures. Then again, tourniquet issues like incomplete tourniquets, malfunctioning, suddenly the tourniquet gives off, and then a lot of gushing. All this you need to plan it, and you should be ready to tackle all those things to prevent complications. And prolonged tourniquet time should also be taken into consideration when you are doing ACL reconstruction surgeries. Again, bleeding, which will hinder the visibility of the surgery. You need to add some hemostatic agents. You should have diathermy or a RF equipment with you to make sure that you get a very clear picture. And then equipment malfunction, which again will have an impact on your surgical results. So you should always have a resource, as well as you have a standby equipments. Light source can give off anytime. Camera can get damaged, because majority of your surgery is dependent on the equipments, electronics. Anytime it can get breakdown and you will have problems. So all this need to be taken into considerations when doing the ACL surgeries. Again, sometimes you miss the chondral lesions in preoperative planning, and then a meniscal injury, and suddenly you don't have that proper implant to address that. All this can have an effect on the surgery. So all these things should be taken into consideration. The other thing with the graft is dropping of the graft. Occasionally it happens to people, and then once the graft is dropped, then you need to wash it properly with triple antibiotic solutions. Soak it there for 30-40 minutes, and then you have to reapply that. Then accidentally amputating the graft also has a detrimental effect, which you need to take into consideration, and you have to have a plan B to take other graft to compensate that. So again, complications or the adverse outcomes after surgery or during surgery, and which will have a negative consequence and will ultimately have some leftover effect on the patient's conditions, which needs further treatment or intervention. Could be intraoperative or a postoperative complication. Just briefly see the intraoperative complications. Graft harvesting can have problems in tunnel preparation and graft fixation. So when you harvest a patellar graft, the fracture of the patella, small bone plug, bone fractures, patella fractures, very long tendon, patellar cartilage damage, all this can happen. So all this need to be considered. Again, in hamstring, premature amputation, MCL injuries, sometimes sciatic injuries can happen. So that also need to be taken into consideration. Again, in tunnel preparation, injury to the femoral medial femoral cartilage should be avoided, and then you should have adequate tunnel, because if you don't have adequate tunnel, there won't be any flipping happening, and then you may pull it too hard, and ultimately the wire or the fiber wire snaps off. So that length of the tunnel, everything should be properly planned. Tunnel mismatch and visualization is very important, as Yugal told, that you need to do notchplasty or everything to see that you exactly locate the tunnel point. Again, if you put it anteriorly, there will be a notch impingement, and if you put posteriorly, there will be a PCL impingement. On the femoral side, if you have anterior graft, it's likely to fail. Posterior blowout is another thing you need to consider. Then a very vertical graft is also not good for proper functioning of the ACL. So all this can happen. And then I'll go to the graft passage. So there's always a chance that the knot will fail or the loop will fail when you try to pull it too hard, or if there is a mismatch between the tunnel and graft, you don't drill adequate tunnel, or your staff gives a reamer saying that it is 8.5 or 9, you always cross check. That is in my experience, I always cross check the reamer, because at times they may miss and give you a smaller size reamer. You will assume that it is the normal size, you ream it, and then ultimately your graft won't go inside, and then you may try to pull it too hard. Ultimately the graft lacerations, graft damage can happen. That is one of the things you need to avoid. Then when you put a screw in the patellar tendon, there's always a possible posterior slippage. Then screws protruding into the joints can cause cartilage damages. 2 minutes. Right. Graft rotation can happen, so you need to pull it hard before putting the screws on the tibial side. And then it should not be too tight to lacerate or damage or amputate the graft when you put the screw. All these are graft fixation problems. Postoperative, as you all know, aseptic effusion, infection, neurovascular injury, arthrofibrosis, thromboembolic thing can happen. So all this need to be considered. And then re-tear, recurrent instability, reflex sympathetic dystrophy, all these are post-op things that need to be considered. The most common is infection, which is a dreaded one. Then the loss of motion, this are arthrofibrosis. The third one is recurrent instability, and ultimately the graft failure is also one of the complications that you come across. Again, infection, you have to change the antibiotic, aspirate it, send it for culture. Otherwise, you do a debridement or washout of the joints, and if it is not improving and then there is some pus formation, everything, then you need to remove the implant, and sometimes even graft also you need to remove that, so that the patient comes out of that infective problem. Loss of motion, lot of reasons for loss of flexion: suprapatellar adhesions, improper tunnel, excessive tensioning, post-infection, prolonged immobilization, multi-ligament injuries, early surgeries, all can cause loss of flexion. So early mobilization, CPM, mobilize under anesthesia if it is not working for more than 6 to 8 weeks, and then arthropibrolysis to mobilize the joint. Loss of extension can happen with graft impingement, cyclops lesion, and posterior capsule tightness. Again, notchplasty, excision of the cyclops, posterior capsule release, all can solve this. Recurrent instability, lot of reasons: malposition tunnels, not addressing the associated ligament injuries, and re-ruptures can happen with fresh injury or limb malalignment or graft impingement. All these needs to be considered. So 5 possible causes for reconstruction failure: graft discontinuity because of tear or impingement, inappropriate tunnel position is one of the reason, hardware failure, times have infection, and arthrofibrosis. So all this needs to be considered when doing an ACL surgery. Thank you.
Thank you, sir. So that concludes our session on ACL. So the session is open for discussion, sir.
Question to Arul Daniel. For the ACL avulsion fractures, we know that some cases can be treated conservatively. So which are the cases you do a conservative treatment, and how do you treat conservatively? That is, I think, for youngsters to know to prevent the complications.
So as I described, the conservative stands only for type 1 fractures, which is undisplaced, or type 2, when you can close reduction can be done in full extension, where the trochlea pushes the fragment and reduces. But majority of the time it won't reduce because of interposition. So only type 1, if I ask me, type 1 is the only thing which you can manage conservatively with long knee brace or a cast for 6 to 12 weeks. That too, after about 6 weeks, you have to get an X-ray to check for the union. If it's uniting well, you can ask the patient to weight bear.
Even the type 2, most of the time the posterior cortex will be intact. So when the posterior cortex intact, I think still, unless type 3 is completely avulsed and separated, we know that it may not heal. And most important is that complication of ACL avulsion is the fixed flexion deformity.
Yes, sir.
Rather than because of the, the fragment which is lifted up in type 2, if you don't immobilize properly, then they can go for a FFD. So the most important is that, as Arul Daniel mentioned, you do it in a hyperextension cost better or extension cost. So don't keep them, don't think it's a conservative management. You can put on a knee brace and leave it, because people tend to flex it because of the swelling and pain. Then that extension they will not be able to get because of the fragment. So hyperextension also helps the fragment to sit very well to the tibias, when especially in the type 2. So of course type 3 definitely needs surgery. Thanks.
And one more question generally they ask us, how long we can wait? Like when we can fix, like you get a patient after 3 months or 6 months after ACL avulsion, can we fix it? Yeah. So I was just talking to DVR sir also. He was telling he has done even after 1 year, if you can create the crater and get the reduction properly, then I think you can even fix it.
So you can prepare the, the preparation of the bed is very important.
Very important.
So when you go more and more chronic, it will be difficult to get back, because by the time some fibrous formation in the bed, so you have to clear the whole blood. That way the reduction you will not get it, and you don't need to do it on day 1, because there will be a lot of hemarthrosis. So don't do it on day 1. Wait for 2 to 3 weeks time till the swelling comes down. Especially if you don't have much experience of doing arthroscopy in acute cases, it will be frustrating with all the bleeding. You can damage your scope and everything. So better to all the swelling to come down, knee become quiet. So you can tell them that you can do it even after 2 weeks time. Doesn't matter. So no need to do on a day 1. We can do as late as we can, as SAR said.
Generally 10 days to 2 weeks.
Thanks.
Thank you, sir.
And in some ACL avulsions, the lateral meniscus anterior horn is also torn up. So it is important to look for lateral meniscus anterior horn. So in case it is lifted up, just advice for youngsters, you can put a traction stitch and pull it, then reduce the ACL avulsion and fix through that same tunnel. Or you can do at the end also. But important to look at the lateral meniscus anterior horn. Thank you.
Shall we go ahead? I'd like the chairpersons to felicitate our faculty. I call upon Dr. Narendran. Thanks, Dr. Narendran. It was a wonderful talk. You nicely elucidated how to harvest the grafts. It was really nice. Next, I call upon Dr. Suman sir. So, Dr. Suman sir spoke about adjustable and fixed loop. It was a very nice explanation on how to deploy both. It was really nice, very useful for the youngsters. Next, I call upon Dr. Yugal Varandanani. A very nice talk on the safe method on for femoral tunnel placement for ACL reconstruction. Dr. Arul Daniel, a talk on ACL avulsion incited a lot of questions. Very nice talk. I call upon Sundar sir to honor the chairpersons for the session. Dr. Karthik Chitartha. And Dr. Priyan. Thank you, everyone. I think the Dr. Santosh sir is ready with the live surgery. We are going to the live surgery. Over to you, Santosh sir. I call Dr. Sundar sir and... oh, okay. I call upon Dr. Sandeep sir and Sundar sir to moderate this live surgery.
Check. Good afternoon, everyone. This is the first case. It is a 35-year-old male with complaints of instability while climbing stairs and running, and also recurrent locking episodes of right knee. Total of 4 episodes of locking. Last episode was 1 month back. He had an history of injury due to fall from a two-wheeler in July. His profession, he owns his own business. On examination, his range of motion is 0 to 140 degrees. Latchman test is positive. Anterior draw test is grade 2. Posterior draw test is negative. And McMurray's test is positive. Varus and valgus stress test is negative. Beighton score is 0. This is the Latchman test positive. And then we have an anterior draw test grade 2. And valgus and varus tests were negative. On sagittal section of MRI, we can see there is absence of ACL tear and lateral meniscus tear and double PCL sign. On coronal section, we can see the lateral meniscus tear and the bucket handle segment in the intercondylar notch. His MRI report was complete ACL tear with complex tear of posterior horn of lateral meniscus and bucket handle tear of medial meniscus with meniscus fragment displaced into the intercondylar notch. Plan is for arthroscopic ACL reconstruction using ipsilateral hamstring graft and meniscus repair, oblique partial meniscectomy. Over to Dr. Santosh Sahanand, sir.
Yeah, good afternoon. Thank you, Amarendra. So, who's there on that side? So, as Amarendra briefed on the...
Santosh, I'm Sundar here, and Sandeep is with me for moderation.
Okay, sir. Excellent facility here. Deepak is next to me. Dr. Anushri is the anesthetist. And Dr. Manita, Shamli and Vidiksha are with me. Big team. Thanks, Sundar sir, for the excellent team here. So what we've done is already started the scopy 10 minutes back. I've harvested the semity. Before we go, let's see the MRI first. The MRI coming. As Amrindra had shown, this was a case of 3 months old ACL tear with the repeated history of locking present. So, as you can see the MRI, there is a clear ACL insufficiency. And the second film, last row. As you can see a clear cut posterior horn of a medial meniscus tear. But the central, second last row, central image. Zoom. If you can see, there are 2 posterior fragments. You can see the posterior horn tear, but there's one more, something close to the PCL. Probably that's a flap. Can you point out that? Yeah, that's probably a flap. Yeah, exactly. That's not a usual fragment when you see for a bucket handle. But in the left image, you can see a double PCL kind of a tear, which may be a bucket handle tear. So it is a complex kind of a medial meniscus tear, which is probably a bucket handle tear. No, second row coming. No, for lateral meniscus. See the lateral meniscus, yeah, you can see a posterior horn tear in the lateral meniscus. So both the meniscus are torn clearly. Then the locking is probably the medial side bucket handle tear and the ACL tear. So before you go in, you must be to some extent prepared what you are going to encounter. Medial side, there is a flap tear. You might not be able to salvage this meniscus. It's a 35-year-old. His activity level is low as a businessman. So you have to know to some extent what you are going to expect. So let's go see the arthroscopic view diagnostic wise. So I've already started the scopy. Inside picture, okay, diagnostic scopy wise, as you can see, medial gutter, you can already see a flap lying there from the medial side, medial meniscus flap in the medial gutter. So mild kind synovitis, not much. Fetla and trochlea were normal. That's a popliteus, and you can see the periphery of the lateral meniscus. You can see a small tear in the lateral meniscus as well. So I've already prepared the notch. So notch is, it was a complete ACL tear. Save time, I prepared it. Let's see the compartments now. Figure of 4. You're getting into figure of 4. For beginners, see the assistants are very important. See, as I said, figure of 4. The outside view, zoom out பண்ணிக்கோங்க. Zoom out. As you can see the position in figure of 4. So Deepak is giving a good pressure onto the proximal knee to give me good opening. See the inside picture, you can see very nice opening of the lateral side. The meniscus condyles are good, pristine, and you can see that unstable tear in the posterior horn of the lateral meniscus, right from the posterior horn, extending probably up to the middle third, as you saw in the gutter itself. So upper surface is not bad, but it looks like rounded off edges. It is definitely not an acute tear. It's a chronic tear. So it's definitely a repairable meniscus where we can place all inside device because it's the posterior horn over here. This might, quite a long tear, so this might require a couple of all insides, one over there and one over there to stabilize the posterior part of the lateral meniscus. We'll come back to the lateral meniscus later. Now we'll finish the diagnostic. Going on to the medial side, bolster. To see the medial side, have a look at the bolster going in the inside picture, going below the thigh, above the PIP required, PIP, above the popliteal area. Outside picture shows that. Then take the knee into valgus and slight flexion. Yeah. Then you can see the opening in the medial side. As you saw, there is one flap in the meniscus here, one more flap in the meniscus here, and there is a tear in the medial meniscus, a longitudinal tear. Yeah. That seems to be a white zone tear in the medial meniscus, which is coming and unstable, coming into the joint. What's happening to the remaining meniscus? That's the periphery. You can see one more tear in the periphery. So this is a double bucket handle tear. First bucket handle is white, and second is probably red, white or red. So and what we saw in the MRI, we have to look for the flap. There is the flap. As we saw in the MRI, you can see the flap in the posterior part, which was seen as a separate flap lying there. So this is a complex tear and a chronic situation. This is a white zone tear. I do not want to repair this at all, and repairing this will not. Healing tendency is very less, and already 2 flaps are there. I'll definitely excise this part of it. But if you excise the remaining, also you would have a subtotal meniscectomy or total meniscectomy kind of picture. So probably we can freshen it up and repair at least the remaining half of the meniscus. At least 50% of the meniscus will remain. Sir, is that okay with the plan?
Are you planning to do, Sandeep here, are you planning to do any pike resting here?
Before repair, pike resting is definitely required. For diagnostic, I have not done much. So I will show the pike resting how much. So pike resting is a method where if you're not able to visualize, you have to do this pike resting to have a better vision. I prefer doing the distal part of MCL pike resting. Make multiple punches. You can feel the cracking sound. Sometimes, Malgus, punch flexion. Do it in the extension. Do it in a sequential manner so that it slowly opens out. You can see the opening there. Not to do it too aggressively. It's good enough that you see enough. Not to try to see the entire meniscus in one shot. Now let me see. Actually, I'm happy with this much of opening. For demonstration purpose, you can be a little aggressive, but I don't want to be too aggressive here. Do you have a good vision, Sandeep? You want me to do more?
No, it looks better. Yeah.
Yeah. Okay.
So this is very important because when you do a pike resting, you should not do blindly. You keep seeing inside only the necessary level. We should do it. So if you do unnecessarily, if you open more, then it will be like grade 3 laxity. So this is the only space which you require for your repair. It's very well demonstrated. Santosh, because it's a very complex case, that's why we told you to do. So we are all looking.
So still I
waiting.
don't want to repair this part, sir. Two flaps, 1, 2, and 3 flaps in the white zone, so white tear. So I'll excise this part, then repair the remaining.
Dinesh wants to know, is there any ramp tear?
So the flap was in the way. So while we excise the flap, we can see that. So I left it like that, not to waste more time there. Let's finish the ACL part of it, make the tunnels, then come back to meniscus so that we concentrate on the ACL also. I've debrided the footprint.
So you want to do the femoral tunnel first, so
Yes,
that you don't want to do again deep flexion, isn't it?
Correct.
Okay.
So deep flexion activities are to be reduced as much as possible, especially if you're using an all-inside device. Inside-out device, we can still retighten. But when you're using an all-inside device, you would not be able to tighten it. So do the deep flexion activities as much before you start doing the ACL.
Yeah, any ramp repair or a posterior horn repair with all-inside device, then definitely put a lot of stress after the deep flexion. So better do the femoral tunnel first, then go back to the, then do the repair is better.
Block.
That's what Santosh is doing.
So femoral tunnel, let's talk about the femoral tunnel. So that's the footprint area. So look for the over the top position where your condyle is finishing. That's over the top. And probably that's the residence ridge, probably. Most of the time it's a change of color. Sometimes you will be able to appreciate the residence ridge, especially in acute cases. Such chronic cases, you might not be able to appreciate that clearly. So probably that's the upper half and this is a lower half and that's the center point. But we prefer doing the high AM. So we go pure AM. That's a little high, but that's what we are following now. The bone is so soft, I don't need a mallet. Tap, one tap for the flexion. This is the way where it is eyeballing, tap, tap. Eyeball method where you just see where is it and go. To confirm your position, if you're doing this method, always switch your portals, view from the medial portal, make sure you're in the right place. Here I'm slightly shallow. I would prefer to go slightly back. That graft prepared is 8 and 8. 8 and 8, length is 7.5. I want to go slightly back. I can do dilatation posteriorly and go back. So we can either make a mark posteriorly and go further back or do a sequential reaming where you go back slightly. So in this, I would prefer to do a sequential reaming where I take it back further. Other ways to do it, your osteocare has got these offset jigs in their set. For beginners, you must be aware of these. The PIP, can you show the PIP picture please? Enlarge the inside picture. So these are offset jigs. So these are very good instruments. If you are wary of going back, having a posterior blowout, always use these kind of instruments where you need to place them there, flexion. There is no way you're going to go back and have a blowout. So your wire comes in there and that's the mark which I made. So you're no way going to go posterior. These are safe ways to get the tunnel right. So as we are used to doing the eyeballing method, we would continue to do so. Because sequentially, I will be able to dial it in front or back and change the tunnel position accordingly.
The another advantage of using the offset guide especially for the beginners, I would suggest to do offset guide because you won't come anteriorly because the most common failure of ACL reconstruction is the non-anatomical tunnel, that is more anterior tunnel. So that mistake we should not do. When you use an offset guide, always you are going behind the femoral condyle, so always you know that you are in the posterior, you are not going to come anterior. Especially because all the knees are not same. Some of them will have a very long notch. So in that case, you have to be careful that you're going exactly where you wanted to go, and especially when there's a small notch, still a problem. Sometimes you come too anteriorly also. So you have to balance both and make sure. But if you are experienced enough, then you can use the blend technique. But again, as Santosh clearly demonstrated, you should go to the other portal, make sure see from your medial portal and you are in the correct entry point, so that you have a extra that 7 mm or 6 mm posterior to the entry point.
So I've drilled the wire now. The point over here is to get a good length. We should not, I don't prefer getting a short tunnel. I always try to prefer getting, at least when you use button proximally, I want at least a 35 tunnel. In small knees, you tend to get 30 and less. So a way to get a long tunnel as much as possible is these angles. Your angle, the inside picture you can see, right? The angle from the midline. From the midline, your angle must be less than 45. Around 30, you get a good long tunnel. So from midline, it should be less than 45. Around 30 is good. And from the side, when you see from the side, your knee must be maximum flexed as possible. This is in a supine position. So knee flexion must be maximum as possible. Can you change the camera view to camera 1? Yeah, you can see the knee flex maximum, and the wire must be as parallel to the floor as possible. In this way, you try to get as maximum length as possible. This is based on a city-based study which Geethan and Artha were involved. But this doesn't apply if you're doing it in a leg holder. So I'm drilling the first 4.5. Our plan is to have a suspensory fixation here. Carefully. So 4.5 goes through fully. Out. Let's see what is the.
What is the size of the graft, Santosh?
8 and 8, length 7.5, sir.
8 and 7.5. Okay. How many strands?
Depth, so the mark is above the number, so that's 40, and it is 3 minus 35, 36, 37. So it's above 30, 35. So we'll take it as 36 here.
So did you use is a quadrupled semity or used 5 strands with the semity and grass?
Quadrupled semity.
Okay.
You can show the graft, ma. One camera anga kaamikiringa. Deva? Vela kudutharu. Outside we'll show the graft shortly. Overana. Shamli has prepared it quickly. Before I turned and looked, graft is ready. That's a quadrupled semity. And the button is placed over there. Button size, na? That's a 20 loop button. But the difference in this situation is, have you seen the graft? Yes. Coming here. This is a EcoFlex button, outside view. That button it seems to be a fixed loop, but it is a hybrid.
Zoom out.
So that button, that length is 20. It behaves like a 20 CL. You can flip it and place it there, but it has an additional adjustable loop over there, where further tightening of 5 mm is possible by pulling the white thread. So even though we are putting a 20 fixed loop, further 5 mm can be pulled in. So the loop will be shortened. So in this situation, it is ideal where you got a 36, you got good flipping, and further tightening is possible. And in this situation where distally, plan is to do a button fixation, suture disc kind of fixation. In that suture disc tensioning is slightly difficult and challenging. You can fix it distally and then tighten it proximally by using this adjustable loop. So tensioning also is possible in this. We'll see it at the end. So our tunnel is 36. So for a 15. So if we have to calculate for a 15 CL asset, so 36. So how much should be the tunnel? 11, 21 plus 7, 28, 7. Goal drilling 28 to 29. So drilling as per the calculation of a 15 CL, expecting our tunnel to button to go in and sit at 15. 8, okay. So as you can see, the posterior wall is quite thick. So our aim is to go more eccentric and go more posterior, so that we end up more posterior. Our tunnel must be as posterior as possible. So our native footprint is so. you're not confident, you can always use a scoop or a notcher to go back further. Ready? 8th another. Slightly bulky. What is he? So we are going till to push fluid. Possible? Yeah. Okay. Going till 28, 29. Clear? So posterior wall is thinned out now, as thin as possible. I'm happy with the tunnel. To have a better view, let's switch and see. That's a tunnel. As you can see, it's slightly high than.
Very nice.
The
You can see the footprint. You can see the surrounding of the tunnel. That is the original ACL fit down. You can see that still. You can see all the footprint. So that is the ideal tunnel.
So femoral tunnel done. Shiva. So let's do the medial side first. So as I said, we'll do the all inside as much as the last one as possible. So I'm doing the lateral side after I do the medial side. Now cutting instruments. So a case where we have all options to be shown here. So all inside, inside out, excision as well. Bolt stump. What duckbill? So as Dinesh was asking, now we have a chance to see posteriorly. There the flap was there, I was not keen on seeing the posterior part in the beginning. The flex panama. Okay. Arc 36. That is a flap. As this is in a good position to cut, so I'll cut it straight away. Then we can do the diagnostic part posteriorly. A large duckbill. A large duckbill. Smaller now. Let's cut the flap first. When you're doing this, you have to be really careful not to cut the remaining root. So sometimes in the early phase of your career learning time, you tend to be a little blind over there. You would inadvertently go a little deeper and you might end up cutting it. Counter in one hand, extension. Yeah. No, the blade is in a blade. So that part of the flap is gone. Rope, please. This is the first tear which I was telling, white zone. Second tear, I don't think it is there. It is extending till there. I wouldn't say this is the ramp tear. This is the red zone, posterior horn of meniscus tear. Ramp is slightly back over there. Ramp is intact. Dinesh, I hope you would agree with me. It's a posterior horn, red zone tear extending till the middle third. That's the second tear. First tear, you'll excise. My small duckbill, Venu. I want to use a small duckbill because it is more precise. Yeah, smaller there. Okay. So yeah, this is the stage which I said. Yeah, be very careful only to cut the first bucket handle and not the second. Please stop me if you're seeing anything. Allow me. can cut 90% and leave the rest also. It will come by twisting the fragment. So I will leave it there. So if you leave such small tags, it actually makes things easy for you because the meniscus stays there. It makes our excision in the anterior part much easier. So here, things which you need to learn is when to use which portal for the working and viewing. Till now, our viewing portal was the lateral side and your working portal was the medial. So now it is a tight angle to have a cut over here. You can try to cut, but it makes things difficult for you. Now you probably need to switch. So your viewing portal will be here. I'm debriding the synovium there because our view will be obstructed when you switch your camera that side. So I'm clearing a little bit of synovium there. I'm switching my viewing portal to the medial side. Then looking down onto the meniscus. The view is not great, but your working portal instruments come in the right angle to do the excision. Small than So here, you need to exercise this so you can balance it at the same time. So the angles are right over here. If this is more difficult, if your this thing is still anterior, then you probably need to use those rotary punches or right angle biters. I'm finding it difficult to take a bite, so I'm inverting it upside down. Yeah, it is difficult to take the bite here, but I've made the balancing part of it, the bite came out easily. You can still come in from the medial side and complete it, or try one more attempt. With hard meniscus. Probably it's been flipping in and out. That actually hardens the meniscus. You have to complete this so that you can remove the meniscus. Oh, that's a piece. Grasp it another ka. Grasp it. You just need one instrument to grab this and take it out. Okay. Grab it. Ratchet it. Can you hold the camera? I just, if it has a ratchet, you can lock it. I just need to use both the hands to twist the meniscus here, so that whatever the remaining 10% which we left will snap. It snapped, and the pieces come out. You can see the piece. And the remaining flaps are still there, so we need to debride those flaps without damaging the remaining meniscus over there.
So that is a nice way of accessing the bucket handle tear, partial meniscectomy, where you address the posterior side first, don't cut fully, leave a 10%, then come back anteriorly, detach it, then use this and you can rotate it and to remove that last 10%. If you detach the posterior first completely, then it will be wobbling here and there. Very difficult to control your anterior side always. So always try to don't excise the posteriorly first.
Meniscus is quite hard in this case.
Yeah. And always it's tricky to do a meniscectomy in the anterior horn.
Shiva? This is the blade material, the blade experiment. Tips for using the shaver in the meniscus. One, you should, when the compartment is narrow, don't use the serrated one, use the non-serrated. But you have to expose some raw, if you're using the shaver on a intact meniscal surface like this, it won't shave. So take some few bites where you expose some injured or ragged edge, then the shaver starts working.
Correct.
So you can chew your meniscus slowly and remove it piecemeal also. So the initial cut helps us to take away the fragment. As you saw, it just took it away. So you have to have some raw area to start your shaver to work. Here I've changed over to the serrated, which is not usually used. See, this is a
You can
serrated.
use a wand also, the diathermy wand also will be help to smoothen that, because that is more flexible than your shaver blade.
It is important to take away this corner because that's going to act as a stress raiser, and it might create new flaps. Saline. Okay, this is saline implosion again. Oh, okay. Okay. Here, if this diagonal doesn't work, again switch portals and get your shaver from the other side. That's one option. Shaver, just so using your viewing and viewing portal and working portals effectively is key in managing such anterior, especially in the anterior part. So sometimes you might anterior part you might need a third portal or a portal more further medial, I mean further lateral. If your instruments and shaver is not reaching this part, then probably you need to make an accessory lateral portal, anterolateral portal, to get it further away. As you see, now your shaver is in a better position to shave away that apex. You can see that that part has gone away. Well balanced. Okay, I'm switching it back. On the shaver, a bit, lot of fragments are there. Torpedo on the single oval. So now going back to the smaller opening, because I'm going to go back, right? So if you use a serrated blade here, I might do more scratching of the cartilage there. So I'm using a non-serrated with a smaller oval opening where it's not going to damage your cartilage or remaining meniscus. So now we can see one good meniscus which probably is okay for repair.
I think we can repair,
Yes, sir.
we can freshen up and because it's almost meniscocapsular junction.
So we will rasp. It looks a little bit chronic, so I'm using the rasp to freshen it. So when you will come across these chronic tears, always use, these are diamond rasps which freshen this tissues over there, something like freshening the scar tissue, fibrous tissue, and stimulating the surrounding synovium, which enhances cells over there. There are other ways of doing this. You can do trephining or vascular access channels where you pass in needles from inside out or outside in and create channels. But in this case, we are not too much worried because we have made big tunnels for the ACL. So there is a lot of BMAC cells which actually enhance healing. That's why Palni Rajan sir was saying when you do a meniscus repair along with an ACL, the chances of healing are much, much better. So this freshening must happen both in the fragment side as well as in the peripheral side. You can see bits of those fibrous tissue which is covering or flying away. So now we need to plan our repair. Posteriorly, you might need an all-inside for the posterior most part, but our main robust fixation is going to be achieved by our inside-out sutures here. So our cannulas need to come in from the opposite side. So if you get cannulas from this working portal, your angles will not be right. So you have to get in your, again you have to switch. Your viewing portal is going to change. You're going to go to the medial side for the viewing portal. The 40 degrees cannula. So as today's events by Australia, they have a lot of innovative equipments. This is the cannulas from their side. They have 0, 15, 30 and 45. I am using the 45 degrees angle cannulas. So these cannulas are single lumen cannulas, zone specific, rather the zone that is degree specific. So from using these cannulas, we are now using those double loaded Can you see the outside picture? Can you see the needle?
Yeah, we can see it. They can.
Double
Yeah.
loaded needles. Two ends of the threads are loaded with needles. There are other needles also. We'll show. This is the conventional way of doing regular, usual way of doing the inside out. So when you're getting your cannula, so when you're moving back and forth in this, be wary of your tibial spine. So if you want to go back, go behind the tibial spine. If you want to stay in front, you come in front of the tibial spine. So first is to get a good reduction suture so that the meniscus falls back behind, then so that the other sutures, extension. Okay. Other zone specific cannulas actually have two curvatures. In these we just have one curvature. Try to do some tricks here. It is not reduced well here. So this is a reduction suture. Extension ma, your counter should be good. Extension call to kuno. Okay. Poma. I need ulla panana direction matra. Wait. Enjoy வெளிய எடுங்க. வெளிய எடுங்க உள்ள போங்க. Okay, போங்க. கொஞ்சமா போங்க. Okay, stop. I'm trying to raise this.
So what Santosh is trying to do that, with the needle, just prick that loose fragment, then you take that with the needle and reduce it.
Joysticking.
Joystick. So you can see where is the superior margin of both the bed and the fragment.
Okay, pull. Okay, first suture is done. Next one is in the capsule, which is going to be extension. 1 minute. Camera bring. Opening is not. Good. I'm trying to go above that flap of meniscus so that you get good reduction. Yeah, okay. It's facing upwards, it's okay. This as is the reduction switch, I want the meniscus pulled back. Okay. Okay. So meniscus is pulled back and staying there. Now you'll have good amount of pull on the meniscus, so you can take further bites up and down, and it will be much easier. Double load ready. And the port the tension கொடுத்து பிடிச்சுக்கணும். நம்ம டென்ஷன்ல பிடிக்கணுமா? அந்த டென்ஷன்ல இருக்கு. Wait. So down is not. It's moving around a bit, so I'm not comfortable with taking purchase over there. So you can see the bevel. How is the bevel? In that one, the bevel was different. When you have bevel facing one side, it makes things much easier. First. So one bite going through the fragment onto the base of the capsule. Okay, pull panikala. Okay, I've actually, if you see the outside picture, they are using the same needle, cutting one needle off and using the needle. And if you see this needle, can you see, zoom the needle? This is a open-eyed needle, you can see. So the free end of the other needle thread is fed onto this one. So we are using the same cost-saving method. So we are using the same double arm needle thread for two switches. Yeah, pola. one more double arm. So it's lifting up, so I want to put one down there. So that I want to go back and do something there. Middle good posture good thing.
Middle.
Okay. The pinna report is real to pitch come. No. Okay. That's too far close to the periphery. I don't like it there. Yeah, follow. Other thing is to pass it inside a bit, then use your cannula. Again, joystick. Follow. Okay. Oh. Posterior cannula. So what we've used is a middle cannula, among the zone specific. So I cannot go back further with the middle cannula. Posterior. I'm using the posterior cannula here, which is from the zone specific cannula system. So here, if you go behind your tibial spine, as you see here, you will be able to reach up to there. So I'll try to get one on the inferior surface now. கடைசியா போட்ட கீழ இருக்குறத இழுத்துக்கணும். அது இழுத்துக்கோங்க. போலாம். மூணு மேல் தானே ஓகே. So pulling the other threads is the key to get the bite going in easily. போலாம். Go. It will be a little tight angles. The needle will struggle to get through so much of soft tissue. So now you can get it right to the capsule also, or into this fragment. Anything is fine. I will try to take it to the capsule. Voila. Speed. So we got some force sutures to stabilize the meniscus. We need to add few more to stabilize it further. You can have one all inside there to keep it fixed to the capsule in a different direction. Here we need few more on the inferior surface. Here we'll try to demonstrate another variation from osteocare. Under the eco stitch, which is a hybrid again. They come up with so much hybrid. It is a hybrid of inside out and an all inside. I'll try to show you if you want. Show you. Open. Outside camera, please.
Santosh.
Yeah.
Yeah. What's your opinion of using scorpion at this anterior portion? It is very much wider.
Scorpion, you are going to take a bigger thread. Anterior, you can do an outside in or inside out.
Okay.
Scorpion, I just got 1 centimeter further to stabilize. I'm almost in the shoulder right now. It's the shoulder. That's the end of the meniscus tear.
Correct.
So there, I don't think scorpion is required. Can you see the outside picture? This is the system where system where
yes,
there are
we can
two
see.
inside out system.
Yes.
And there are two. These are the all suture anchors, which will act like the peak in our all inside devices, and then we can tighten it. It is slightly complicated.
So this is all inside.
It's inside out, but behaves like an all inside.
Inside out.
You don't need to tie the sutures outside. So you're not going to tie across any nerves or any structures, which Dr. Karthik was mentioning. So, but this needs a separate cannula system, which cannula, double lumen cannula is required. Slotted cannula system, because both the threads go into one mechanism. Let's do it one by one. இப்படி இருக்கணும், கையில் எடுக்க வேண்டாம், அப்படியே இருக்கணும். நீ இப்படியே வச்சுக்கோமா. So cannula, I'll show the cannula. This is the double lumen cannula.
Outside picture is big.
Yeah, the double lumen cannula, which is which
Can
has
you
a
show the slot?
slot on the inner side.
Yes.
Can you see? I can't see here. You can see better than me.
No, this is not slotted cannula. I don't.
That's what, the slot is here.
Yeah. Yes.
Along the slot, it is slit
We can see
throughout over there. So the thread falls off after we pass the first needle. Let's see inside. Let's see how it works out this time. Oh, that we didn't do. Okay, that's one more. Marking pen.
Santosh sir.
Yeah.
Dinesh here.
Yeah, Dinesh.
When you go more posterior, is it advisable to use safety incision and put on retractor and then get back the needles, or with your experience you are going just like that? But for my, just I'm asking for the safety purpose.
Yeah. Medially, there are not much of risk factors over that. Medially, whatever you're going to encounter is the suffiness.
Okay,
how much ever posterior you go. So medially, it's not a problem. Lateral is the question. So how much ever posterior you're coming, you're not going to go to the midline anyway.
Okay.
So it's away from midline, it's all fine.
Okay.
Lateral is the problem.
Thank you, sir.
Okay. Pass. அது வெளிய இருக்க thread anterior thread இழுத்துக்கோங்கமா ஒரு கையில அது அப்படி பிடிச்சுக்கோங்க. பாஸ். Okay. பாஸ்.
Santosh sir, Terence here.
Bring the distinct. Yeah, Terence. Please. Yeah, Terence.
We want to see the outside picture as a bigger image, please.
Yeah.
Yeah.
You can see that? So the first needle is being passed. So pull the first needle till the entire needle comes out. Wait பண்ணுங்க. இதை பிடிச்சுக்கோமா. You take care of this one. No, this. Yeah. Okay. கொஞ்சம் இழுத்துக்கோங்க வெளியில. Okay. Till this light. Can you see till this anchor comes till this point? You stop there. Take your thread out of the slot. Can you see the thread coming out of the cannula?
Yes.
And it should come out intra-articularly also. இழுத்துக்கோங்க thread. வினிதா இழுத்துட்டீங்களா? thread இல்லைங்க, இந்த பக்கம். சரி, அந்த பக்கம் இல்லைங்க. Okay, it's come off. Might not be fully, but it's come off. That should be good enough. So our second needle has to go in now, so that doesn't tangle. இது வரல வெளியே வரல. இங்கே இழுத்துக்கோங்க. இன்னும் கொஞ்சம் சொல்லுங்க. Okay. Okay, second needle.
Sir, how much did you pull that thread? Like you want the anchor to go out?
No, now we've not yet pulled it. Anchor is still lying in my side.
Okay.
Just the needle has come out. Anchor pullage comes in the next step.
Okay.
The needle out. Needle is coming out till the anchor enters the cannula. Pull.
Okay.
Can you see that cannula?
Yes, sir, very clearly, yeah.
So now, again, I am pulling it out of the cannula. Okay. Slotted. My cannula is coming out. So from now on, you don't need cannula. You just need to keep pulling these two. Now is the challenge to see if camera. The system is working. So here, can you see the outside picture? The thread comes up. These are the pulling threads for the all inside. This stays with Deepak. Hold this one, okay. So there are two, okay, there are two anchors there. We have marks in the anchors. So we have to keep pulling these anchors till we see the mark intra-articular. Got it? Hope I am clear. Now I'm
Sir, how much is the mark from the anchor side? How much have you marked?
2 centimeters.
It's standard.
Yeah, that's what Bhavik says.
Okay.
That's the length of, I mean, it depends from the capsule to the meniscus.
Okay.
You get the anchors close by now, so both anchors are staying there. Now the challenge is to find out whether these come through these holes outside. So attention onto that. I'm pulling it out. Yep, it's come out. A mark is come out.
Excellent.
I'm stopping there. I want to pull the green also, the other anchor out. It's through the meniscus. Yeah, it seems to be working. So it should come out of the meniscus. Hopefully it's outside the capsule. Now comes the phase where we are going to tighten it using these two. Putting a camera. So now it is like a, adjustable loop. Outside we have two threads. As we pull those threads, this is getting tightened.
Sir, Ajay here, sir. So
Ajay.
when you are pulling the threads, do you need to pull both the threads like as you did sequentially, or does it alter the tightening mechanism?
Sequentially, both gets tightened. Then only our all suture will bundle up. That's an all suture anchor, right? It has to bundle up. The broad anchor must become a ball.
So, when you are putting in the anchors, the outside sutures where the needles are, so we can pull both the needles simultaneously.
If you pull out too much, it will come outside the skin. That's my worry. So I'm not pulling it the other end. I'm tugging it to see how tense it is, and I'm pulling it. It is quite strong. So this knot is finished and final.
Very nice, sir.
And these two threads, you can cut it, or you can further again use a free needle and use this for further sutures. So in this situation, I don't want to do that. I think I got good enough fixation in the anterior part. Probably we need one in the lower part. So cutter. Cutting it, huh? Okay.
Dr. Santosh, Dr. Karthikeyan here.
Coming there.
Sir, when you are repairing, how important you feel is to maintain the shape of the meniscus. We see that sometimes when you do this, it's slightly bunched up now. So,
correct, exactly. Not very happy with the shape here. If you want to, this thing to work properly, unloading effect, it must maintain the shape. But it is already rounded off. We're just trying to salvage whatever is there. But the shape is not. It's because already half is excised.
Because this portion may not, we don't need to worry about the shape. Because when you do a full bilateral repair, where at that time the shape is important to evenly distribute all the hoop stresses. And this is only just a rolled out, even like whenever you see a red white zone tear, bilateral tear after doing a partial meniscectomy, in the chronic cases you will see this kind of shape. So that's not going to affect the stress on that. But anyway, you need to do some more. It already is everted because this was tightened.
So for that, yeah, correct. It's everted. One more suture on the lower
side. One more
surface.
stitches on the inferior side will be better, and he is going to do. And Santosh,
sir,
live surgery time is up to 1:40.
So what can we show the?
No, then we can have till 2 o'clock. We can go ahead.
So that will finish that. Now we will show the all inside for the lateral side after cutting the thread.
Yeah.
We'll go to the all inside part of it for the lateral.
All inside. Then you do the ACL and probably we can finish it with that 2 o'clock. You do show the all inside, then you can pass the graft with
pass the graft and then finish the medial side later also. I think the sutures here is a challenge. Okay. So we'll go to the lateral side. All inside open, please. One more thing we can show here, other thing which the company the advantage of this is you have two sutures coming out from the needle. Can you see the outside picture? Outside picture bigger. Can you hold this? Can you hold this? Outside picture mattum coming, inside picture venda. So this one, there is a needle. So scissor, knife. You can cut and remove, but the other thing is needle putting. You can cut one and remove this needle. You got one more needle with the long thread. You can use this for putting couple more sutures. So the remaining sutures, whatever are there, you can use the same system threads. So with this cost saving, opening of one implant device, we can place four sutures probably, without any incision on this side. See, this comes off. So there is table reduction over there. Okay, let's go to the lateral meniscus now. So we have to rasp the lateral meniscus before we place all inside. Again, rasping the lateral meniscus. Do not forget rasping or freshening the margins. Internal rotation. So here now I am not able to see inspect or flexion. There is no internal rotation in the leg. Internal rotate. As you internal rotate, you would get.
Santosh sir.
Yeah.
As you continue the repair, just want to ask you, you have one technique where you get, for all your inside-out sutures, you get it through the graft harvest site and tie it.
Yeah. These remaining, those other inside-out, we have to take it out through the same. So at the end, I'll show that also probably. So all the other remaining threads have to come out through the ACL harvest, hamstring harvest site.
Okay.
So freshening it. It's again hard meniscus, probably a very chronic tear. Tourniquet time? Enough? Device coming? No, okay. So the all inside device is similar to the. Okay. Can you see the device? Similar to Striker Air. Wait. Okay, sheath out. So as you all can see, sheath is required to keep all these peak implants in place. It's quite a long tear. You can place it horizontally to reduce the cost, but I would use two all insides here because it's quite a long tear. One goes in the anterior part of the tear. You release and deploy the first one, twist and pull it out so that the peak stays inside. The first peak is deployed, and the second peak, let's go to the capsule as much as possible, at least a vertical mattress. It's going to the popliteus, missing the popliteus and going down. Okay.
Sir, what is the length of the all inside you kept initially, sir?
It was nearing to it. I kept it at 20 only. 20. I don't go below 16. If it's a really small knee, I go to 16.
Okay.
18 to 20 is the size which I prefer to keep.
You always miss the popliteal tendon, sir, or?
Yeah, try to miss it because the failure of deployment is there when you go through. You can go through that, but it doesn't get deployed sometimes. So I try to miss it whenever possible. If not, it's okay if you don't able to. Pull pannu, koncha pull pannu thread. Slow, look up and pull. Pull. Relax. Okay. As you can see that lifting up, that's why I'm loosening it a bit so that the meniscus doesn't lift up. So now the question is whether the second one has to go inferior surface because it's lifting up. But passing all inside on the inferior surface is not simple because your curvature is different. You need a reverse curve ideally to pass it easily. Hold. Don't. Straighten it. So, probe. Let me assess again my angle of approach, whether flexion ma. Flexion. So my second one has to go there. Whether working portal must be this side or we want to switch it, all of that helps with the probe. So either you can go this way, or if possible you can go there and second one. Well, let's try the inferior surface. I think it's possible.
So any tips to avoid encroaching on the tibial spine when you're addressing these regions?
I think she thought. So sorry, Dinesh, I didn't get you.
Sir,
Avoid the tibial spine. Tibial spine is away. I'm far away from the tibial spine.
Okay.
In this case, the tibial spine is actually not so prominent. Sometimes it will come in the way. So in those situations, you might need to use the reverse curve.
Okay, sir.
So this might be going to the, yeah, this bite is good. Call open pannu. Not gone the full, yeah, okay, it's gone nearly 18, it's about 20 now, 20. Can you see the mark 20?
Yes, sir.
2 is 20. Deployed, I think 20 is enough. Hopefully. Slightly tight to come out. Hopefully the second peak comes out well. Okay, here is the button. Stuck in the soft tissue. Yeah, okay. So now we have to go to the capsule right at the back. Okay. That bite is okay wherever in the capsule or in the peripheral fragment, anywhere, this is okay. Okay, see the first one has actually gone through the upper surface and then gone out, which is actually good. So tightening, if you have worried about cut through here or the peak coming out, lift up. You can always place your probe between the sutures, then tighten. Pull ma, tighten. Slow. Pull. Your target is not to over tighten too much. You just need to keep them approximated, like any skin suturing. Don't tighten your skin sutures too tightly, just to keep them approximated. Similarly, just to keep them approximated. Hold. Okay. 2 sutures done is all inside here. So let's move on, after cutting this, move on to the ACL part of it. ACL tibia ma. Cut 2 threads. I've actually kept, I feel a little loose with those knots, so I've kept a lot of thread remaining, so that doesn't de-thread. Flexion. So let's, femur is done, let's go for the tibia. Tibial tunnel jig. So there are various jigs for the tibia. This is an elbow aimer, as you can see the line over there, or there is something called the tip aimer or aperture aimer. Based on that, your positioning on the footprint will change. Mediolaterally, 2 spines are there, so it must come somewhere in the center over here, in line with the posterior border of the anterior horn of the medial meniscus. Lateral meniscus. So exit point should be there. So as this is an elbow aimer, I'm going slightly back. Push. It seems long here calculation, but long is okay because we are planning for we must length is 7.5, so our plan is to put a suture disc, so our graft must end inside the tunnel on drill.
So for femur, you told the trajectory is around less than 45 degrees. For tibia, is there anything like from the midlines?
Tibia, we say, I mean, setting this thing is set it at 55. 55 is the universal mark. So usually 55, size of the knee, based on what graft do you want. With pediatric, you want a more long tunnel, so you have to come down. But the entry point for the tibia, some literature say that 60 degrees is the mediolaterally, but doesn't matter. Our aperture inside is the one which we should be worrying about, not the entry in the anterior tibia. Your exit point in the tibia is more important.
Okay.
Unlike femur, our entry point is more important, but tibia exit point is more important.
Okay, sir.
Drill. You have to check for the impingement. Slow. So hold the thigh. Flexion. Yeah, it is slightly anterior and slightly medial. As I'm going for a sequential trimming, I'll accept the position. I'll go for 6, then make 7 and 8. So that I'll come slightly lateral. We have a paper on this eccentric sequential trimming, where about 2 mm changing of the center point is possible by this eccentric trimming. So initially your this thing is coming there. I think it's okay. Still, we'll go for a 7 and 8. Yeah. So you can have ply of this much either side. You can lay over it and bring it further medial. But this looks central. I'm not trying to change it. I guess you are breaking for lunch.
Santosh sir, everybody is eagerly seeing your surgery. We have still not. Nobody is feeling hungry in the
You're not serving
auditorium
lunch
yet.
7 done. Going for the 8. Here, 8. So as we are using the suture disc here, as I said, tensioning is difficult when you tie the knots. So we will use the fixed loop clipping part done initially. Then the adjustable loop part of it, where we tension it, to be done after the distal fixation. So that our tensioning is better. That's one of the indications for adjustable loop, is what in my practice at least. Otherwise, in my practice, it's always fixed loop. The serrated blades. So shaver blades, you must know when to use which blade. Use those blades. Be aware of what blades are available. If you use a smooth blade here, those will get damaged quickly. So lifetime of those blades will reduce. Leave as much footprint as possible here. It's not going to impinge. Similarly, I opened out the mouth with nibbler so that the passage of graft is easier over there. So, bit pin. Okay. Beat pin. This is a pin which is used for shuttling of the graft flexion. So that it goes into the 4.5 tunnel. Yeah. Cool. Can you see the outside picture? Top view. So thread comes out. Vanita is not letting me take it. Graft ready, yeah? Retractors, correct? 1 minute. There color marudha. With the first white first. White. Okay. So we need to know which thread is the leading thread and which is the lagging thread. I'm taking the white first, white tiger first. Quite a bulky threads coming out. What size is it? 2 yeah. Camera please. Relax. All these threads, it's a 6-strand thread which is coming out through a small hole. think we need to make a nick. Is it okay? Nick helped. பொறுமை இல்லைம்மா இருக்கும்மா yeah. So I'll come this way, Dinesh. So hold the scope, Dinesh. So Dinesh is holding the scope. This is viewing from the lateral portal, but for adjustable lobe, for us to make sure it flips correctly, we usually switch portals. But here this is behaving as a fixed lobe. So our leading thread is going to be, the blue you see is the lagging thread. So white was the leading thread. For you to show better, so the thick white is the adjustable lobe. The tiger white, which has the black lines, is the leading thread, and the blue tiger is the lagging thread. So I'm flipping, advancing, I'm pulling all together right now. Straight artery. I'm pulling all of them together. Mark engama? Mark is the white, violet. Which one? Pull down. Okay, so there you can see the mark there. That mark is 5 mm further down. So only if you use your pull panunga, it actually went inside the full length. Pull down. So if it's going too much inside, it will flip in the soft tissue. So I just want to, it's a 20 cl as per now. So it will flip, but I don't want to flip too much into the soft tissue. Okay, I'm flipping now, and then tensioning. For flipping, I need to pull the blue. Okay, it's flipped. Good flipping, pull down. Yeah, now this is quite tight, no flipping. But there is further 5 mm where you can pull it further, probably 3 mm maybe, using this adjustable loop. I'm not using them now. I'm going to fix it distally, then do the tensioning part of it with this adjustable loop. So the button is seated in the lateral cortex now. I'm going to do a distal fixation now, then tension it for the adjustable loop. I'm taking out the scope. I need to. Nibla? For suture disc must sit clearly onto the bone. So I'm clearing the periosteum. This is a 17 mm disc. Tunnel loss 8. So hopefully, and the disc you can place the disc and see if it's seated nicely. Am I freshened it enough? A little more freshening required. Okay, button. Feeding the button now. Slot to the, it's okay, slot now. The second put slot slot. Okay.
Sandosh.
Sir.
Because it's a peak material.
Sir.
Is it advisable to use a hybrid fixation? At least smaller screw can go inside and put an additional suture disc as an additional fixation, or?
I've used a fiber wire thread here.
Okay.
Graft is a centimeter inside. If you want me to use an additional screw, we can use it, sir.
That will give us some more extra security, because it's a peak sometimes can break.
Okay.
Or a 23 or a screw that put it up.
Okay. Screw.
Stable only.
9 size screw. 9 into at least 23. 925. 925 screw. Okay, we'll keep this here. We'll put the screw, then come back and put the dual fix. What sir wants the dual fixation. If you're not confident of your fixation strength, dual fixation is the best.
Thanks, Santosh.
Yeah. Straight artery. So now, before we fix, I just want to test it. Now we are going to put a screw. So we are going to go a cyclic loading, tensioning, and then fixing with the screws. 30 times. Keep this with you. Keep this with you. Okay, keep all the arteries close to the thigh. Yeah. 30. 1, 2, 3, 4. 20. 30. Okay. Retract. Section 10 la idu nikka vekka mudiyuma. Bolster. Okay. So section. So you can see the graph there. So our target will be to fix deep inside. Okay.
Santosh sir, it's always very scary to do a cycling after doing a meniscal repair on both. Do you always do it?
Yeah, definitely. You have to have a stable ACL, right? So trying to save the meniscus, ACL is lax. Means no. You're not in such a bad repair, I guess.
No, sir, not definitely. It's, I think, probably the best that we could get.
Okay, good fixation there. Screw is next to the scope coming. Have a look for you. Can you see the screw and the graph next to that?
Can you show the arthroscopic view?
This is the tunnel scopy where you can see the screw and the graph. Arthroscopy just to see whether the screw is exiting there, flexion.
That's good.
Probe. I placed the screw lateral here, so expect it to come somewhere there. Nothing palpable. Tunnel is quite long, sir. 25 screw, more than 45. Should be okay here. So I'm going to place the disc now, then come back to scoping. As this is fixed, I mean, this is just a dual fixation. Adhe mari bolts vechikala. This goes inside. No.
Can you change the picture? Audio visual.
Outside view, theriyala pala. Retract is coming in the way. Yeah, okay. Putskoga. இரண்டு படிக்கிறீங்க அதெல்லாம் போடுறேன் நான் அந்த பக்கம் போடுறேன் நீல ஹோல்டுமா. So unlike when you put the screw, you were able to give so much tension onto the threads. When you're putting this kind of knots, such amount of tensioning is practically not possible. So that's the reason I'm saying we will tension the adjustable loop after we fix this one.
Santosh, we are still seeing the live surgery. We are going to still continue that till you finish it. Meantime, we are opening for lunch, because the next live surgery we should start at 2:30 at least.
Yes, sir.
So
after this, I'm just going to
Yeah, you're going.
A few sutures for the
Yeah.
Meniscus, and the
Yeah.
adjustable part of it I will need to show. You continue with the lens, I'm here. I'll finish with that.
Yeah,
What's
yes,
the
yes.
time? 1 hour 38 minutes. So
Time
we'll
is
finish
now
for 2 hours.
2:05.
Hmm.
So the next live surgery will be at 2:30.
Ah, okay, sir. 15 minutes will be done.
Yeah, yeah.
Okay. மூணுதான் போட்டாங்க
Santosh.
Now, Scopy. So we've fixed the distal in good angle, retaining the angle, then watching the. Can you keep seeing that? Whether we can have the adjustable loop further, quite tight already. We'll just check if it's possible to tension. Left and right.
Sir, Ajay here, sir.
Ajay.
So you did eccentric reaming on the femoral side, the femoral tunnel.
Yeah.
So you did it free-handed. So is it possible to do it with the guide wire on?
Then you cannot go eccentric. If the guide wire is there, it is going to be guide wire is going to stay central, and you are going to ream it all around only. So only if you don't have the guide wire, you can go to one side.
But without the guide wire for beginners, there is a chance of misdirection of the reamer is.
Totally different tunnel. Yeah. We have totally different tunnel. Chances are there,
Okay.
but you must take it a path where it is soft and not to diverge it too much. Probe, I'm not able to tension it. We're already in good tension. Only minimal movement was there. This graft is in good tension. So that is good. Lateral meniscus is done. ACL done. Adjustable loop is pulled, and we'll see how much more switches we can put for the medial side. Probe. Let's see how much unstable. The middle third, hardly any meniscus is left. I'm not happy with this probably, but posteriorly something is left. Thread chiltukonga. I'm happy with the number of switches. Do you think you need more switches? Maybe one knowledge said there, but for this amount of meniscus, I think maybe this is rolled up as you were saying. We can put, we have needle. We'll put a couple of lower switches just over here. Because it's rolled up. Needle irukuma? Yeah, I'm just adding a few switches in case we have any cutout there. I'm just worried about this switcher there. Right, middle. இருக்கிறதே போடுங்க போல்ட்ஸ் கரெக்டாக இருக்கணும் போல்ட்ஸ்
Sandhu sir?
Yeah.
Like we are breaking for lunch actually. Most of the audience have gone. We don't have a separate screen.
Okay.
So just wanted to thank you, sir. It has been like a wonderful live surgery. We learned a lot. It was a very complex case, and I think if somebody could do justice to this, I think we've got the best man in Coimbatore to do it. So it's a great. It was like a treat to watch you, and we learned a lot out of the surgery. So I think
thank you, Terence, for the
whoever
generous.
is there in the hall, please give a round of applause to sir and his team there. It's really wonderful.
Team, Ganga team here. Thanks to the entire team here. Thank you, Terence. Thank you, Sundar sir, and thank you, Ramakant.
Thank you. We'll be starting the next live surgery at 2:30. So we'll see you soon.
How long will the counters be open, Terence?
Sir, for you, counters are open 24/7, sir.
So I have two options. Already lunch is ready here. Ramakant sir in lunch, so what shall I do? I'll be there after.
Right. Bye, sir. See you. Bye.
Bye-bye. No. நீல் இருந்துச்சு போதும் அதோட போதும் அந்த இது கீழே வெளியே மாட்டிட்டு இருக்கு அது கட் பண்ணா இது லூஸ் ஆயிடும் அதனால இப்போ போட்டுடலாம் Pat kai.
Hello, Ramakant, are you there? This is Suman here.
Ramakant sir? Ramakant sir?
Ramakant, anybody in the Ganga OT?
Sir, just a minute, sir.
நான் போய் எக்ஸ்பிளைன் பண்ணணும்.
Ramakant sir?
Hello?
Yes, sir. Your mic on, sir.
Yeah.
Hi, this is Suman here. Karthi is also here. The audience
hello,
have
Suman.
gathered after good lunch.
Hello. Yeah, lunch is over.
Lunch is over, boss. We can start.
Yeah. So we can start.
Or maybe 2 minutes, little more crowd.
Yeah, okay. Okay.
Just 2
We'll
minutes.
wait,
We'll alert you.
Yeah,
Thank
no
you.
problem. No problem. We'll wait for 5 minutes also.
Thank you.
நான் போய் எக்ஸ்பிளைன் பண்ணணும்.
Sir, irukanga, sir.
Hello, Ramakant, Suman here. Shall we start?
Yes, sir.
Yeah,
First
please.
first give it to the case history.
Hello, good afternoon everyone. So we are starting with the live surgery case 2. So here we have a 50-year-old female. She had a complaint of left knee pain since 3 months. She had a history of trauma, fall at home, slip in the bathroom 3 months ago. On clinical examination, the range of motion was 0 to 120 degree with medial joint line tenderness and McMurray is positive. And there was no medial lateral and anteroposterior laxity. On clinical photo, this is the alignment of the patient, pretty neutral. Then this was the gait. On the clinic, on the X-ray, There are no marginal osteophytes and any advanced articular osteoarthritic changes. Then on alignment, right was in 5.3 degree varus, and operating left leg was in neutral, almost 0.9 degree varus. Then on alignment, MPT and LDFA was pretty normal. Then on the MRI, as you can see on the sagittal section, you can see the ghost sign, which is suggestive of the root tear. And on coronal section, we could see the truncation sign. And on MRI report, it was a medial meniscus posterior root tear with 2 mm extrusion. So we planned for a arthroscopic medial meniscus posterior root repair using root fix anchor. Over to Dr. Ramakant sir and the team. Thank you so much.
Yeah. Good afternoon, Suman.
Yeah, good afternoon. We are all eagerly waiting.
Yeah, sure. So as you've learned the history about this patient, this is like 50 years old with a history of pain for 3 months, and you can see the classical truncation sign. There is a gap here. So usually we see the dip in the meniscal, so that shows that there will be a root is avulsed from the attachment. Okay, and also you can see the classical ghost sign here. Okay, and so we'll be using this set here. Can you show here? Yeah. So this is the set from Osteocare where there is a complete, the instruments are there. So this is the drill bit which will be used for transtibial tunnel. It is 2.3 mm. And this is the crosswire which is used to pull the suture from the portal to the anterior surface of the tibia. And this is the loop wire. So loop wire will take the all suture anchor. Okay. So we'll open this set. So this is what we'll be using it. Okay. So this is the all suture anchor. So we'll be using it for the root fix. Okay. So, and this is the loop wire. And they have a special cannulated pin through which we'll pass this cross wire. So we'll show you that how to use it. So we'll use it from the anterior surface of the tibia to the root and then shuttle those wire out through the portal. Okay, so now I've already done the diagnostic round. Okay, able to see my scope? Yeah. So this is a suprapatella pouch. Here you can see there are some cartilage grade 2/3 in the patella. Trochlea was okay. And coming in the front, so this is the age appropriate ACL. Here we can see that. And now going to the medial compartment. So there was no varus in the knee. So varus alignment of the knee will have the tight space. So this was a neutral alignment. So I didn't have to do any of the pie crusting. So we had a good space. I think this space should be good enough for us to work. Okay, so you can see the root tear here. Can appreciate, Suman?
Yes, Karthik here. We can appreciate the root tear very well, Ramakant.
Yeah. So this is the attachment of the root. So that is the footprint area. So it is usually about 9.6 mm posterior to the medial tibial spine. So this is a medial tibial spine. So it's 9.6 mm posterior. That's the anatomical attachment. And also in front of ACL, if you consider, it should be around 8.6 mm. So these are the measurements from the Laprade paper. So this is the around that. Usually it varies about 4 or 5 mm plus or minus depending on the size of the knee. So this is where our tunnel is going to be there, and that is the attachment of the root, and we can see that it's nice rounded root here. Because it is 3 months old, so it is nicely rounded off here. So here cartilage, there are some cartilage changes here, probably grade 2 to 3, about 40 to 50% of thickness of cartilage is gone. ICRS grade 2 to 3. So now we'll proceed with the tunnel. transtibial tunnel, and then we'll show how the all suture root fix anchor is deployed. So can we proceed? Any questions now?
Please proceed.
Yeah. Okay, so we are using this standard ACL JIT, and just I'm keeping it there just beyond the attachment of the root, so that the angle makes it, the entry in the tibia to be just around that root point. Okay, yeah. Come behind me. Yeah. Yeah. Put. So we mark it with the skin, then the sleeve goes in, and the incision is done, and then the sleeve goes in. Okay? So this is the 2.3 mm drill pin which comes with the set. Yeah. Can you go? First cortex is gone. Yeah. Yeah, just pull it out, little pull it out. Yeah. Yeah, take it out. So we have to keep the sleeve, because otherwise we'll lose the hole. And then we pass this, special cannulated, cannulated seed which they give. Okay. And now we can take off the sleeve. So we have the hole in place, and then we take it off. So can you all see? Can you appreciate?
Yes, Ramakant, we can appreciate.
Yeah. So now I'm taking off the, slightly pull out the, now I'm taking off the ACL. So it just comes around that region. Yeah. So now we are passing that shuttle wire, or cross wire they call it. Okay. So that is to pull the suture. Okay. So that comes intra-articular. You can see there.
Ramakant, have you already prepared the bed where your drill is coming out?
Yeah, I off live I did prepare a bed little bit there. Okay.
Okay.
Off live I did prepare the bed there, so I can show you that.
Yeah, it's up. We are able to.
So you can see that beyond my the tip of that cannulated sleeve, you can see that I've prepared the bed. Yeah.
Yes, we are able to appreciate. Yeah.
Yeah, sure. So I catch this, and now you can withdraw a little bit the cannulated sleeve. Withdraw the cannulated sleeve. Yeah. Okay. So I take it here and then park it. Okay. I don't take it out of the portal yet, because I want to pass the cannula. So because otherwise all the soft tissue will get caught in between. So now what I do, I rotate my light source and then visualize. It takes a little time here. Yeah, so that's our cannula is coming. So you can use a flexible cannula, or the regular cannulas also can be used. The idea of using cannula is like for better suture management, and it doesn't get caught in the capsule, anterior capsule or things like that. Okay, so now I pass this flexible cannula. Flex the knee slightly. Yeah.
Any specific size for the cannula, or?
No, this is a flexible cannula. So you can use 6 mm cannula if you are using, the regular cannulas. Yeah. So now that shuttle suture comes, that crosslink wire comes. So then we pass this loop suture. So why it is called loop suture? It has a free end here, and then the other end. Can you show this? Can you show the outside picture? Can you? Yeah, can you zoom in? So this has the loop in the another end. So that's why it is called loop pin suture or a loop wire, loop fiber wire. So this loop wire is very important because we take it out. Yeah, now pull. Yeah, so now you pull that cross-link wire. So the loop wire goes in, okay? And now in this loop wire, now we are going to feed the all suture anchor or a root fix anchor. Sister, can you get it?
Can you zoom the outside part so that we can appreciate the
Can you zoom the outside part? So now she's going to feed it, and can you get it near? Yeah. So here you can see that. So we have marked about from the all suture anchor, we have just marked about 10 mm or around 13 mm, that blue mark. So that will tell us that when we have to deploy this anchor. Okay, so she has to feed this. So feed the fiber wires of the anchor into the loop anchor, a loop fiber wire, loop in wire. Okay, now I take this loop in wire from the outside, I keep pulling it until that, yeah, it's got stuck somewhere. Yeah, now it's coming, yeah. So I'm keep pulling the fiber wire. So now it comes out, okay? So now this anchor, the fiber wire in the anchor comes out. Now I again keep pulling it. So when I use this cannula, I don't have to get worried about, this all suture get entangled into the anterior capsule or the fat pad. Okay, because I'm using the cannula. Okay, so now I keep pulling it. Now we can see that all suture. Can you see?
Yes, we can see it, please.
Yeah. All suture, now it is just going to go inside the tunnel. Okay? So now it has to turn 90 degree there. Yeah. Pull it little. Okay? So now she is pulling it. My assisting sister is pulling it. Okay? So now I can take off this wire from outside. Okay? So now the anchor is deployed. So when you pull back like that, so it gets bulged up, and the 2.3 mm anchor becomes around 4 to 4.5 mm. Okay, you can see that the whole tibia comes. So that's a good fixation of the all suture anchor into the proximal aspect of the tibia. Okay.
Yeah, we can appreciate the good fixation.
Yeah. So now the challenge is there are 4 sutures are there. Okay. So there will be always a problem of the suture entanglement. So what do? I pass this scope into the cannula anteromedial aspect, and then I take 2 sutures through the suture retriever. So I want to park it away so that my sutures does not come in a way when I take bite or when I put the knots. Okay. So the color coded, so you can see the color either of black or blue you can pull. So I think I'll pull the blue out through the anterolateral portal. Okay, black comes, okay. I'll pull out the black now, okay? So I'm parking this black tiger into the anterolateral portal. And now I go back and then take my bites in the blue. Okay, so now you can see it is away. Okay, this is very important because this makes our life easier. Otherwise, there will be a suture entanglement around, and then it will be difficult. Now I pass this, self-retrieving device, that is knee scorpion. Okay. Now I have to take 2 bites. Okay, I take this posterior first one. okay, and then I pull it gently, and you have to keep watch over it. Suddenly you should not pull too hard, because the suture can get wound around by itself. See there, yeah. So that is what I was telling. So it forms that loop, so I had to undo that loop, because we never know how this sutures passes around those wires. Okay, so I had to pull out this wire so that I undo that loop. Okay? And then your assistant pulls that. Now we have taken that bite. Okay, now what we can do, we can park this into the anterolateral portal and then take the same thing, repetition. Okay, so now I'm going to take this black tiger into the anteromedial portal. Okay, and then put my scope into the anteromedial portal, and then I want to park the blue tiger away. Okay, can you give the suture retriever? Yeah. So now blue bites are taken, so I want to keep it away so that it doesn't come in my way of the black tiger. Okay, so since scope and everything is there, it's a little tight. Just pulling it gently. Yeah, can you pull away the loop? Yeah. You have to be careful, you have to pull the right threads, otherwise this is a all suture anchor, so you can unload the anchor also. Okay, so now my blue is away, and now I go for the black.
When you take the scorpion bite, just demonstrate to the audience, right? The small tilt you give to avoid hitting the condyle for the benefit of the PGs.
Yeah. So here we go. Yeah, so I've already taken the posterior bite. Now I know where is my lower jaw, and I see where is my upper jaw. And then when I fire the needle in the scorpion, I just give a small tilt so that the needle does not break after hitting the condyle. Okay, so now I keep pulling it slowly. So here again it forms the loop. So we need to undo this loop. Okay, can you all appreciate? So any questions at this stage?
Ramakant,
So we are undoing this.
the threads that you're using to take bite, are they similar to the 2 fiber wire that we use, or is it different?
This is 0 fiber wire. This is a very thinner one, 0 fiber wire. Okay. Yeah. So that is, the bites are done now. So now we are going to do the knots. So I'll come the other side, so it will be easier for me. You can leave the leg to me. Yeah. So today, Dr. Amrender, he's our fellow in Ganga Hospital. He is assisting me, helping me out for this case. So there are 2 ways to do it. We can put a sliding knot, but sometimes, it can cut the meniscus also. It can cut the meniscus, and then the cut through can happen. So we have to be a little careful. So which one you want me to put first? Actually, I think I'll take the blue first. Okay. So I have to shuttle this across and then shuttle that up to the other side. So blue, I'll shuttle it through the anteromedial portal, because my knots are going to go from the anteromedial portal. Okay, and then I want to keep this black away when I'm putting the blue. So I have to repeat this step. So, yeah. So I'm going to plan, this has to come below, so that when I put the blue sutures, it doesn't come in my way. Okay, so shuttling across is the portal is the best way to manage when you have 4 threads around. So You can see that, so blue is above the black, so that when I put the knot, it won't get caught in the black. Okay? Konja open pannunga. Yeah. Hold it. So this one I'll try to do a sliding knot. The meniscus quality seems to be good. If the meniscus quality is bad, then simple knot would be best way to do it. Because sometimes, see, this sliding knot, it has to turn almost the killer turn, what we call it in a PCL, that almost 90 degree. The anchor is deployed in the proximal tibia, and then this sliding has to happen almost, it has to turn 90 degree and then come there. So I'll try to use the sliding knot in this, we'll see. Hopefully I don't get the cut through of the meniscus. Because the meniscus quality seems to be okay, I just want to try this out. Because sliding knot will pull the meniscus across to the root, and then the better fixation can be achieved. Okay, so here I have knotted fully. No, suture retriever. So here it forms a vertical knot. So I want to put it like a horizontal one, the horizontal one. So what I do, I take this thread and then try to wind it around posteriorly, and then try to pull my meniscus little bit. So can you tighten it, sister? Can you pull that? Gentle, gentle, slow. Don't pull it fast. Wait. Don't pull it. So it just slides around. So we'll see one or twice. We'll see how it goes. I take this. Gentla pull pannunga. Yeah. Gentla. Some more. Okay. Leave it. It slips around. So I would like to have it like this. You are. So I just tighten it a little bit there. This is a sliding knot, so we have the advantage of, that stays there. Now I pass the knot pusher for the final tightening of the knot. So I was just pulling through the limb suture in the sliding knot, so that the knots get seated over the meniscus. Okay. So Amrinder is holding the camera. Yeah. So now I push the knot. That is the limb suture. Now I pull the other suture. Sorry, that was the post suture, and now the limb suture. Okay. I tighten it nicely there. Okay, and now the remaining half inches, one overthrow and one underthrow. So this is a very good system, root fix anchor, because when you want to combine it with ACL or HTO, the tunnel does not come because your anchor is in the proximal tibia, and for combined procedures, this is a good anchor to be used. Okay, so one overthrow, one underthrow.
So what is the sequence in the combined procedure? HTO first or the meniscus root first?
Meniscus root first. First, we'll finish off with the intra-articular work, and then when you use this root fix anchor, then we don't have to bother about the the transtibial tunnel, which will come in the way of our osteotomy or in the screws. Yeah. Okay, 100%. If you use this root fix anchor, we don't have to worry about it. Yeah, but in case you are using transtibial pullout technique, so what you can do is we can do the meniscal work. We can take bites and park those sutures in the anteromedial portal itself, and then we can do the HTO, opening the wedge, the plate fixation, and then keep the space little anteromedial region so that we can take out the sutures through the anteromedial. So first we can finish the meniscal work, and then park the sutures in the anteromedial portal, and then after the HTO, then we can pull out the sutures. That will be the way to go. So in this case, as you have seen that the alignment was just 0.9, and then there was no need for any HTO in this case. Otherwise, and also you can see the good joint space actually. So most of the varus knee, constitutional varus knee, they will have a tight space. So in which case we'll be forced to do a MCL pie crusting for us to operate.
So this case you hadn't done MCL pie crusting. It was already
lax. Yeah, there was a good space. Just with good valgus power of Dr. Amrenda, I was able to open the space. So yeah. So that is our first. Now we take the black, and then we are almost done. So any questions? Any questions from audience?
Anybody? Audience, faculty, anyone?
Yeah, actually I would have got that anchor a little more posterior, but each time I was trying to tighten it, it was slipping away anteriorly. But that's okay as long as the root is fixed.
Dr. Ramakant, Yugal here.
So that is the first and very important suture. So that approximates and then fixes into the bed. Yeah. Somebody was asking.
So when do you prefer to take scanograms in these sort of cases?
No, all cases we take. All cases it's better to take and just see how much of varus is there in these cases. So most of the cases will have a constitutional varus. So it's better to do scanograms for all the cases and then see, because that helps us in a two-way. If you don't correct the alignment and then just do the root repair, and then there are reports saying that your root can get failed again because of the constitutional varus, because there is a more medial loading is happening. So you have to unload the medial compartment. So that is very important. Okay.
Ramakant, we see that the root has now come back nicely to the original bed, but any concerns that the bulky non-absorbable knots are always going to be there on the meniscus in the long run? Is that a concern?
Definitely. That is a good question. Actually, what happens is, see, all the knots, these are very zero fiber, where all these knots gets synovalized. So there are, the second loop arthroscopy pictures, you can have it in, you can look in the YouTube also. There are like people who have done like HTO with the root tear, and they have gone back to look how the root has healed. So almost all these knots, they get synovalized. So that should not be a problem. And it doesn't cause, believe me, it doesn't cause any cartilage damage or irritation. So over a period of time, actually, it just takes 6 weeks for that to get synovalized. The whole thing will be covered with some kind of fibrous tissue, and then the body heals that.
Okay, yeah, thank you.
Ramakant, Suman here. No, the talk now is extruded meniscus, the body goes out extrusion, centralizing it back. Any experience on this technique used for extruded meniscus?
Yeah, so we have, we have produced 2 papers based on all, the extrusion and the root. So what we have found is, whenever there is a extrusion of more than 6 mm, so root repair alone will not be reducing the meniscus back into the tibia. Okay. So less than 3 mm, root repair alone will reduce the meniscus back into the tibial plafond. The gray zone, the gray zone, there is always a gray zone in all the conditions. Okay, so the gray zone is 3 to 6 mm. So 3 to 6 mm, it's depending on the case-to-case basis, then you need to add a centralization technique. So that is what the literature tells. So I've written a review article on the auxiliary procedures which is needed along with the root tear. So when we did a review literature, so that is what the present literature is concluding. But there is no real evidence to tell that whether centralization technique is needed or not. Okay, so here we can see that once we do that root repair, the meniscus is pulled back. Okay, so in this case, I think preoperatively there was about 2 to 3 mm. So this case does not need any the centralization technique. So the centralization, for benefit of the younger audience, the centralization technique is nothing but to reduce the extruded meniscus from this tibial plafond. So what we can do, we can put one anchor here, maybe all suture anchor or a peak anchor here, and then take the bites around this meniscus region through the mid-medial portal. So there will be one portal here at this region where we have to do the mid-medial portal, and then either you can tie him or bury it, or whichever technique you can use it. Actually, Sundarajan sir has published one the root repair with the centralization technique, and it is there in the arthroscopic technique. So it's free, so people can go and look into it, how to do a centralization procedure. So here we can see that it is nicely seating into the bed, and this is our root repair. Okay. Yeah.
So audience, any other questions, or can we?
Any other questions? This root repair is a simple procedure, quick to do surgery, probably just taken about 20 minutes to do this surgery.
But and quite well done. Your emphasis on all avoiding entanglement and everything, it was so nice. So
yeah, thank you very much. So here we have Anita sister, Kamachi sister helping me, and then this is Amrenda, our fellow who's helping us, and Dr. Santosh was anesthetist. It was a good teamwork.
Yeah, thank you. A big round of applause, please, for the wonderful team. Thank you, Ramakant. We'll carry on with the sessions here. Thank you.
Yeah.
So thank you, Ramakant sir. Now we move on to the next session. This is a session on multiligamentous knee injuries. I call upon Dr. Jain will be chairing the session. Dr. Sundarajan sir will start the session by a talk on how to manage acute knee dislocation.
Good afternoon. Many of you might have heard this talk before. If you not, if you heard before, I didn't send many of the slides. So. Continue putting it. Okay. So the acute dislocation of the knee, I think most of us are aware it's a complex problem, and it's like it's not like an ACL. So we know that each injury is different. Like even if if you take a KD3, all the KD3s are not same. So that's why it makes a bit unique and challenge in the treatment, and also needs an arthroscopic expertise and experience. And I would always suggest that if you are a starter, better not to attempt to do a multiligament injuries in your first year, and take your mentor help or your seniors help to do these kind of cases. And we know that what happens when the patient presents with acute dislocation. We should not send for an X-ray, you should not send a CT scan, you should not for MRI scan, because there could be an impending vascular injury. So always you reduce the dislocation, like anything on the shoulder or anything. So the knee is the most important thing, because there is a possibility of a neurovascular injury. So reduce the joint as early as possible, and don't put a plaster like this. You can see this patient was sent with a plaster and sent for an X-ray, which is not required. So you reducing the casualty also. Just sometimes
the gentle traction can get reduced. If it is not possible, then you have to take to the theater and reduce it. Then you can go for X-ray. Then you can go for a MRI scan. And we know that this is very important, that you should rule out the vascular injury, look for the pulses always if you are in a casualty, and look for the extremity color, temperatures, look for always popliteal fossa, turn the patient on the lateral side, look for any expanding hematoma on the popliteal fossa, then you should suspect there could be a vascular injury. Then these patients require an immediate CT or an MRI angio before any MRI scan. And also it is very, very particular, especially when you have a fracture dislocation like this, posteriorly completely dislocated tibia can cause a vascular injury. So this kind of patients, you should identify the vascular injury and need a saphenous graft immediately. We know that early diagnosis can save the limb. Otherwise, if it goes more than 6 hours from the time of injury, and if you miss the vascular injury, the chance of amputation is around 94%. So the algorithm for the management of vascular injuries, I think all of you are aware. Still, this holds good. It was published in 2009, where if the distal pulses are present, if the well perfused, if an ABI index is more than 0.9, still admit the patients, because sometimes initially the pulse can present, sometimes you can have an intimal tear, they can go for a problem. So always observe for at least 24 hours. Don't send the patient back home. Keep the patient for 24 hours to 48 hours. And if it's suspect or if you have doubt, do always some arterial ultrasound or angio. If the distal pulses are asymmetric or the present well perfused limb, then better do an arteriogram. If it is an absent, you don't need to do any CT angio. Directly take to the theater with the plastic surgeons. We have to do the graft. I think all of you are aware of the classifications, but mostly what we are worried about is the KD3 or 4 or 5, which are most challenging cases, because the 1 and 2, I think most of you manage the cases. And another important thing is most of them will be a transient dislocation, so make sure the joint is reduced very well. There are some instances where you can have an asymmetry of the joint space, minor subluxations or avulsion fractures we should observe in the X-ray. Like this case, this is a 46-year-old male patient. You can see that there's a puckering of the skin on the medial aspect, and also you see the joint, the same X-ray which I'm showing here, that is a lateral subluxation. You see the medial joint is open, it's an asymmetry. That means it's a joint has not reduced, it's an irreducible dislocation. So this we have to identify, and you can see there is an MCL invagination. It's not very common, but you can have this kind of cases. You should not miss this problem, because this is one of the rare instances where you may do a early reconstruction and the reduction of that MCL invaginations, so that these patients will joint will get reduced. So this is the acute situations where you can go one go of ACL, PCL, you can remove that MCL from the invaginations, and you can do the all in one go. So the immediate intervention required only in vascular injuries, open dislocations and irreducible dislocations. All other cases can wait for at least 2 to 4 weeks or 3 weeks. Once the knee becomes quiet, get back the movements, then only you can go for a surgery. So once you think that the patient, after seeing the patient after 2 weeks or 3 weeks time, then you can think about stability of the knee joint. So the first week, you need only immobilizer with the rest, allow the knee to quiet, don't move the knee joint. Even it's an avulsion injury, bony fractures, it is not an emergency surgery. So allow the swelling to come down. Then you gently move the knee to get back at least 80 to 90 degrees of movements. Then you go for a reconstructions. And some cases, sometimes in the low velocity injuries, you can see the old patients or even sometimes in young females, they can have a frank dislocations. But still, if you see them, sometimes they come late, or if you immobilize them for 3 weeks time, 4 weeks time, then slowly mobilize the knee, and sometimes they can get a very stable knee, surprisingly. So this kind of patients sometimes can be even treated conservatively. So there are some role for a conservative management in multi-ligament injury. If it is a stable knee after your reassessment, then still you can treat conservatively. Like in older patients, like low energy injuries, if there is no obvious instability after your second or third visit, or middle and old aged patients with arthritis patients, still you can try for a conservative management. But if you found there is instability in younger patients, so you can try to do in a single stage in all the low energy injuries. Like a KD4, like high energy injury, you may need to do a 2-stage procedure. Single stage advantages is the cost. You can do only single rehabilitations that makes the patients to go back to their work quickly. Of course, it needs expertise, because you have a time constraint, because you have to finish it within 1.5 or 2 hours before the tourniquet, and you should have all the armamentarium and set up to do a team. There should be a team to do the multi-ligament injuries. So this is a KD3 injury, 43 years old. Of course, all of the patients, whatever the MRI shows, you don't believe them, because most of the lateral collateral ligament injury will be very, very stable, because if you see that ITB, popliteus, biceps will be intact. You don't need to do the lateral collateral ligament repair because of the MRI shows. So you have to assess the patient both preoperatively and also intraoperatively, make sure that that patient has got a laxity before you do reconstructions. So this is the patients with the KD3 injury. You can see that grade 3 opening. So anything with the grade 3 opening in multi-ligament injury needs more aggressive treatment than the collateral or a single cruciate injuries. Because these patients, we know that we cannot restore the normal knee. So try to be more aggressive in collateral ligament injuries and multi-ligament injuries. And is there any difference between KD3 lateral side and medial side? This is one of our paper which I showed all done in a single stage. There is no difference in the outcomes, where we do the both PCL and ACL at the same stage and address the collaterals at the same time. So when you do the reconstruction, which one is to do first, whether PCL or ACL is one of the other controversial. So I always do the PCLs, always once you do a PCL, most of the time the joint gets reduced, it's very stable after that, then you can go ahead with the ACL or collaterals. But sometimes if you are not expertised and the time is not there, then you can leave the ACL, just do the PCL and collaterals. Sometimes patient may not come back for the ACL at all. So there are some difference of opinion whether to do a PCL first or ACL first, and I'm not going into too much about the literature because it doesn't make huge difference. Because when you do a PCL first, sometimes you can translate the tibia too anteriorly. So you have to be very careful. The same way, if you fix the anterior ACL first, again you can fix it more posteriorly. So what is most important is that this is the picture which is very important. So whatever you do, PCL or ACL, then make sure that this is the reduction of the joint, where you in the lateral side, your notch of lateral femoral condyle should match with the lateral meniscus anterior horn. The medial side, same way, your medial femoral condyle should match with the medial meniscus posterior horn. So this kind of landmarks will help you to know that whether done the properly reduction or not. Let me take 1 minute extra. What about the collateral ligament injuries? Especially in the medial side, most of the femoral injuries can be treated with repair. They give a very excellent results because most of them will be in avulsion. So femoral side is easy to treat. And also tibial side, you can treat it with repair, but they may not suffice most of the time. You may need to do a repair and also better do an augmentation. And also come to the mid substance, always you have to do a reconstruction. Yeah, you can do a repair with the augmentation. So mid substance will not heal. So you have to do a reconstruction at the lateral side and also the medial side. As you see in this case, it's a mid substance tear. It was reconstructed. To conclude, be suspicious about dislocation in all the knees. Whoever receive a casualty in any knee injury, it could be a transient knee dislocation. As already said, that each injury is different. Of course, you should give an importance for the neurovascular examination. Open and irreducible dislocation or an vascular injury is the only time you require an immediate intervention. Otherwise, wait, assess the stability, whether single stage or 2 stage, doesn't matter. And whatever we do, that it should be a certification to the injury and to the patient. Thank you very much.
Thank you, sir. That is a very good overview of knee dislocations and how to manage. We would take any questions from the audience for this talk now.
Any questions? So usually when you do the post-vascular repair, always plastic surgeons wants you to wait for at least 4 weeks to 6 weeks time for the graft to heal well. Then you mobilize the knee. So when you do that, you see out of maybe if you take 10 patients, 8 patients may not get the full movements also, because by the time it will be the KD4 injury or KD3. When you get back, these patients rehab them, when you see them after 3 months, by the time when you go for a ligament reconstruction, it will be at least 3 months time. You should get at least you should get 100 degrees of movements. When you get 100 degrees of movements, most of the time knee will be very stiff. So you may not require to do a reconstruction in some cases. So suppose this patient get a full range of movements after the vascular repair, I think it will be at least 2 to 3 months time. And always I ask plastic surgeons, can we go ahead? They will also assess them. And we do the Doppler. They make sure that everything is good. Then you can go ahead and do the reconstruction. The only challenging is when you do a vascular repair, there will be a posterior adherence of all your soft tissue capsule, and the arteries could be very close to the posterior tibia. So you have to be very careful that you have to carefully separate it. We have done cases, but as I said that you may require it to do 2 cases out of 8, because many of the patients will become very stiff, knee stable, then I leave it them. So anybody who comes for a second stage, with just like a KD4 or a KD5, may not require a second stage cruciates at all. By the time knee is stable and they are all happy. Yes, Sugal. Yeah, standalone synthetic, again it's coming back with some. Yeah, so it's again you cannot use standalone in my opinion. So guys who come with now that all this new ligament, again people are using with like an augmentation. Like if you do a PCL reconstruction, like internal brace, they are using that ligament. Standalone still I don't advise do standalone, because you know that synthetic is known for failures. It goes like a patches. You should not believe anything which is not in biology. We should not blindly follow any company. You wait for at least 5 to 10 years of result, then do it. That is a big take from this maybe this meeting. Don't go for anything. If somebody does first time, don't think that okay I have to do first time and put on wherever social media. That is not a good, because that may fail. So better to go for the biology, multi-ligament injury. If you are we have now a lot of ligaments. Now we have peroneus. Peroneus. So you have a lot of graft options to do with the biology. So I would not suggest for a standalone, but you can augment it. There is no harm in that.
Sir, in combined ACL and PCL injuries, do you always go for a vascular assessment with a CT angio to identify whether the patient had a transient dislocation of the knee, and by the time they reached you, it would have reduced, and the X-rays it will be appearing like a normal knee?
Yes, so if it is on day 1, so usually the pulses are well felt. We observe for 24 hours to 48 hours. If the pulses are well felt, always we send them back. If it's an asymmetry or the not felt, then only we send for a CT angio. And most often when they come back for the second time reconstruction, suppose the patient comes with like if you are doing a cruciates or a collateral, if you are doing a collaterals first, or if it is a very swollen and it requires 2 weeks, 3 weeks mobilization. Second time, when you go for a surgery, the previous day also it's very important to do the Doppler and make sure that everything is okay, because some intimal tear can go for a thrombosis, even slightest insult, because we had a case like that. Previously pulses are very good, and when you did a case, reconstruction, then pulseless. If I did an angio, then it shows the thrombosis. Then you see the previous angio, first time did an angio, that was an intimal tear. So when you do a second time surgery, you are touching the artery. Now, in a way, you are putting all the scoop and pushing. That can give us an insult that goes for a thrombosis also. So that's why we have documentation also very important. Of course, we found out, put a graft, patient was okay. But it's important that before you do the procedure, better do a Doppler or angio again. No harm. No need. Only in a KD4, if you think it's very unstable, we put on external fixator and bring the patient. Otherwise, most of the patients are stable. What usually I do is we put a knee immobilizer. If the knee is stable, leave it for 1 or 2 weeks time. Then if it is a collaterals are unstable, then we started a hinge knee brace with the ROM. So you can with the brace we can start the ROM. Then once you get a 90 degrees, then do surgery. Anyway, these braces are required after the surgery also. So anyway, you are going to put the same first brace for first 3 weeks time. Then when you start moving the knee, again going to put a range of movements brace. So the 2 braces are required always. So I use pre-operatively also. The same braces can be used post-operatively. Yeah, for the first 3 weeks. After that, not required. So.
When you use that PCL support brace, is there a chance of compressing the vascular structure?
So usually because that's what the pressure should be in the calf region, upper tibia, not in the popliteal fossa. So people make mistakes. Sometimes they put a lot of pressure on the popliteus, can cause a lot of pressure issues. If you put on the upper tibia, you are going to just support the tibia. It's not in the popliteal fossa. I don't think it will cause sepal. And we are not going to use any hard thing to support it. What we use is that normal brace with that cushion, and we put an extra pad and put a plaster on that. Still, we don't have a very good braces for that. Thank you very much.
No more questions. We'll go for the next talk. So I would like to invite
Dr. Karthikeyan sir for the PCL basic anatomy and reconstruction techniques.
Good afternoon, everyone. Post lunch session, I would like to make it as short as possible. So I have been asked to talk on posterior cruciate ligament, the anatomy and the surgical reconstruction technique. So PCL is the largest and the strongest intra-articular ligament, around 32 to 38 mm length, and there are two bundles, the large anterolateral and a small posteromedial. Though they are distinct, they are actually inseparable. And the arthroscopic anatomy on the femoral attachment, we see that the femoral attachment is almost double the size of the tibial attachment, and there is 11 mm gap between the centers of the two bundles, and the anterolateral bundle attaches at the roof of the notch. And the landmarks that we can appreciate on the arthroscopy are the trochlear point, the medial arch point, the posterior point, and there is something called as the medial intercondylar ridge. Oh, first linde varliya. Okay, I'll start off again. This is the largest and the strongest ligament of the knee, and the mean length is 32 to 38 millimeter. There are two bundles, the large anterolateral and a small posteromedial bundle, and though they are distinct, they are actually inseparable. And on the femoral side, the attachment is double the size of the tibial attachment, and there is a 11 mm gap between the two bundle centers, and the anterolateral bundle attaches at the roof of the notch. And these are the arthroscopic landmarks. There are 3 points on the cartilage margin, the trochlear point, the medial arch point, and the posterior point. And there is a medial intercondylar ridge, which is the posterior margin of the attachment of the anterolateral and the posteromedial bundles. And this is the tibial sided anatomy, and the tibial attachment is very compact, and there are 3 to 4 landmarks that we need to appreciate, which helps us during reconstruction. There is something called as the bundle ridge, which is between the two bundles, and there is a shiny white fibers of the posterior horn of the medial meniscus which guides us, and there is a lateral cartilage point, which is the cartilage of the lateral tibial condyle, and there is a medial groove. So these are the landmarks that we need to take into consideration during reconstruction, and this is the arthroscopic image. When we look from front, you have the lateral cartilage point here, the fibers of the medial meniscus, and that's the popliteus tendon, and this is the bundle ridge and the champagne glass drop-off line. So radiologically, you see in the anteroposterior view, the tibial attachment is along with the lateral tibial spine, and it is around 1.6 millimeter from the articular joint line. And on the lateral view, the center of the PCL footprint is around 5.5 mm from the champagne glass drop-off line. So, and there are the meniscofemoral ligaments, and their role is in the main aim is not to disturb them if we find them, and their role is still controversial. And during the tibial tunnel femoral tunnel placement, in a single bundle reconstruction, we aim to reconstruct the functionally dominant anterolateral bundle alone, and their attachment is almost at the margins of the articular cartilage of the femoral condyle. Around only 1.5 mm distance is there, so we try to be as distal as possible, as the traction happens when we fix it, tries to pulls it back, and the tunnel direction should always be oblique, so that you avoid osteonecrosis and insufficiency fractures. So this is the patient who was 18-year-old who had a dashboard injury, a high velocity injury, had bilateral knee injuries, and the MRI showed a mid-substance tear of the PCL, and we decided to do a reconstruction for him. So this is looking from the anterolateral portal and probing from the anteromedial portal. We see that there is a complete tear of the posterior cruciate ligament at the mid substance, and we go in and debride the stump of the PCL and then create a passage so that we can go to the posterior aspect of the knee between the PCL and the medial femoral condyle. And once you go inside, and that's the posterior capsule under vision, and this is the area that you need to clear between the medial meniscus and the native PCL footprint, and you always make a posteromedial portal under vision, which helps us to shuttle the scope posteriorly so that it helps us during the tibial tunnel placement. And cannula is always helpful to, during this procedure, and bring in a radiofrequency ablation device and gradually start clearing. And we should be careful about causing an iatrogenic injury to the posterior root of the medial meniscus. And once the soft tissues at the posterior aspect of knee is beginning to get cleared, and there you see the lateral articular cartilage of the lateral condyle, so that is one of the landmarks. And once you clear off, that's the ridge there, and you take a vision of the popliteus muscle also. And now looking from behind, still some more fibers are there. You can use the PCL guide as a rasp to gently rub off the tissues, and a shaver judiciously should be used, and always make it to point towards you as the vessels are just behind. And once you clear off all the remaining debris and the stumps of the PCL, this is how the area looks where you need to place your tibial tunnel. So we have already taken a semity and a gracilis graft. Around 9 mm was the diameter. So I like to place my tunnel around 15 millimeter from the cartilage margin. And once you get in the beath pin there, always be gentle so that the vessels are behind, and the first reamer comes in, and followed by that you can start serially reaming it, and use this PCL protector guide so that the pin doesn't go beyond the margin of the beath pin, and pass the shuttles sutures after that, and the sutures are placed in the posteromedial portal. And then now come back to the front and start preparing for the femoral tunnel. And here I am drilling, visualizing from the anteromedial portal and passing the guide wire from the anteromedial portal. I think I might be wrong, the other way around. So once you pass the pin, you'd like this is the reamer for the endo button, and as told earlier, you like to be as close to the cartilage as possible, and then the depth gauge measures the depth, and you want to be having around 20 to 25 millimeter of graft inside the tunnel, and the final reaming is done up to 25. And once the sutures are shuttled, and the next step that you would like to do is pass the I am using an adjustable loop button here, and to negotiate the killer turn, it's always helpful if we are bringing in an instrument through the posteromedial portal and gradually deliver the graft outside, so that it helps to wind around the killer turn smoothly. It can be a bit of a task, but then it can be accomplished, and that's the graft finally after it's been passed into the femoral tunnel, and this is the final picture after the fixation. So, and always supplement it with a suture disc on the tibia. Yeah, thank you.
Any other questions?
So that was a wonderful talk by Karthikeyan sir. We would like to take any questions now.
No questions means about the meniscofemoral ligament and the PCL. So sometimes people get confused with the PCL fibers and the meniscofibular ligament. Both look same almost like, but it is not there for all the cases. Around 60 to 70%, whether in the Wisberg or sometimes in the anterior ligament, but they have attachment to the lateral meniscus. So that's why you should not disrupt the lateral meniscofemoral ligament. Always try to protect it, even when you do a meniscus reconstruction. So always meniscus, we try to preserve the fibers to create the more remnants of the PCL to incorporate with our PCL graft. The meniscofemoral ligament is so important that better to not to disturb that, because we know that it's important stabilizer of posterior horn of the lateral meniscus. The meniscofemoral, from the medial femoral condyle, it goes down and goes posteriorly and attaches to the lateral meniscus. So sometimes if you see, the lateral meniscus also will be hanging with that. So always better to stabilize the PCL, don't without disturb the meniscofemoral ligament, that indirectly stabilizes the lateral meniscus also.
All right. Karthikeyan sir, I have a question for you. Do you do any double bundle PCL reconstructions for isolated PCLs?
I personally don't do, but as far as the literature goes, we know that the attachment of the PCL on the femoral side is large. So there are two schools of thought. There are also literature supporting two tunnels for the femoral side, and for the tibia it's always a single tunnel. But the literature both supporting both a single bundle reconstruction and double bundle is there. Biomechanically the double bundle is more stable, but the functional outcomes there's not much of a difference. And I think Sundar sir can tell about.
As I said, biomechanically is more strong, like any double bundle, like a shoulder when you do a single row, double row. Definitely biomechanically is better, but doesn't make any difference in the functional outcome. Especially when you do multi-ligament injuries, doing double bundle is a big task because you need more graft. And also when you do a double bundle reconstruction, one is where you use two tunnels in the femur and one tunnel in the tibia. Or some people doesn't agree with that, because if you do a tibial side only once, it is not a double bundle at all. So people want to do, they do a differential, they keep two grafts, tibial side, but fix it in the two different angles. So that they say that it can work as a double bundle. So, but as you said that, when you do a multi-ligament injuries, it's a time taken. For a double bundle is more, and biomechanically, functionally, this outcome is not a big difference. So I also do mostly single bundle reconstructions. When I have an isolated PCL, I do double bundle.
Thank you, sir. And especially it will be a problem when it is a PCL with MCL, where we need 3 tunnels on the medial femoral condyle. So, no more questions. We'll go to the next talk. I would like to invite Dr. Sivakumar Mani for the talk on MCL management guidelines.
It's not working. Go to the next talk.
So, the next talk is by Dr. Leo Bernard, sir, PLC injury management.
Until the slide loads, for the people who are there, one interesting comment was, I got an opportunity to meet the guy who devised the PCL, double bundle PCL. So actually, his concept also was the same, that as Sundar sir said, that after you tie the anterolateral bundle at 90-degree flexion, you put a screw, and then you take the posterolateral bundle down, and then you put a stable and fix it. So technically, the screw is already fixed both the bundles at 90-degree flexion. So technically, it acts as a single bundle, though you're doing double bundle at the femur. So we don't know whether it really works or not. Yes, sir. Please, let's continue.
Good afternoon, everyone. Thank you for the opportunity. Today we'll go about the PCL injury and the management. Why is PLC important? Because usually PLC is a combined injury along with the ACL and PCL, and failure to repair or reconstruct the lateral compartment of the knee can lead to subsequent failure of the reconstructed ACL and PCL. The posterolateral corner was considered to be the dark side of the knee because of the multiple structures that are there. But with advanced studies, it's no longer the dark side. It is as fresh as Angelina Jolie's legs. And the dark side has multiple ligaments in the cross section. And the anatomy, we have the lateral collateral ligament, the popliteus, the popliteofibular ligament, the fibula-fibular ligament, arcuate ligament, the IT band, and the biceps. So there are two stabilizers, the static and the dynamic stabilizers of the knee. The LCL, the popliteus tendon, the popliteofemoral ligament, fibular ligament, the meniscofemoral, meniscotibial, arcuate, and the fibula-fibular ligament, all the static stabilizers. Whereas the biceps femoris, popliteus muscle, IT band, and the lateral head of the gastrocnemius act as the dynamic stabilizers of the lateral compartment, out of which the fibula collateral ligament is the prime stabilizer in extension, getting attached from the femoral epicondyle to the head of the fibula. And the popliteus has a Y-shaped origin from the femoral epicondyle, the posterior horn of the lateral meniscus, and the fibular head. The popliteofibular ligament is the arm of the fibular origin of the popliteus, and the arcuate ligament is again a condensation of the fibers of the origin of the popliteus. And the fibula-fibular ligament is a structure that is present in approximately 30% of the persons. It's an sesamoid bone in the lateral gastrocnemius. The IT band that gets attached in the Gerdy's tubercle, and the biceps femoris tendon getting attached to the fibular head. These are all the stabilizers. And in biomechanical tests, have proved that the order of failure is the first the lateral collateral ligament, then the popliteofibular complex, and the popliteus. So why is the posterolateral instability important? As I told already, it can combine with the ACL and PCL injuries, and failure to reconstruct it can lead to failure of the graft. And there are multiple tests, the dial test, the reverse pivot shift test, and the recurvatum hyperextension test. It can be diagnosed with the MRI, which shows it can be an avulsion fracture of the LCL or mid-substance tears. This is a CT showing the Sigon's fragment. So there are multiple papers which compare the repair versus reconstruction. In acute cases, mostly when it's amenable to repair, less than 3 weeks, it can be repaired. Whereas when it's more chronic and more than 3 weeks, we can go for a reconstruction. Sometimes a repair can be augmented with a reconstruction technique also. And there are papers which suggest repairs alone have a failure rate of 30%. So when they are combined with PCL injuries, with the PLC, if it's a mid-substance, we can go for a delayed reconstruction of both the PCL and the PLC. If it's a sleeve avulsion or a bony avulsion, early repair can be done. When it's combined with the ACL and PLC injuries, the Larson's technique, modified Larson's technique, Lapred, Banchas, Muller's, there are multiple techniques. In case of acute injuries, there are 3 categories. One is the femoral avulsion, the mid-substance tear, and the distal avulsion. So it can be from the femoral attachment, the mid-substance, or the distal avulsion. A popliteus, when there is a femoral avulsion from the epicondyle, we can go for a suture anchor repair. And the mid-substance tear, a Bunnell type of repair can be done. And the third, from the tibial attachment, tenodesis can be done. When there is a mid-substance laxity with intact proximal and distal attachments, we can go from a femoral advancement of the attachment of the popliteus tendon in the femoral condyle, epicondyle. mid-substance laxity, it can be augmented with a popliteal bypass using the IT band and the biceps. So in this, we take a strip of the IT band and tunnel it through the tibia and then again into the original attachment of the popliteus. The same can be done with the biceps, a strip of biceps, and then it is passed into the tibial tunnels. And LCL injuries, if it's a fibular avulsion, always best to repair it back to the fibular head. A mid-substance tear can be sutured. When it comes to reconstructive surgeries, for the posterolateral corner, ACL and PCL are just like Tom and Jerry. It's very easy. Whereas PLC, it's like watching Pidamahan, because we have to understand the anatomy, then only we can understand what the director is trying to tell. So the PLC reconstruction, there are multiple techniques. The Larson's technique, simplest one, 2 tunnels, one in the femoral condyle and the second in the fibula, and a single graft being passed in this triangular fashion. It can be a percutaneous one. Here I've done an open technique where the dissection is starting from the Gerdy's tubercle up to the proximal femoral condyle. We see the bands, the iliotibial bands. First thing is dissection of the common peroneal nerve and the tunnel in the fibular head from the anterior to the posterior, and then sutures are passed into the fibular head. Isolation of the peroneal nerve through a tube, and then creation of the tibial tunnel, the femoral tunnels, and then the graft has to be passed beneath the fibers of the iliotibial band. So this is for the looping of the graft, and this is a final fixation by means of bioscrews in the femoral tunnel, and through the fibular tunnel the graft is looped. So this is the picture, and this is a 18 months follow-up after this patient had a combined ACL and a PLC, and able to see the patient had come last week. Good lateral stability is there after ACL and PLC. Apert, he designed the anatomical reconstruction of the LCL, popliteus, and the popliteofemoral ligament. In this, there is an additional tibial tunnel, the same thing, the isolation, the fibular tunnel, and then we go for an additional tibial tunnel from the Gerdy's to the anterior part of the tibia, and then the femoral tunnels. There are 2 tunnels in the femur, one for the LCL attachment and one for the popliteus attachment, and they are at a distance of 1.8 centimeters to restore the anatomy. And this is the technique in which the graft is passed from the, and both the grafts are passed from the tibia up to the posterior aspect of the tibia, then through the fibular head, and then beneath the IT band and into the LCL insertion to the femoral condyle. The second is the reconstructing the popliteus that comes from the tibia back to the posterior aspect of tibia and then into the femoral condyle, just anterior to the LCL attachment. So this is the Lapierre technique. There are other methods. Now is suggested the allograft plication, like in West on Pant, Banchas. There are multiple techniques. All of them, the rehabilitation is very important. Immobilize for 3 weeks in a week, non-weight bearing, and then start knee bending exercises to get a good range of movement. So the take-home message is all PCL injuries need a good clinical examination so that we don't miss it in the initial phases. We have to have a good knowledge of the anatomy of the posterolateral complex. And when we are doing a combined reconstruction, keeping the tunnels away so that they don't impinge, and a good rehab is essential. Thank you.
Excellent talk, sir. So as sir showed the Pidamagan image, it's a complex anatomy. Knowing the anatomy and it's a more technically demanding procedure. So any other questions?
stress views. Yes. Before reconstruction, the valgus stress view shows a definitive opening in the lateral complex. Clinical examination, actually we had images of the clinical examination in-drop and before surgery, but I don't have it now. But the post-op reconstruction shows that after 18 months also it's good, stable, full range of movement is there.
Thank you, sir.
Thank you.
Now we call upon Dr. Shivkumar Mani for his talk on MCL management guidelines.
Pardon for the delay. So I thank the organizing committee for this wonderful opportunity. I'm Dr. Shivkumar Mani from Arvind Hospital, Namakkal. So today my topic is on MCL management guidelines. So MCL injuries you often see in all the MRI reports. Approximately 40% of all knee injuries involve MCL. In grade 3 MCLs, the risk of other associated ligaments is 78%. In that, 95% is always often ACL. So this is the 3 layers of MCL. And a special mention about the posterior oblique ligament. Like sir spoke before, the PLC, the POL is the important structure of the posteromedial complex. So MCL tears are in the femoral site, which is the most common. They are also in mid-substance and on the tibial site, where they have a good healing factors, but in case of Steiner lesions, it has to be fixed. So in grades, there are 3 grades, which is based on the lateral translation or opening of the joint. So grade 1, the opening is up to 5 millimeter. Grade 2, there is a valgus loading opening, which opens the valgus, but has an end point. The opening is from 6 to 10 millimeter. And in grade 3, there is a valgus opening, but there is no fixed end point. And the opening is in excess of 10 millimeter. Always make sure to do the tests in complete extension and in 30 degrees of flexion to test the POL and the MCL. So where do you conserve or repair when you have that doubt in an acute setting? This is what to be followed. In a combined injury with the ACL MCL, you can go for a conservative MCL, then go for a delayed ACL. Or you can go for an early ACL reconstruction and go for a conservative MCL, which most often is the case. Or in case of multi-ligament or even after an ACL reconstruction, there is a grade 3 opening on extension, you go for MCL repair. And in isolated injuries, grade 1 and 2 conserve. Grade 3, see in the OR, if there is a normal valgus, then go for conservative. If there is severe valgus or Steiner lesions or multi-ligaments, you can go for an acute repair. So most surgeons prefer the non-operative treatment because of this good self-healing ability, especially when combined with an ACL. So after a ACLR, mostly a grade 2 middle MCL opening becomes a grade 1, so that can be managed conservatively. Even after a post-ACLR, if there is a grade 3 opening on full extension and 30 degree flexion, take a call on repair or reconstruction based on the patient's needs and what do you see there. So case 1, there is a 39 years old male, 1 week old injury, ACL and MCL, grade 3. This is the MRI. So even after ACLR, completing ACLR, there was grade 3 opening. So I went for a femoral side open MCL repair with a anchor. So this is at the end finishing of ACLR and MCL suturing with suture anchor. Just like to show a video of the start to the end. So this is the hematoma you get in an acute situation. So you always test for the ACLR under examination under anesthesia before you put the scope in. So there is an anterior draw is positive and the MCL grade 3 opening first tested on complete extension and in also flexion, 20 to 30 degree flexion. Then the pivot shift, so it's also positive. Sorry for the lagged video. So this is after ACLR. The anterior trois is negative. So always do this examination before you go into the extra-articular procedures. Now still after ACLR fixation, the joint is opening on 0 and 30 degrees of flexion. So then I decided to go for an open acute MCL repair with a suture anchor. So sometimes the MCL avulsion or tear, it's easier to identify as soon as they open there, it's there. So this is at the end, again test for MCL opening, and it's not opening. So the final picture. So this is during suture removal, I try to achieve up to 90-degree range of motion, then start partial weight bearing. So the clinical test at 3 weeks. So always do examination before you promote your rehab from non-weight bearing to partial weight bearing. So that is very important. So coming to another case, similar 1 week old injury, but this patient was bulky. Again do the test under anesthesia, the anterior trois and the grade 3 opening. So again in this I went for a ACL repair. After that it was opening, but it was a huge tear from mid substance to femoral side. So I decided to extend with the graft harvest site, and this was the repair completion. Again check with the test at the end. So there is no opening. So when do you plan for reconstruction? In my experience, the reconstruction numbers are very less, because as I said, MCL has a good self-healing ability, and in any acute scenarios where you need to do repair, heals very well with the repair. So reconstruction, there are anatomical and non-anatomical types. So whichever suits you best, you can do. There is a Laprade technique and Kim's technique, but what I follow is the weave technique. So it's basically with an open stripper, you take the semitendinous, harvest it, then reroute it through the superficial MCL on the tibial side, and then bring it to the femoral side just below the medial epicondyle. You fix it with a screw, and then reroute it back to the tibia 1 centimeter distal and posterior, and you fix for the POL. So this is a similar case where this is an isolated MCL injury. It's a 3-month-old injury, but the patient still had a grade 3 opening. So I went with an open reconstruction, sorry. So with an open stripper, you harvest the semi-T, then you fix it on the femoral side with a screw, then reroute it back to the tibial side, and I am placing an anchor like 1 centimeter just below the joint line and posterior for the POL. And important note here is you fix the femoral side in flexion and the POL in extension. So that's an important point. So I placed a shoulder anchor there, shoulder knot. So this is in the weave technique what you do, and the remaining graft I just 7 centimeter distal to the joint line, I just rerouted it to the lateral side and tied it up just for extra precautionary procedure. So again examination under anesthesia, and anti-drois was negative, but the collateral openings, the valgus opening was there. Again it was a 3-month setting, so this is at the end. So this is what you aim to achieve. So this is the final picture. This is for the MCL, and this is for the POL. This is where I redirected it. It's not so necessary, but the remaining graft was there. So my rehab is 0 to 3 weeks hinge knee brace, non-weight bearing, and gradual range of motion to be achieved up to 90 degree. After that, you take a clinical examination test, then you unlock the knee brace and allow partial to full weight bearing gradually and increase the range of motion. So this was the recent paper by the Ganga team where approximately 30 patients each, they have done MCL repair, isolated suture tape bracing and no repair for these patients, and have achieved a similar outcome in all these patients. So based on the patient's requirements or budget, you can actually go for all these three. So my take home message is grade 1 and 2, you protect and conserve. Grade 3, you conserve or operate. You take a call depending on the previous said things. And less than 3 weeks is an ideal for an acute repair. Always examine after an ACL reconstruction. Don't neglect it. Thank you.
Thank you. It was a wonderful talk. So any questions?
Shivakumar sir. Just wanted to ask you, because which the femoral sided tear or an tibial sided tear, it's we usually put suture anchors and we repair and we get good outcomes.
Yes.
We also follow that if you're in an acute condition, we have an ACL and an MCL. We also don't treat MCL conservatively now.
Okay.
Despite the trial, still a little bit biased for repair. So we do a repair. But with the internal brace, though on a statistical level we didn't have any problems, but we had in the 30 patients, around 3 patients had gone to stiffness. And patients who are, after the trial also, we had a lot of issues with stiffness with internal bracing.
Okay.
So internal bracing is something that we don't do. And we used to do internal bracing mainly for mid-substance tests after the trial. So that was out.
Like an augmentation? Like just internal bracing?
Just internal bracing.
Okay.
Just brace it so that the mid-substance heals. But now the biggest problem comes is when you have a mid-substance MCL.
Yeah.
And if you have already used your hamstrings for ACL, then you're stuck with what to do for MCL because you're not happy with doing the MCL repair. So what we do now is we see if you're very clearly your MRI shows if it's a femoral sided tear or a tibial sided tear, we go ahead, we take the hamstrings. But if it's a doubtful mid-substance tear, then what we do is we take peroneus for ACL and we keep SEMITI for the MCL. And even we like to do the view technique. It is a very nice technique, and you can keep the distal end intact. Proximally, you reroute. If you want to do the PO, you do it. Otherwise, you can stop it at the superficial MCL level. And maybe you can add an extra anchor there at the distal tibia for doing that. So I think mid-substance is the challenge, but if you get femoral and tibial sided, I think it should be straightforward.
And in all my years I've experienced, that's the only MCL reconstruction I've done. So I didn't want to take any chance, so I opened. So when you get experience, actually you can do it like femoral side incision, tibial side incision, just reroute it. You don't have to open that much. I just wanted to be sure. So with the experience, you can minimize the incision.
Right. Yeah. Santosh sir? Acute ACL tear and MCL grade 3 injuries, what is your take? Would you repair MCL when you're doing an ACL reconstruction?
Yeah, depends on the grade of the tear. If it's
grade 3.
Grade 3, and if there is a Steiner's lesion distally or if there is any bony avulsion, it is a clear-cut indication to repair a tear. If it's grade 3 and when the opening is really gross, it is not springy, no remaining fibers which is seen across, you try to put some sutures. But if it's a mid-substance, you cannot really take bites and repair them. If you're going in acutely within, suppose 5 to 7 days, you cannot take many bites. But if it's the ends, if it's the femoral side or tibial side, it's possible to take sutures, put in an anchor and repair them. And if there are multiple levels of tears, if it is mid-substance, proximal, at least take some, if in the MRI, if it is just there, it's going to heal, you can leave it. But it's far away or folded up, then at least try to get those sutures close to the bone as possible by a few sutures and anchors. Mid-substance you might not be able to repair, then you might need to augment it by whichever technique you are familiar with. So augmentation is to keep the knee stable during the range so that you can start doing range early. So that's the main purpose of augmentation, so that there is no stiffness when you do range. If you're unable to achieve that, do not mobilize, keep it immobile so it will heal. Grade 3 most of the time heal well, but it depends on when you start mobilizing, when you start loading. So if you're not able to achieve good approximation, keep them non-weight bearing, do not mobilize them. They will get stiff, but ultimately you will be able to achieve good range after some time. Stability and extension is the key. Stability and flexion usually settles down in about 3 months if you're not able to.
Okay.
If you augment, will you open it and augment or mini open?
So if you're repairing, we have to open it and repair the. If you're not planning to repair anything, mini open is enough.
Mid substance stairs.
Mid substance stairs, if you're going in acute.
Try repairing it?
No. Mid substance you can hardly take bites in those tissues
So
acutely.
sometimes in mid substance stairs also, the deep MCL will be always torn. When you open it up, the meniscus will be seen outside. So is it better to open it up and repair the deep MCL and then augment it, or just
deep MCL also, it's going to be in place, right? In the MRI, it will give us an idea. If it's in place, it is going to, you're going to keep it there.
2 cases and the middle meniscus was totally seen outside.
Seen outside.
Yeah.
So MRI will give us an idea. Yes. MRI images are coronal cuts. If your fibers are there, you'll just leave it. If the fibers are splayed open, then you need to get them back in place so that when you leave it, it has to heal onto the anatomical position.
Do mid-substance tests and arthroscopic view from seeing the middle meniscus, do they show like some hematoma on that side?
No, that sometimes it's seen, sometimes it's not seen. When deep MCL is gone, it is seen. Arthroscopically, other thing which you can do is when you do a valgus stress, you can see whether it's a suprameniscal opening or inframeniscal opening when you do a valgus stress. If it's a suprameniscal opening, it's obviously the femoral side is torn, so you give attention to the femoral side. If it's infra, you give attention to it. If both means then it's everywhere. That will give us an idea what to do.
But if it's mid-substance, I think if we are sure, it's better to go minimally invasive.
Another thing is when you have an ACL with MCL, when you're going in acutely, there will be fluid leak outside. So always make a medial, the graft incision. So when the hamstring harvest site incision, and try to open up the sartorius fascia. So whatever fluid is seeping out will flow out, doesn't go into the posterior compartment. So your chances of compartment syndrome will be less. So when you're going in acutely for an ACL with MCL, be careful about compartment syndrome. And while draping the patient, you wrap the ankles up till the calf, where you tightly wrap the calf muscle with clean film or something which you saw in the live surgeries, so that in case it is up to the mid calf at least, so that in case the fluid seeps to the posterior compartment, it seeps only till here. So when you release the tight compression at the end of the surgery, the tight compartment distributes out, so the pressure is not too high. So those 2 points are very important when you're dealing with acute ACL with MCL.
Sandhu sir, if you have the same scenario, ACL tear with an MCL femoral sided avulsion soft tissue, not bony avulsion, would you go ahead, put an anchor and repair it? Grade 3?
Again, if it's moved away in the MRI, yeah, probably put it. But if it's there, just there, they do heal well. And again, demands of the patient. If it's a high demand, we are worried that he wants to get back early, better to put an anchor and get it back so that we are sure that it heals. Because the patients which I've left conservative, they kept opening inflection for 3 to 6 months. But eventually they do heal. But sometimes it takes 6 months where I ask them to avoid climbing stairs and sitting in the floor and squat. But we can't do that for a high demand patient. So probably for a high demand patient, be a little more aggressive.
Okay.
Even if after ACL reconstruction, the instability is not that much.
So I used to leave it, but they say it's a pre-ACL reconstruction decision. So usually after you do the ACL, opening will reduce. But literature clearly says don't assess by that. Assess what is there before you do the ACL.
Thank you, sir. Thank you. Thank you, speakers. The next talk is by Dr. Ajay Gautam. He's a young, dashing arthroscopic surgeon of Coimbatore. So he'll be talking about managing instability following fractures around the knee.
So we've come down to the last talk of the day. I'm Dr. Ajay Gautam from Gautam Hospital. First of all, I would like to thank Indian Arthroscopic Society, Sundar sir, and the organizing members for having me here. So I'm going to talk about knee instability following fractures around the knee joint. So before we go into the topic, the term knee injury is very broad. It might range from minor contusions to minor effusions to major ligamentous disruptions to gross fractures. So knee ligament injury are associated with 5 to 55% of femur and tibia fractures. And in such situations, the focus is mainly on the fracture management, but it is not the only predictor of clinical outcome. So the initial diagnosis in such situations is quite challenging because of the associated pain and deformity, and neglected knee injuries can lead to instability, persistent pain, and post-traumatic arthritis. So there is adequate evidence in literature regarding the incidence of knee ligament injuries following fractures around the knee joint, but less is talked about their primary management. There are a handful of journals explaining the incidence of knee ligament injuries following intra-articular fractures like proximal tibia and distal femur fractures, and some of them compare both distal femur and proximal tibia fractures. But the problem with the available literature is that there is wide variation in the incidence reported. For example, Thurig et al. Reported 93% ligamentous injury following fractures around the knee joint, and Guler et al. Reported only 16.6% ligamentous injury around the knee joint. So this inconsistency in literature is mainly due to various reasons. First one being the difference in the population included in different studies. For example, in our study, the mean age was around 34, and in Gardner et al. Study, the mean age was around 52. The second being the methodology. Some have included only shaft fractures and the other have included intra-articular fractures. Third being the method of detection of the instability. So it could be some have used clinical examination for identification of the instability, some have used MRI for the identification, and some have identified arthroscopically. The problem with the clinical examination is quite difficult, and in open injuries and other such situations, the problem with the MRI is that it is not always possible in several cases, and sometimes there might be an overemphasis of ligamentous injury. So we published this journal 2 months back in the Indian Journal of Orthopedics, and all these cases were done when I was in Preeti Hospital. So a total of 595 femur and tibia fractures were included in this study, and we finally included 92 cases. So we showed 15.46% of incidence of ligamentous instability, which are clinically significant. And 19.6% of these cases had MLKI. So almost like 90% of the cases which presented to us were following a road traffic accident, that is high velocity injury. And we identified around 80% of the cases acutely, because most of them who present with the MLKI along with the fracture have at least one bony avulsion around the knee joint. The most commonest fracture was the tibia fracture, 56 cases, out of which 46 had proximal tibia fractures, and Schatzker type 2 was the commonest in the proximal tibia fractures. So we had the highest incidence of PCL injury following fractures around the knee joint, and this may be attributed to the dashboard pattern of the injury following road traffic accident. And with respect to MLKI, we had 3 cases of injury to all 4 ligaments, and all of them were associated with a floating knee injury. So with our paper, an ideal case for a single stage or a primary intervention for knee ligament injury associated with a fracture would be those associated with a shaft fracture, or those intra-articular fractures who have a unicondylar or fractures, or a rim avulsion fractures, or other subtle fractures. But the most important point is there should be minimal soft tissue damage around the knee joint to do an arthroscopy in the first place. So this case was a 30-year-old male who had a simple Schatzker type 2 fracture, which was undisplaced. Definitely you can do a scopy, and scopy showed shattered ACL, so he's planned for a second stage ACL reconstruction. The medial side was okay, and another important point is you can directly visualize the fracture line through the arthroscopy, and which will aid in direct reduction. You can also see the lateral meniscus had a longitudinal tear, which was addressed arthroscopically in the same sitting. Another case, a very subtle fracture in the X-ray, and CT showed an anteromedial fracture, rim fracture. Arthroscopically, the ACL and the other ligaments were okay, meniscus were okay. The fracture was reduced with the arthroscopic assistance with the T-plate. So we also published this journal in JAJS, primary arthroscopic bicruciate repair following multiligamentous knee injury following long bone fractures. First case was a femur fracture who had an LCL avulsion, and it is good to take an MRI if you suspect any knee ligament avulsion fractures preoperatively. So he had a Sherman's type 5 ACL avulsion and femoral serrate PCL avulsion. So femur nailing was done, and 3 days post the initial procedure, we went on with an ACL and PCL repair and an open LCL repair. Another case, a tibia fracture, who had a displaced PCL avulsion fracture. So after fixation, we found there was gross anterior and posterior instability. So we went in, fixed the PCL and also fixed the ACL with arthroscopically. So when to repair is another question. Not all ligaments are amenable to repair. So this paper by Hirschman et al. Clearly says that an ACL with an intact synovial membrane is ideal for repair, in contrast to two-part ruptures or multilacerated ruptures. So moving on to completely articular fractures, there is no role for arthroscopy, and primary anatomical fracture reduction is in the first stage is mandatory. And later on, these patients usually present with instability after 1 year or so, where we can plan a staged implant exit and an open or an arthroscopic reconstruction can be done. So this case, a comminuted distal femur fracture where a lateral plating was done initially, and later on we went in after 3 months for a medial plating and bone grafting. So after 1 year, he presented with instability, and the medial plate was removed, and the condylar screws from the lateral plate was also removed. And after removal of the plate, 2 months post removal of the plate, we went in for ACL, PCL, and PLC reconstruction, and the patient is doing good. So the causes of delayed diagnosis of knee instability following fractures around the knee joint is the complexity of the fracture per se. The next one being conditions requiring external fixators such as open injuries, neurovascular or other injuries, and compartment syndromes which require fasciotomies, and other soft tissue procedures. So these fracture situations that are quite challenging to do a scopy. For example, in acute situations, there is always a chance of compartment syndrome if you do it in a single procedure, and there is always a high chance of arthrofibrosis. In chronic situations, there is a possibility of tunnel position due to the presence of metalwork. There is bone stock is always an issue, and the seating of the button over an irregular surface might be difficult following a fracture scenario. And there is always the chance of multiple procedures. So any procedure is not without complications. So we had 3 delayed units, 8 stiff knees, and 2 common middle nerve injuries and 2 vascular injuries which required tendon transfers and vascular repair. So in summary, knee instability following fractures around the knee joint is not uncommon. So the key is in identifying the telltale signs like abrasions, ecchymosis, effusions, or avulsion fractures, which are present in almost 70% of the cases. So always get a preoperative MRI is very best when you have any avulsion fractures, and a CT scan will be helpful. The most important point is the clinical examination under anesthesia after fixation of the fracture. So even if you don't do primary scopy in the same sitting, you'll have a rough idea of what instability the patient has, and you can plan for a second stage reconstruction easily. So for beginners, always don't try to do a scopy. Always you can go in for the primary repair also, you can go in after 3 to 4 days. The repair is only for selected cases. So nowadays, most of the PCL cases also, reconstruction gives more rigid construct than repair. So PCL you can repair only if you have bony avulsion. For soft tissue avulsion, it is better to go for a reconstruction with respect to PCL. Thank you.
Thank you, Dr. Ajay Gautam. It was really a nice talk and on a very complex topic. This talk is open for discussion. Any questions from the audience? So, a question from me, Dr. Ajay.
Yeah.
You said it's very, even we face this problem because of polytrauma in our hospital. The question is to put guidelines on which patient requires a MRI pre-op when you have a fracture kind of a scenario, because everybody, we all as trauma surgeons, we will think about the fracture first, right? And it's at that time when the patient is so very painful with the fractures near the joint or maybe away from the joint, somehow the attention gets diverted. So those we see, we try to get, but most of the times it's missed. and patient comes back only at 6 weeks, 8 weeks with this kind of problem. So it's so what do you suggest?
So according to a paper, if there is any along with the shaft fracture or along with so the problem comes in an intra-articular fracture. So shaft fracture along with any bony avulsion injury, suppose an LCL or a bony avulsion is there, we advise directly go for a preoperative MRI. Suppose if the condition of the patient is bad, or we are not able to shift for MRI, well and good, we can go in for a fixation. But after fixation, the role of MRI is not that good. So there comes stress X-rays, and we stress about the one important point is the clinical examination after fixation under anesthesia. Because if the two intervals of detecting instability is one, immediately post-operatively under anesthesia, and two, when the patient, because most of the patient go in for a stiffness of the knee, even if it is a single ligament or 2 or 3 ligaments, they go in for a stiffness, and most of the cases which we did chronically, they presented with the instability around after 1 year. So the two intervals are one immediate post-operatively, and the next at follow-up after 1 year, where we are able to find out the knee instability. So any bony avulsion fracture you see around the knee joint, whether you see other things is that swelling, effusion, or you clinically find there is definitely, you know that there is something inside. Preoperative MRI is very helpful. If you're not able to do it, no problem. The clinical exam, stress X-rays is very helpful.
Right. That's a very important message for all the young guys who are seeing trauma and also interested in doing scopy, because pre-op counseling, and that plays a very vital role. Any other questions, Santosh sir?
So question to both Terence and Ajay, both have been in a polytrauma setup. So when there is a proximal tibia fractures, when there is associated avulsions along with the type 4 or type 5 Schatzker, so you're not going to fix the avulsions obviously. So how frequently in such situations after the fracture heals, you are in need to do reconstructions or avulsions? Do they become unstable is my question, or do the ligaments heal?
I wanted to ask this question to you actually, because I was thinking you would get a lot from outside, but from my experience it's very, very less, because they will become stiff. But I think with PCL avulsions the story is different, because with the proximal tibia fractures also, if you have a displaced PCL avulsion, eventually at 6 weeks to 2 months, 3 months, they will have a sag. It may not be unstable, but there will be a sag, like it will go into almost like a fixed sag kind of a scenario. That is very difficult to address. But otherwise, patients coming with instability following fracture fixations, periarticular fracture fixation, very, very rare.
So in our series, out of the 92 cases, 76 were acute. So identified in the initial stages, and the rest of it were chronic cases. We had out of the 18 MLKI, only out of 595 totally, only 8 cases had MLKI, which presented with instability, and all of them presented after 1 year. So out of total 595, 8 cases presented with knee instability, and although it is not much, we have to have a look for it post fixation, whether it is Schatzker type 5 or type 6. It's better to have a look for it post operatively.
How long? After a year?
That's yes sir. That's what. If the patient is asymptomatic, we leave it off. So there are cases where the patient is asymptomatic, but out of 595, 8 cases were symptomatic. So then we plan for same sitting implant exit and fixation, or we can do a 2-stage plate exit and then reconstruction, sir.
So very good point here. What Terence told was PCL avulsions are to be taken care of, because ACL avulsions, if you get the knee into extension, that fragment is going to sit there. So if you let it stay there, it's going to heal. So young surgeons not to think too much of this ACL avulsions, give more concentration to fix the tibial plateau properly, get the alignment right. This ACL avulsion will sit back. We are trying to do a suture bridge along with the plate fixation might be a overkill. But try to fix the PCL fragment, try to get the screw through the PCL fragment if possible. If not, you need to give attention to keep the knee in a sag corrected position when you're immobile. Do not mobilize the patient early in those situations. And as my experience also same, we hardly come across these proximal tibias when we fix and after rehab, they have some stiffness, or very rarely they come with ligament instabilities. But keep looking for them at a later date, but there is not much need to overzealous avulsion fixation when there is a comminuted proximal tibia. Probably that should be the message.
One more point to add on this. Sometimes when you have a proximal weight-bearing medial condyle fractures, patients come with like valgus laxity. It's depressed fracture. Patients come with this, and a lot of trauma surgeons diagnose it as MCL laxity. And a lot of them keep referring patients to you saying that MCL is lax, do something with the MCL. So either that, or recently we saw a few patients with tibial slope reversed, with patient going to recurvatum, trauma surgeons suggesting PCL reconstructions for that patient. So complex scenario, but as he said, we have to keep a watch, I think, because some of the other patient is going to come back with this kind of a scenario.
That definitely, so that's what we are stressing. So first point in Schatzker type 5 and 6 is anatomical reduction. We should not leave back any, like as you said, like medial depression or PCL, because when we were there, we had 2 cases of like posterior slope, as you said, and medial correction. Even a simple osteotomy will correct the instability. Because the problem is mainly in the bone and it is not in the ligaments per se.
Correct. So I think we'll wind up with this session.
One question for
yeah.
Karthik.
Please.
How long do you wait for a PCL avulsion fracture to fix it? The maximum time you think you can wait?
In an acute scenario, once, why do you think we need to wait, sir? Delayed presentation. Okay. I think the answer holds good for the ACL also. Dr. Daniel had said, I think DVR sir said even 1 year later also he had gone on and fixed the ACL. Only problem was if the bed was covered, you need to, freshen it up and fix. I think the same holds good. Unless it's too much displaced where you might feel that the PCL has contracted, you may not bring it back, but I think if it's not too much displaced, time is not an issue, you can go back and fix it.
One point I would like to add, the same for ACL and the PCL, so we have to be prepared for both repair and reconstruction. So, and we have to look at the quality of the bone which is avulsed. So if it is purely white or it is powdery or it is the quality of the bone is not good, then it is better to do a reconstruction than to repair the part. And one more thing is again, as you said, when we clean the crater, the ACL might not come back to its original position, and then in that case also we might need to do a reconstruction.
So thank you all. We come to the end of this session. So I request our chairperson to distribute felicitate our speakers.
Please come up.
Yeah, I request.
So I request Santosh sir to come on the stage.
Yeah, I'll come.
Dr. Karthikeyan gave a wonderful talk on PCL. A lot of doubts cleared there, and a very nice demonstration. Next, Dr. Shivkumar Mani, MCL injuries, a very clear algorithm presented on how to manage them. Very nice and a practical talk, Dr. Shivkumar. Dr. Leo Bernard, a very nice elucidation of PLC management in acute and chronic scenarios. It was a very wonderful talk, sir. My co-chair, Dr. Jayendra, just a second, sorry. Dr. Ajay Gautam, it was a very wonderful discussion on how to manage ligament injuries after fractures. Very nice and a very clear talk. So Dr. Jayendra is the young dashing guy in Ortho 1 now. I think probably you'll see these two guys in the frame very often from here. So, but yeah, thanks for co-chairing and a wonderful session. Thank you, Santosh sir.
We have come to the end of the lectures. Next is the workshop. So we'll break for tea in between so that tables are arranged for the workshop. So I thank all the faculty, especially Yugal, who's come from Chennai for us. All of us are close by. Yugal is taking the pain to come along. Thanks, Yugal. And rest of the faculties, please break for the tea. We'll do a rearrangement for all the delegates. We'll divide into 4 tables. We'll divide us, and there will be workshops on demonstration for inside-out meniscus and all inside meniscus, hands-on demonstration. So when the tables are ready in 10 minutes, you can come back. You can break for the tea. Tea is served outside.